Have you ever experienced any difficulties because of implant fracture, screw loosening, or dislocation of abutment? The brand new KS system is designed to avoid potential issues for implant placement. With 1 to 2 taper drilling sequence, now it is ready to place implants. The KS comes with a abutment holding system, which is located in the lower part. When the implant is connected to the abutment, it holds these two parts firmly without using a screw. At the moment of loading prosthesis, the KS system prevents dislocation of abutment, which may cause by gingival elasticity. Also, it is more convenient for clinicians because it does not require to see X-ray after loading. For conventional abutments, clinicians are required to select between mini platform and regular platform. However, KS abutment is compatible with all different diameter of implant, so the selection of prosthesis becomes a lot more easier for clinicians. The abutment screw of KS system is designed slimmer, and the space is being used to reinforce the inner wall of the implant body. The KS system is aimed to reinforce abutment by thickening the walls and implant wall as well. In addition, the depth of connection between implant and abutment is increased. As a result, structure of the KS system disperses masticatory pressure effectively. By the reinforced structure, the external force which may affect on the screw stays minimum and eventually minimizes the screw loosening. As of the diameter of 4.0 implant, the KS system secures the degree of strength at 4.5 with the increased depth of connection, reinforced walls of abutment, and thickened implant body. Find your key solution. Introducing the last kit, the lateral approach sinus kit that safely raises the sinus membrane without perforation. The patented drill designs, both dome and core drills, feature rounded cutting edges that minimize direct contact with the membrane. In this way, lateral windows can be created safely. The dome drill in the last kit helps lift the sinus membrane safely while collecting autogenous bone particles between the cutting blades. By creating bone chips between the blades, the core drill's rounded cutting edge reduces the chances of direct contact with the membrane. The last kit's dome and core drills are specifically designed to create the lateral window safely. Last kit allows for more precise control over drill depth. The last kit features drill stoppers in 0.5 mm increments. 6 different lengths of drill stopper allows for more precise control over drill depth when creating a lateral window. All these last kit features contribute to safer sinus lifting surgery and reduce the chances of sinus membrane perforation. Let's go over the advantages of our last kit. It is specifically designed to help surgeons to create lateral windows safely with the patented drill design. 6 different lengths of drill stoppers with 0.5 mm increments allow for more precise control over drill depth. Try the last kit specifically designed for clinicians to perform a sinus lift safely in a short time. Introducing the CAS kit, the crystal approach sinus kit that safely lifts the sinus membrane with a hydraulic lift system. The casket reduces the chance of membrane perforation. The patented cast drill creates a conial bone lid that keeps the drill edge from direct contact with the membrane. Casket ensures safer drilling by preventing sinus membrane perforation. Using the drill stopper makes it easier to adjust the drill depth. The casket features drill stoppers in 1 mm increments. It is possible to control the drilling depth precisely by using the stopper, which ensures safer drilling without the risk of perforating the sinus membrane. The hydraulic lifting technique of the maxillary sinus can facilitate the blood supply of the surgical site. The casket's membrane lifter is using hydraulic pressure to elevate the maxillary sinus membrane higher and wider. Consequently, it facilitates blood supply, which encourages the formation of new bone and the healing process. Try the casket that reduces the risk of membrane perforation to ensure safer surgery. Introducing the asset kit for narrow alveolar ridge split. The asset kit uses expansion drills able to expand the bone buccally and lingually, even in the case of severe alveolar bone resorption. Eliminates the use of a mallet. A safer and easier buccal plate expansion is achievable when minimizing the risk of buccal fracture. During the final stage of implant placement, the implant can secure a strong initial stability in the narrow ridge without tilting. The asset kit allows regular size implants to be placed in narrow ridges with a low risk of buccal fracture. You can try it out. Introducing the 485 kit, the kit for placing short implants. The 485 kit has drills with round design apex, which minimizes damage to the inferior alveolar nerve when performing surgical drilling. The 485 kit allows you to place 4 to 8.5 mm short implants. Only 3 drilling steps are required when placing implants with the 485 kit. When placing short implants, try the 485 kit. MS implant. Introducing the MS implant, the one body type implant for narrow bone width areas such as the mandibular anterior region. There are 3 types of MS implant: narrow ridge, denture, and provisional. First, the narrow ridge is a one body type implant suitable for areas with narrow bone width or narrow interdental spaces. Second, the MS denture is an implant designed for overdentures. Third, the MS provisional is used when immediate placement of the temporary prosthesis is necessary. Try the MS implant in the mandibular anterior region where the bone can be very narrow. Introducing Osstem Implants HiSil Plus. HiSil Light Plus is excellent at reproducing fine areas. HiSil Light Plus can reproduce 20 micrometer lines without any tears or distortion. The stone model poured from a HiSil Plus impression produces smooth surfaces and separates cleanly. Thus, the user can fabricate accurate and precise prosthetics. HiSil Plus is highly hydrophilic. HiSil Plus has a short intraoral setting time of 2 minutes and 30 seconds. HiSil Plus offers a sufficient working time of 3 minutes and 50 seconds. HiSil Plus has a high elastic recovery ratio of 96.5% or more. Experience HiSil Plus for accurate and precise impression taking.
임플란트 유명한 기종일까?
뭐가 달라도 다르겠죠?
임플란트 세계적인 게 좋을까?
뭐가 달라도 다르겠죠.
치과 의사에게 사랑받는 게 좋을까?
뭐가 달라도 다르겠죠.
오스템 임플란트!
7학계 최고의 학술 심포지엄 오스템 미팅 2024 서울. 전 세계 치과인들의 뜨거운 관심 속에 지금부터 모든 강연이 대놀 사이트와 유튜브를 통해 실시간 생중계되며 영어와 중국어로 동시 통역됩니다. 이번 행사는 디지털의 시대 컴플리케이션 줄이고 극복하기를 주제로 7학계에서 폭넓은 경험을 갖춘 5분의 좌장과 함께합니다. 본격적인 강연은 임세웅 병원장의 부작용을 줄이는 수술 방법과 행준영 교수의 치조골 관련 합병증 극복에 대한 내용으로 시작되며 이어서 방주혁 교수 그리고 박정현 원장이 보철적 부족합을 줄이는 방법 TSIII 임플란트 사용법에 대해 다채로운 강연을 펼칩니다. 오스템 미팅의 하이라이트 라이브 서저리는 오전과 오후로 나뉘어 진행되며 김진우 교수가 골다공증 약제를 복용했던 환자에서 원가이드를 이용한 임플란트 식내일, 오스빌더를 이용한 수직적 불진강술을 선보일 예정이며 손영희 원장이 원가이드를 이용한 질식예프와 GBR에 대해 생생한 임상 노하우를 전해드립니다. 마지막으로 주지영 교수, 김준영 교수, 이유송 교수 세 분이 함께 임플란트 주위염의 다양한 증례들을 디지털로 극복하는 방법을 주제로 열띤 토론을 펼치겠습니다. 이와 함께 세미나실에서는 디지털 시대의 교정 치료를 주제로 한 교정 세미나, 개원 입시와 치과 인테리어, 치과 경영과 환자 관리를 주제로 구성된 개원 세미나, 그리고 치과 기공사를 위한 세미나까지 다양한 강연이 진행될 예정입니다. 여기에 직접 현장을 찾아주신 분들을 위한 특별 프로모션과 다채로운 이벤트도 가득 준비되어 있습니다. 디지털 시대를 현명하게 맞이하는 방법 오스템 미팅 2024 서울 지금 시작합니다.
네, 안녕하십니까. 오스템 미팅 2024 서울 저는 오늘 진행을 맡을
Good morning. I am announcer Lee Geun-ha. I'm going to MC today's Osstem meeting 2024 Seoul. I believe you are not familiar with my face through the screen. Through the demo screen, I sometimes introduce the products, and it is my honor to be able to see you in person here. Before we start, we had a very good response for dental staff forum from the staff and clinicians. Thank you very much for the response. Now it's 9:02. Under the theme of navigating the digital age, minimizing and overcoming dental complications, we are going to start Osstem Meeting 2024 Seoul. The meeting is held here, Osstem Implant Head Office Auditorium and third floor seminar rooms. And special programs are prepared. The seminars on ortho, clinic opening, and digital dental lab will start at 2 p.m. Take a note of it. Come to the dental online site, and you can watch the live webcast of all the lectures, live surgeries, and also seminars. Osstem meeting is getting more and more popular over the years among the dentists around the world. Now, people from 10 countries are joining us on and offline. English and Chinese simultaneous interpretation is provided. Special lucky draw gifts will be given out for those who are present in person. After today's program is all completed, the lucky draw will be at the end. We have many gifts such as LG OLED TV, Busen toothbrushing kit, Osstem eye toothpaste. Please stay with us till the end. That is not the end. To mark the Osstem meeting, various events are staged on each floor.
I'm sure you have seen some on the second floor and fourth floor exhibition booths. So we have 3 separate zones, and please refer to different Osstem equipments and look at the orthodontics, GBR, and implant products. We have a new product today. Additionally, we have a Pyorang mascot photo zone and a free profile photo booth available, so feel free to take advantages of these opportunities. On the second floor, you can look at the product exhibition hall and fourth floor exhibition booths. Collect stems from a total of 5 locations and submit them at the reception desk on first floor. Now, I would like to introduce different events. Among those who log in and watch the event online via dental website, 900 participants will receive coffee and dessert set coupons. So you can participate through a prize draw pop-up that will appear on the dental website for about 3 minutes, so don't miss out. The results will be announced after the session, and the coffee coupons will be sent via the text message simultaneously. Moreover, for those who watch the event online till the end, we have prepared generous prizes including Dyson V12 vacuum cleaner, Wattpick oral irrigator set, and Portal set. We encourage you to stay tuned till the end. Please note that to participate in the prize draw, you must log into the dental website. Please remember that. Don't forget to register in advance to ensure smooth participation. Also, if you're watching on a mobile device and want to participate in the pop-up event, make sure your phone is in portrait mode. We have also gifts for those who participate in the lectures. During the Q&A session after the lectures, we'll select 10 people with the best questions from both online chat and on-site questions and give Wattpick portable oral irrigator. We encourage all participants, both on and offline, to actively participate. So I feel quite nervous because today is very important. Lastly, from 4:30 p.m. to 5:30 p.m., there will be a discussion session. Before the session begins, please take a moment to participate in a short survey related to complications using the QR code displayed on the screen or the banner at the entrance during the break. For online viewers, a survey link will be sent via text message. The results of the survey will be reflected in the discussion, so the more participants we have, the more fruitful the discussion will be. Now let's officially begin Osstem Meeting 2024 Seoul. We have a keynote speech from Vice President Kang Chung-gyu of Korea Dental Association. Please welcome him with warm round of applause. Greetings, I am Kang Chung-gyu, Vice President of the Korea Dental Association. I sincerely congratulate the successful organization of Osstem Meeting 2024 Seoul, a prestigious event. So, I am wholeheartedly give my congratulations. And since its inception in 2004, the Osstem Meeting has been held successfully for 20 years, becoming a globally recognized dental academic event that represents Korea's leading dental company, Osstem Implant. The meeting has garnered international attention and acclaim. This year's theme, Navigating the Digital Age, Minimizing and Overcoming Dental Complications, will feature various educational sessions, including live surgeries, periodontal seminars, and orthodontic seminars. These sessions promise to be both informative and innovative. I'm confident that all participants will gain valuable insights into the future trends and advancements in digital field. In particular, I hope that Osstem Implant will continue to play a leading role in the global stage by achieving the top position in world dental industry through international academic events like the Osstem Meeting. To our esteemed colleagues from both Korea and abroad, next year marks the 100th anniversary of the founding of the Korea Dental Association, a milestone that is deeply significant to us all. The 100th anniversary celebration will be held from April 11th to 13th, 2025 at Songdo Convention in Incheon. In addition to academic conferences and dental exhibitions, the event will feature various cultural and social activities, including art, music, and photography exhibitions, providing an opportunity for communication and celebration. I would like to extend my warm invitation to all dental professionals and colleagues from around the world to join us in this grand celebration. I would like to express my deep gratitude to Chairman Choi Kyu-ok, Osstem Implant CEO, and CEO Kim Hae-sung and all the employees for their dedicated efforts in making the Osstem Meeting 2024 Seoul a great success. I sincerely wish Osstem Implant continued growth and leadership in advancing Korea dental industry. Thank you.
네, 다시 한번 성공적인 행사를 위한 축하의 말씀 전해주시기
Thank you once again, Vice President Kang.
바랍니다.
Please give him a warm round of applause.
오스템 임플란트 본사
Osstem Meeting Seoul is currently being streamed live online from the main auditorium at Osstem Implant headquarters. We're excited to announce the first viewing event for our online audience. Please check the pop-up window on the dental website and enter the draw. The results of the draw will be announced at the end of the session, and coffee coupons will be sent via text message simultaneously with the announcement. One important thing to remember: the longer you watch, the higher your chances of winning not just coffee coupons but also dessert coupons and even more generous prizes. So please stay with us and get more grand prizes.
네, 그럼 현재 시간 9시 11분 해외로도
So this is 9/11. This is being streamed abroad as well. Now we will begin the first session.
시작해 보도록 하겠습니다. 오늘 첫 번째 세션을 열어주실 좌장은 위치과의
Let us start the first session chaired by Dr. Chang. Dr. Chang Dong-wook did the internship and residency at the Periodontal Department of Keele University, currently Vice President of Korea Academy of Oral and Maxillofacial Implantology and works at the Win Dental Office. Please welcome Dr. Dong-wook Chang. Good morning, everyone. Osstem Meeting 2024 Seoul. My name is Dong-wook Chang. I am the chair of the first session. Thank you very much for inviting me. Then, with many dentists from around the world, it is my honor to share this wonderful lecture. So let me introduce the first speaker. The theme is the minimal complications with a modified surgical approach. Dr. Se-Ung Im, please welcome him with a big round of applause. Good morning. I'm the first speaker. I'm from the Wise Dental Clinic, and I am Dr. Im. This is the topic of my lecture. This is a little bit different from the conventional approach. This is the surgical approach to minimize the complications. So in the sinus, 2 millimeter of residual bone is there, and there is a vertical deficiency, which is a challenging case for surgery. In that case, do we need to do the bone graft first, or simultaneous approach, or lateral or crestal approach? And which graft material or membrane should be used for vertical augmentation? About 20 years ago, I performed this surgery. There was a severe vertical deficiency and very little residual bone. So lateral sinus graft was done. In that case, coronally advanced flap would be used on the buccal side. Keratinized tissue would be reduced, so soft tissue graft should be added too. So they can be successful, but in order to get that successful result, it took about 1 year, 3 times of surgery. So in terms of patient satisfaction, that is not very high. So I survey patients in terms of pain or swelling after surgery. And after surgery, The patients have a swelling and pain and a bruise. I believe these are complications as well. Today, I'm going to talk about this. When the form is collapsed, non-resorbable membrane used to be used, but without using it, how can we make the form that's SM bone would be used? When residual bone is less than 4 millimeters, crystal approach can be successful. So I'm going to talk about using gel bone injection. And then there are many advantages. So using one casket, what kind of advantages can we get to get the primary stability? Vertical augmentation is challenging, but there are advantages when we use a one-stage approach. I will talk about two cases. A severe vertical bone resorption in the mandible, and the staged approach with the bone graft, and modified surgical approach for sinus augmentation, and simultaneous approach, which is one-stage approach. First, in the mandible, there is a severe vertical deficiency. In the quadrant 4, bone loss is severe, and there is a very small distance to the nerve, and two wall-wide defect is observed. So even though we wait after extraction, we cannot expect bone filling the space, so bone graft would be required. So basically, when I wait for the soft tissue healing for about a month, and what kind of a bone graft material do we need to use? But before that, let me talk about the bone grafting. The purpose of bone grafting: do we need to make bone or do we need to make space? So these two are different. Making bone is when the condition do not facilitate the bone growing. So two-stage approach, BM, bone maintaining. So this is used to address the problems after implant is placed, the BM, bone maintaining. When threads are exposed or in the anterior region, a long-term bone resorption has occurred, and to make a certain form, we do grafting. So usually simultaneous approach is used. The purpose of doing that is not to generate bone, but graft should be made to keep the form. And in that respect, xenograft is used quite a lot. Next, when bone regeneration is required, and when implant cannot be placed due to lack of residual bone, bone graft should be made first. So staged approach can be used. The purpose is to generate bone for implant placement later, to achieve a primary stability later. So the graft material used here can be allograft. So allograft was grafted, and the second problem, the vertical form collapsed. How can we recover that? In the past, we used to use block bone. We still use them. Or in the past, I used the particulate bone with a titanium mesh so that the form could be made. Non-resorbable membrane have some difficulties clinically. In order to fix them, screws or pins need to be used, which requires some time to use it. And the surgical cost would be increased. And sometimes they are exposed. So, without using non-resorbable membrane, how can we make the form? And then it would be easier clinically. What I chose is the gel bone is mixed. I call it SM bone, space-maintaining bone. The graft itself can make the form. Then we don't need to use non-resorbable membrane. Demineralized bone matrix can be used to create some form, and this is favorable for bone generation. Gel bone and particulate bone is mixed with the cell line, and they can support the form very well. Without using non-resorbable membrane, the collagen membrane would be good enough to prevent the collapsing of the form by external force. We used to use non-resorbable membrane, but the graft material itself can support the form. Then we don't have to use the non-resorbable membrane. So grafting was done. There was hardly any remaining bone, and success factor is the ossification of the graft. And I waited for 6 months after GBR, and 30 Newton centimeter of primary stability was obtained. The threads are not exposed, but additionally, a xenograft is added. Allograft is advantageous for bone regeneration, but that can be resorbed. Therefore, to support the form and to make the bone from being resorbed, xenograft is added to keep the form. 1 year follow-up. For the last 10 years, it has been followed up. The buccally regenerated bone is maintained, not being resorbed. In the past, we used to do vertical augmentation. When a form can collapse, in order to overcome the problem, we use these 4 approaches. Pin is used, or titanium mesh is used, and the screw is used to fix it. And OssBuilder is a little bit better. And sausage technique is also used by Dr. Urban. And the grafting, abundant grafting is put in, and the sausage technique can contain high volume. But clinically, it is a little bit challenging. How can you make it easier? How to make the space better? So that is why we need SM bone. If the graft can maintain the form without using challenging techniques, we can create the form. And AOS collagen is very helpful for creating the form. SM bone is made like this, as I said before. It can be mixed with a gel bone. But the first one, PRP, is what I prefer. PRP is clinically very good for healing, but it itself can support the form, so that is the advantage. So the form is collapsed, and without non-resorbable membrane, the form would be disappearing, but using this, the form can be maintained using PRP. When simultaneous approach is difficult, this can be used. So the allograft is mixed with a cell line, and it becomes like a clay, and this is helpful to maintain the form. And the grafting is done. What I expect from this are 2 things: maintenance of the form and bone regeneration. And in the past, I used to use mesh, but this can support the form as well. Therefore, after grafting, I just use a collagen membrane, resorbable membrane is not used. EOS collagen has been launched recently. This is the case. The mandible, the forms tend to go away. So on the buccal side, EOS collagen is added. Scan healings were connected, and the buccally collapsed form is maintained. Recently, rather than general anesthesia, the digital approach can be used. Implants were extracted, and immediately implants were placed. To release the mount, this e-driver was developed. This is very useful when we do surgery. Scan healing is connected. EOS collagen is easy to use. You just add water. Even with this undercell line, the form still is maintained. That's why we use the EOS without the help of non-resorbable membrane. Collagen membrane can be covered like this. So using cell line, there's no problem. So without the help of non-resorbable membrane, the graft form can be maintained. I briefly talked about the e-driver, which is quite helpful clinically. And how do we use the e-driver during surgery? When we place many implants, removing mount is quite cumbersome. I made a mistake during the effort. The healing driver can fall off, and if a patient swallows it, that's a problem. But when releasing the mount, this can be helpful to release it in the counterclockwise direction. And the 10 to the 50 torque can be adjusted, and the 10 torque is helpful to connect the screw in. Under improper torque, something can be swallowed by the patient, but that chance is reduced using this. PRP is used to maintain the form, and there has been a literature paper published by Yonsei University. Collagen membrane is used versus the PRP only, and if you look at the result, there's not much difference between PRP and conventional approach. But the PRP itself is helpful for maintaining the form. And one body implants failed, so the situation is quite serious. I waited for about 2 months, and TSIII 3.5 implants were placed, and the exposed parts was covered by SM bone, and OssBuilder was used for number 32. Was there any difference between these two sites? PRF covered the site after the surgery. This was the case. The final was completed 3 months later. OssBuilder has some space maintenance advantage, but SM bone still maintain the form, and not much difference. So let me compare the results. The non-resorbable membrane using pin and my preferred approach. Now we cannot overlook economic situation. Non-resorbable membrane. The membrane itself is more expensive, and screws and pins need to be used. So economically, it's not very good. OssBuilder just needs the builder. not requiring screws, so economically it's better. SM bone, clinically it's more advantageous because of the low cost. And gel bone is very expensive, so I cannot recommend it readily. And clinically, non-resorbable membrane is hard to handle. It should be fixed and removed later, and then they can result in very negative results. But as collagen, it should be watered and then applied. Very simple. And the gel bone PRP requires some procedure. So I prefer simultaneous approach. The non-resorbable membrane should be submerged first, and the second surgery is required. Compared to that, SM bone and also collagen can be used in one-stage or two-stage approaches. Titanium mesh OssBuilder is the most excellent in terms of space maintenance. And then the centrifuge is required for PRP. And when we use the PRP, PRF can be obtained as well. That's the advantage of using PRP. The second theme, maxillary sinus augmentation with the vertical bone resorption. When residual bone is less than 4 millimeters, so what do we need to do? 2 millimeters is the height of the residual bone, and do we need to do staged approach or simultaneous approach, lateral or crestal for the situation? So conventionally, if you use a staged and lateral approach, it will have a long surgical time, and the vertical incision, releasing incision is required, increasing pain and swelling on the part of patient. Chronally advanced approach is used, so swelling and pain can result in, and that there is a risk of exposure, and it will take more than 1 year. Vertical augmentation, you need to pull the flap quite a lot, so vertical and releasing incision is accompanied with the pain on the part of the patient. So pain and swelling occurs, and the membrane can be exposed. How can we approach it more easily? Crestal approach, can it be used, or can we use simultaneous approach, just one-time surgery? That is something I want to talk about now. 3 things I will talk about. Crestal approach with the wide elevation of the sinus membrane rather than lateral approach. And then when the residual bone is less than 4 millimeters, can we use a simultaneous approach without submerging? First, the sinus elevation. Can we use a crestal approach? In general, in the textbook, 4 millimeter is the criteria. If it is less than 4 millimeters, lateral approach is recommended. But the millimeter is not important, though, 3, 2, or even 1 millimeter. When implant can achieve a primary stability, yes, I don't think crestal approach can be used. 5, 6, 7, or 8 millimeter of lift can be achieved. But if primary stability cannot be obtained, the staged approach should be used with the lateral approach. In the past, I thought the crestal approach has some limitations. The wide sinus elevation cannot be achieved with the crestal approach, so ossification would not be done properly. So I thought the lateral approach should be used for 4 millimeter or lower. But there are many techniques introduced to lift the membrane. So lateral and crestal, the boundary has blurred. So recently, my favorite is crestal approach, and gel-type injection is used. A wide elevation of sinus membrane, hydraulic approach, and a gel bone approach. Gel bone is to lift the membrane. There going to be resolved, so additional grafting is required. 2 millimeters of residual bone, a gel bone is injected, and a wide elevation of membrane can be achieved. There's no limitation in terms of the millimeter of lift. So a simultaneous approach was used, so it is stable long time. The gel bone can elevate the membrane widely, so it's a helpful bone supply also for graft regeneration. So what is the criteria, millimeters between lateral and crestal? The boundary is blurred. Particulate bone plus gel bone. On CT, it's different. The particulate bone cannot lift the membrane widely, but when gel bone is used and additionally, a particulate bone is used on the right-hand side. What is important is that how to get primary stability when a bone is less than 4 millimeters. We don't place implant first, and lateral approach is used to do the lifting. What is important? We need to drill accurately. If the site becomes wide, the fixation cannot be achieved. I do final drill up to 3.8 millimeters, and I used to use TS implants, but recently SS is my favorite, and it can have more stability. TS in generally, so then it should be placed 3 to 4 millimeters like this, the depth. But when residual bone is 1 to 3 millimeters, TS or KS cannot have very good control. So if it goes on 1 to 2 millimeters down, then it will go into sinus. So SS is better, 1.63. In terms of customer satisfaction and to reduce surgical time, simultaneous approach is used. The cascade is used to develop the site. Gel bone is injected. Gel bone injection is good enough to lift the membrane. So additionally, particulate bone is grafted. The residual bone is less than 2 millimeters. TS implants are not good to get stability. White neck SS3 6.0 implant is used to get enough stability, and you may need some experience, but 20 Newton or more stability was obtained. So simultaneous approach, which is the method to reduce complications and preferred by the patients. Next case, 3 millimeters of residual bone. The residual bone, the height is important, and bone quality should be predicted. Number 26. The HU value is 600, not bad, but 27 is a soft bone. 3 millimeter of soft bone. Can we overcome the challenge? I prepared 2 things, gel bone and AOS collagen and a guide, prefabricated. Gel bone is injected first, and AOS collagen is added. AOS collagen is to this is SM bone, so it facilitates grafting. Gel bone injection was injected and CT was taken. And this is like the result of lateral approach. You can lift it 10 millimeters. And 30 Newton centimeter of stability was achieved. ISQ was very good. Residual bone is not much, but if necessary, SS bone SS implants can be placed, and the very good stability can be achieved. Using a guide, flapless surgery is performed. Usually in the posterior region, up to 3.8 extension is used. To develop the site, if the bone quality is not very good, so it is soft bone, and if you do not do accurate drilling, it will not work. And using the gel bone, the membrane is lifted, and a particular bone is added. Without a particular bone, the site cannot be maintained. So I use the particulate bone. At number 26, a TS was used. At 27, SS was placed. SS may be difficult to place using a guide, but without a guide, so after removing the guide, you can place SS implant. 3 millimeters of soft bone height, but I achieved a very good stability. So accurate site development is important. And depth control can be measured using a flapless approach. And you need to use some device to measure the depth. And after about a month, it was scanned, and we went to the next stage. So let's go back to the case. So with the same approach, incision was made. The implant was placed with gel bone and 1 millimeter of residual bone, but the stability was quite good. Now, what we need to do, the vertical augmentation. The key to surgery is that we don't want to submerge it by obtaining stability of 20 Newton centimeters. If it is submerged, the issues will occur. After connecting the healing abutment, if it is submerged in the conventional way, the pain and swelling will occur. So if stability is more than 20 Newton centimeters, the vertical augmentation is not that difficult. So SM bone is used for vertical augmentation, and no vertical incision was made. Just a little bit of releasing, the pain would not occur. So coronally advancing amount is not very much. So even with the vertical augmentation, swelling is not much, and then FGG would not be necessary. The key is to get the stability, getting good stability. Then we would be able to complete the augmentation very well. 6 months later, the final was set. 6 years follow-up, the form is very well maintained, as you can see. So summary. So when a vertical augmentation is necessary, in the past we used to use a non-resorbable membrane, but if space maintaining material is used, like SM bone or EOS collagen, it will work if the residual bone is less than 3 millimeters. Lateral approach is a good approach, but the crestal approach using gel bone can work as well. When residual bone is less than 4 millimeters, I still use a simultaneous approach. The important thing here is to develop the site very accurately. Then we can obtain 20 Newton centimeters of stability. So with a simultaneous approach, many complications can be reduced. That's all. Thank you. Dr. Im gave us very good lecture. Please give him a big round of applause. So Q&A will be entertained after the second speaker. Let's go to the second speaker.
The second lecture will be presented by Professor Paeng from Samsung Medical Center in Seoul. He'll be discussing the topic overcoming complication or failure of alveolar bone reconstruction. Please join me in welcoming Professor Paeng. Greetings, I am Professor Paeng from Samsung Medical Center. Today I want to talk about alveolar bone reconstruction. Dr. Im has introduced the various procedures and products. After GBR, or in the case where GBR seems unnecessary, unlikely, I want to talk about this topic. It's best if we don't come across these cases, but as we do GBR or implant treatment, bone graft is necessary. At times we come across a failure and bone quality may not be as expected. Unwanted outcomes may result. In those cases, how can we overcome such challenges and how can we avoid them? My topic will be addressed by various lecturers today. A lot of people is going to talk about GBR, and I want to talk about a topic that is not easily, that does not really come off. Don't think of it as too difficult, but I hope you get different tips. I work at Samsung Medical Center, and I don't do prosthodontics. I am maxillofacial surgeon, and I just do surgery. My topic can be divided into three: failure of GBR or bone augmentation. How can we respond to it? And as a way to overcome such challenges, we can utilize interpositional bone graft. Another option is, these days more so than thought, in the past implant cases were not that frequent, but now we come across various bone defects. In the past, we would have given up, but we need to explore more options for such patients. As Dr. Lim has talked about vertical aspect, and what is most important is a fixation bone graft. One of the conditions to become bone is a fixation. Also, there's a soft tissue fixation. How can we make this easier? There are many products. And vertical GBR, what makes it so difficult is not just to building bone, but to fixate it and to maintain it. And soft tissue is one of the biggest contributing factors. A soft tissue, if it is movable, how can we prevent that? We need to fixate hard and soft tissue and release tension. In terms of hard tissue, vertical GBR is more difficult because the bone contact area is limited. When we do lateral augmentation, more so than thought, there's a lot of contact, but if you do vertical augmentation, the space is limited. No matter how you fixate it and add more bone, the new bone formation comes from the patient's bone. And we do not have 10 millimeters of bone, even if we augment it 10 millimeters. So basically, from autogenous bone, from the patient's bone, I think the amount of new bone formation is 4 millimeters max. The amount of maximum new bone formation is 4 millimeters, and it extend beyond that. No matter how you utilize a particulate bone graft, it becomes difficult to do vertical bone formation. Graft material, we use particulate materials. In the past, we used to have more options such as block bone graft, and now people use a lot of collagenated products. Most people use particulated bone graft. In terms of space maintaining, this was addressed. And at maxillofacial surgeons use titanium mesh or titanium reinforced membrane, as well as tent pole. These are not really being lectured these days because the efficacy may be limited and has many downfalls. We talked about using collagen at maxillofacial department. We use a fibrin glue, PRF. It has a lot of obstacles, and a maxillofacial surgeon looking at it, I think it involves a lot of steps. Fibrin glue is something more easy, but I want to talk about fibrin glue later. Vertical augmentation has been reduced because short implants show good success rate, and I only do vertical augmentation only when it is absolutely necessary, and in the case of anterior zone or if there is excessive resorption, I just use anterior zone. Short implants. 8 millimeters is not a short implant. 7.5 or short implants can be used instead of doing vertical augmentation. Even if you do success in vertical augmentation regarding bone quality, it's not on par with a patient's bone quality. Releasing incision was addressed earlier, and in order to do vertical augmentation, everybody has to do releasing incision. And this, if you're not familiar with the incision, then you need to avoid augmentation. Releasing incision, if you do it, there's going to be bleeding, pain, or swelling, and suppuration will not be good, and mucosa will be pulled up, and gingiva can be reduced. There can be a lot of surgical complication, but this is absolutely necessary. We need to avoid the potential problems, but in order to do GBR or vertical augmentation, you need to learn how to do releasing incision. So, vertical releasing incision, basically, you need to check periosteum. You can see smooth periosteum. You need to look at it accurately and do releasing incision properly. What is most difficult to some is the premolar area. People are worried about hitting the nerve. I am cautious as well. In the area with a nerve, it can be quite difficult when it is close to the nerve, and we need to be cautious of it. If you do not look at metal foramen and do incision, there can be nerve damage, so we need to avoid it. As you can see, there is nerve going down. If you scrape it with a blade, this is not something that should be done. Blunt dissection, you need to learn how to do this. Periosteum incision is done, and around that, you can see the nerve very well, and you can see the curve of the nerve. You need to accurately see that and utilize different tools such as periosteal elevator to do blunt dissection and look at the nerve. Some may think this is difficult, but if you think that's difficult, you will not be able to do it. If you do bleeding control properly, and if once you become more used to the surgical procedure, you need to push slowly ahead. There are cases where GBR is difficult. GBR is not a all-for-one solution. If it can solve every problem, you will not be having this seminar. And a lot of people come across GBR failure. If you do repeated GBR in failed cases, more so than thought. Although it cannot be nicely maintained, many people make attempts and leading to more problems. Re-GBR. Why is it difficult? Because if there is failure, as shown here, there is inflamed tissue and fibrotic scars. With repetition, then vascularization will go down, and if you do suture, it's going to fail again. After failure, in order to recover quickly within 3 or 4 weeks, if you do suture, then if the problem is going to erupt once again, re-GBR should not be attempted to the extreme. As shown, there is very little keratinized gingiva and there's only mobile gingiva. This can lead to failure as well. Another point is when there is a root surface exposure, if you try to do a GBR in the root surface, it's difficult for the environment for new bone formation. So we need to avoid those situations. Alveolar bone part may be significantly resorbed. In that case, GBR can become difficult. FYI, I want to talk about interpositional bone graft. So GBR, we put bone graft materials on top, and then we prevent the soft tissue from invading that space. However, in order to avoid such soft tissue problem, you put bone graft material between. In my case, when you fail in GBR, and if there's a need for vertical augmentation, I use an interpositional graft. That in most cases, at the bone where we do bone graft, there's no vascularization. So the chips is a non-vascularized bone. Instead, interpositional bone graft with the soft tissue on, with vascularization on, we do graft, so it has more resistance against resorption, GBR. We do crestal bone augmentation. The implant top is where the grafted bone is, so it has vulnerabilities related to that. The augmented bone is the patient's bone, and the grafted area, there are many advantages. As you can see, vascularized bone, the bone that's on top is covered with soft tissue, so this is a live bone. And with the soft tissue attachment, we push it up. When we do periosteal incision, we can extend it by over 1 centimeter, and as you can see, the soft tissue is quite flexible. The quality of the bone, we need to think about that vertical augmentation, and if we make alveolar bone with GBR, we may think that the new bone formation is nicely done. In most cases, there's particulated bone graft materials, and in long term, there can be problems. The crestal bone goes up like this, so because the patient's bone is there, the bone quality is good. This is four-wall defect. The success of grafted area is very important. The contact surface with the patient's bone is very important. If you do augmentation on top of a very thin bone, then there's limitations in how much we can get. And we need to do, if there's 4-wall available, then we get better results. So you can see in the posterior area, bone graft was done multiple times and failure occurred twice. And there was limited bone for short implants. A graft was necessary. But because there was 2 times of failure and soft tissue was quite lacking, therefore interpositional bone graft was decided. Labial side, there was incision, and I wanted to prevent detachment of soft tissue. And in the case of this patient in the past, the crown implant ratio was important, but because with the availability of short implants, the importance went down, and there's shallow vestibule, and there was movable gingiva, so GBR was considered quite difficult. You can see previous bone graft materials. And if you look at the field cases, these graft materials, new bone formation is very difficult to become into new bone. If you add a xenograft, there is a limitation in potential of new bone formation. When you do re-GBR, these can be very unfavorable conditions. So osteotomy line, 3-4 millimeters away from the crest, osteotomy is done, and in the early days, in order to prevent collapse of block bone, graft was done. Looking back, as of late, perhaps I could have used different types of synthetic bone. Graft was done, and then implants were placed. So I normally waited 3-4 months, and with a revascularization of bone, you place the implants. When you look at implant placement on the crestal area, there is a bit of bleeding. So you can see that the bone is vital. Lower vestibule is very problematic. Vestibuloplasty, apically positioned graft, or different grafts are tested, and there is different options available apart from vital mucosa. I don't utilize mucosa. I do just to get good results with vestibuloplasty. Implant was placed as shown. In the case of upper anterior, if you look at this patient on the right side, the crest is very thin, and the patient underwent trauma, so the soft tissue was scar tissue. This kind of patient, compared with the patients who lost teeth because of periodontal lesion, GBR can be more difficult. Dehiscence or soft tissue problems can result with this kind of patients. So interpositional bone graft was done. After interpositional bone graft, CAD/CAM guide is much more advantageous because, more so than thought, the bone quality or the amount, shape, can be different than in normal cases. A digital dentistry can be very useful. This is lower anterior case. The patient went through car accident, and there is a very limited space. You can utilize short implants, but if the base is quite thick, and you do interpositional bone graft, there can be many advantages. And rather than GBR, interpositional bone graft is better. So in this case, 10 millimeter, 11 millimeter augmentation was done. A bios was used in between. Resorption and other factors were considered. Overcorrection was done after 4 months. You can see that the bone quality is stabilized and implants were placed. So in the case of the past, I would have used long implants, but considering bone healing, implants need to be chosen appropriately. So this is a posterior case, and in this case, GBR was failed, and it's not the matter of failure, but after failure, the bone becomes even more resorbed. So what kind of problems could occur after failure need to be considered. before we do GBR or bone graft. Vestibular incision was made. Bone cutting was done. About 10 millimeter of augmentation was done. After augmentation, particulate bone was utilized. About 5 months later, this is the upper right. You can see there's a patient's bone and there's a grafted bone in between. The grafted bone quality is not that important because the quality can be ensured when you place the implant. If you can maintain the crestal aspect, you can get very good results. This is before surgery and this is after. After surgery, when you place multiple implants, you need to consider the direction. In the grafted area, we need to consider the antagonist. So you need to utilize the guide in order to do accurate surgery. This is a different company's product, but the Osstem guide it's very similar to Osstem guide. After implant was placed, prosthesis was delivered. Perhaps you can get better results with other options, but if you take a look, considering the crown length, I think this result was quite satisfactory. This is a different option I wanted to talk about. So the cases where we used to give up, regardless of the graft material, you come across patients that's difficult to treat. In such cases involve the soft tissue. So many people talk about iliac bone, but that's a free bone. So when you do graft, the soft tissue needs to cover that area for the bone graft to succeed. Vascularized bone graft is utilized. A fibular bone graft, in the case of defects in upper and lower, this is utilized very frequently, and this is almost considered a standard procedure if there's no jawbone. Fibular bone is utilized and grafted, but there's limits to it. So it's difficult. There are many ways to do it, but there are still limitations. In the past, the graft itself was satisfactory, but now patients want implants on it. When you place implants on it, when you do grafts, the bone is important, and in between, there's a vessel going through, and we need to consider where the skin goes. We need to think about when implants are going to go in. Before taking leg CT, 2 millimeter balls are added. So we listen the Doppler and add the balls where there's and we can take a look at this, and you can look at the vessels with CT. The patient is from UAE in her 20s. When she was young, mucocyst, there was a maxillary defect. Because the patient is young, it's difficult for the patient to use denture for lifetime. So the patient refused to use denture and wanted jaw regenerated. Iliac bone graft, whatever the option, free bone would not be able to solve this problem because there's no soft tissue. So you can see there's very little maxilla. We need to think of implant placement onward. You align the implants, and then in line with that, fibular bone graft needs to be done because there's no soft tissue. Soft tissue palate needs to be covered, hence skin paddle is utilized. There's the implant and there's the connected area, and in line with the basal bone, we choose the vertical area. The red reflects the vessel, and if there's vessel, we cannot place the implant, so we need to digitally plan this ahead. How is this going to be cut? We need to consider the cutting guide as well. And then graft needs to be done, and we need to connect it with a vessel in the neck. This is how the graft was done, and you can see that because there's a fur in the leg, the dermatologist said they never removed the fur in the mouth. But this means that vitality is excellent. You can see that alveolar bone is nicely positioned. So there's soft tissue here. So we need to consider these as we position and plan ahead. And the vertical position is very similar. And when you place implants here, if you just place implants, there can be many problems. Osstem guide was utilized to get the position, and guide was made. You can see there was a lot of pet because thin mucosa was made after surgery was done. This is after prosthesis was delivered. You can see that the fur is all gone, and you can still see skin. So the patient's look, you don't see the neck scar. There's about 4 centimeters of neck scar, but the sunken look can be compensated. If you look at this patient, the patient had no maxilla. Because of mysofibrosarcoma, maxilla was removed completely by ENT. So there's no maxilla. But the skin here is like this. You cannot use a denture. The patient was not able to utilize lower, and the patient wanted any kind of option to solve this problem. The patient had no maxilla. So CT of the patient's previous dentition was there. So based on the occlusion, a fibular bone was cut and adjusted to make maxilla for the patient. If you look at the lateral view, you can consider the implant position, and this is aligned. You can utilize digital dentistry here for simulation. After that, in the maxilla, graft was done. Once you do that, such fixation is utilized. After several months, bone healing, once this is complete, implants are placed. This is implant simulation, and after that, panorama was taken. Fibular bone can be quite thick, or this could be thinner, but in the case of this patient, because it was male, there was thick bone. This is at the time of implant placement. In some cases, after bone augmentation, there's lack of vestibule. Vestibuloplasty is done to make a vestibule. After that, prosthesis was delivered. In the case of these patients, this is the only solution available currently. More so than thought, the success rate and such. The basic principle is similar to GBR, and if you use digital dentistry, you can get good results. This is post-op, but this is before surgery. And right before the patient's nose, it was not supported as well, but you can see good support. So such cases are becoming more frequent. Maxillary necrosis, MRONJ or MRONJ, there is a lot of necrosis. More so than thought. I come across these patients. Re-GBR can be more difficult. You might be tempted to try to solve it as quick as possible, but soft tissue and hard tissue conditions worsen. Therefore, I know you get quite antsy, but we need to take a step back. Soft tissue is very important in bone augmentation, and considering bone, we can consider short implants first in the posterior area. Interpositional bone graft is one of the reliable choice for severe alveolar bone defects or insides with previous failures. If there is no jawbone, fibular free flap can be a clinically acceptable option. And you can utilize digitally assisted systems for implant places. I use Osstem only for fibular free flap implant placement because the system is well established. I think that is very important. Thank you for your attention.
Dr. Paeng, thank you very much. Dr. Im and Dr. Paeng, I would like to invite them on the stage. And with the two doctors on the stage, we will have Q&A. First, the questions from the floor. Those who are on the floor, do you have any questions? Please raise your hand. Dr. Im, thank you for the lecture. My question, crystal approach was used. Any membrane perforation, how to check the membrane perforation? First, I use the casket. When I do drilling, I don't penetrate. Osstem is used to do fracturing. After that, we have used the approach quite a lot. You get the feeling when it is fractured. So I use the Osstem to do fracturing. And if the bone is 4 millimeters or lower, the perforation would be visible. So usually, I do fracturing using Osstem, and I check visually in terms of the perforation. Any questions? So we need to share the question with everyone. So if you want to ask a question, please identify yourself first. My name is Dr. Kim Hyun-jae from Icheon Sungmo Hospital for bone grafting. And then the adjacent tooth can be infected, and that will lead to bone resorption. And interpositional approach, what is the margin? And when you do bone grafting, and you need to check crestal bone resorption. So how do you check that? And when you do augmentation, in order to release the tension, you do dissection a little bit more. And so does that lead to more resorption?
Thank you for the good question. So augmentation, and if you try to do accurately, I think difficult cases involve root exposure when you do GBR in that area. there's a new bone formation attached to the tooth. Perhaps, fortunately, if you do interpositional bone graft, the augmented bone does not come in contact with exposed tooth, so it does not become attached. But because of that, if there's soft tissue, it doesn't lead to resorption. If you can do bone augmentation that can cover adjacent tooth, that's good, but that's very difficult and it's not easy to overcome that technically. And when I place implant, I always add particulate bone. So the anticipation is that the bone formation will not be properly formed. The second question is about resorption when you do GBR or other options. So we do periosteal incision does not necessarily lead to more resorption as mentioned. How mobile is the bone in the first healing phase? Bone formation goes up like a ladder. Bone graft material needs to go through the ladder. If the ladder moves, the bone graft material will not be able to become a bone. If it becomes immobile, then bone formation will not occur. As Dr. Lim has mentioned, what is most important is for the bone graft material to be immobile. It needs to be fixed. Releasing incision or just because you do more dissection, it does not lead to more resorption. The second question, if you do more releasing, I think with more pressure, this leads to more resorption. Regarding pressure, if you do releasing, we need to prevent the pressure. We need to think of mobility. The periosteal incision, this is for more graft, and there's leads to more soft tissue mobility. And the fixation of graft material needs to be paid more attention. I'm sure this answers your question. We'll entertain more questions. Thank you for the wonderful lecture. So, Dr. Lim, I have a question.
Additional question to Dr. Im. Osstem is not used because the sinus floor, the cortical bone there, it can be fractured. That lead to the loss of implant stability and tearing. Cutting can occur. So it is very important to clear cut the cortical bone. So casket was developed for that. But today, Osstem is used to heat it. Would you explain it a little bit further? Thank you for the good question. I use a casket to fracture the remaining bone. I increased RPM during drilling. During drilling, when a fracture occurs, you don't really feel it. And when you lower the RPM like to 50 and to feel the pushing up, I tried that, but I prefer to use Osstem for a long time in terms of the procedure. I wanted to feel the fracture point. As you cited, after site preparation, if it is not accurately done, the Osstem wouldn't work at once, which will lead to trauma. But individually, I prefer to use Osstem to do the fracture just at once, but it is not recommended for everyone. So that's a very good question. Any other question from the floor? If not, We have questions from the online participants. To Dr. Im, we have many questions. First, what kind of gel bone do you use for the sinus? In the past, I use quite a lot the Surefuse from Osstem, but now I use XLOS, a beta TCP gel type bone. That's alloplast, right? Yes. The second, what is SM bone? I heard it all of a sudden, so maybe you need to go back to your explanation. And in the case, in quadrant 2, there was a prosthesis, and you delivered the prosthesis in 1 month? No. In order to reduce the patient visits, I do recall checkup at 1 month. If no problem, I do scanning. And it is not easy. Actually, when a scan healing is used, you can do that at 1 month. And after 4 or 5 months, I do the setting. And I talk to prosthodontists, and if the time gets longer, there can be issue. And if the distances, if those who come from far away, I do the scanning again. So prosthesis is set in about 2 to 4 months. And Sandonan asked a question. Gel bone is used for sinus lift. If membrane ruptures, what happens? And I have a lot of experience of this, so I didn't talk about this. So when gel bone is injected, the most important thing is the controlling of pressure. If the pressure is too high, the highly viscous material, so if pressure is too high, the membrane can be ruptured. So I pull it back and push it in to reduce the pressure. And if membrane is ruptured, you need to use the lateral approach to do the repairing. And the rest, helicopter 2 asked the question, when xenograft is applied, on the surface of an implant, osseointegration would not be achieved. What do you think? Gel bone is just to lift the membrane. Xenograft is grafted additionally on top of that, so that that will be integrated. And to Dr. Paeng,
I think the questions are similar. So I used AS collagen, but there was failure, and I think this is a personal opinion. Do you have experience using AS collagen and having experienced a failure? Dr. Lim?
I don't know what kind of failure you're talking about. Is it failure of ossification or maintenance of the form? Particularly the bone is mixed with the cell line. If that is compared, the space maintenance is excellent. AS collagen is xenograft. So xenograft is to maintain the form rather than ossification. Dr. Paeng?
So we were quite astonished and amazed by Professor Paeng's lecture. And the on-site question was also, I want to ask you a question. Interpositional bone graft is bone elongation. So it seems similar to that, but then you did not use a separate tool. So, which do you think is more advantageous, distraction or your method? Bone distraction, I used to do that quite frequently too, because I thought 10 millimeter, 15 millimeter of bone distraction will be possible, but the patient discomfort while you do it is quite significant. And the patient needs to have that on for 3 to 4 months. So patient discomfort is quite significant. After I used interpositional bone graft, unless I extend by 15 millimeters, I do not use distraction. So just with the interpositional bone graft, you can increase 10 millimeters. So distraction, you can increase soft tissue, and with interposition bone graft, you can always extend the soft tissue as well. So there is very little limitation, more so than thought, and there's much less discomfort on the part of the patient. So interpositional bone graft is more useful clinically, and I think it has many advantages. I use interpositional bone graft more. I want to give you another question. Professor Paeng's lecture is quite fresh. So you use digital dentistry to do bone grafts. So I think many were amazed, although it was not their case. Many people were impressed, I think. A GBR failure can be experienced frequently, and how can we respond to it, and what is the source of these problems? When you do failure, we try to make many attempts to overcome the situation, but with continued failure, things can worsen. If you rush into fresh attempts, then things can spiral out of hand. So we need to remove inflammation and do healing. After a certain period of healing, we need to do retried then. We need to give it time to heal. It's the same with other surgeries. Cancer surgery, when you do construction, you do it together. And after radiation therapy, within 3 to 4 weeks, or you do it a long time later. If a soft tissue problem occurs, if it's still fresh, you can try, but with continued inflammation, if you just try to revisit the site, problems can occur. We need to wait for healing after removing inflammation. When we do retry with the sinus surgery, we need to wait at least 2 to 3 months. We need to give it some time before we attempt GBR once again. You need to either really make a fast response or give it some more time. Thank you for your response. Because of time constraint, this will be the end of Q&A. Among those who raised questions, I'm going to choose 2 best questions. So the last question, so question was raised regarding post-op complications, and from on-site, Dr. Dentist from Incheon will be chosen as best question raisers. Congratulations, and thank you once again for the 2 lectures. The first session is now complete. Thank you. Dr. Chung No-Mook, once again, thank you. Please give a warm round of applause. So now we are going to announce the winners of coffee coupon. 300 people will win coffee coupons. Now we will start the draw. Congratulations. details can be found in the notice board and dental site. You can get coffee coupons via text messages. Now we will have a break time, and there are exhibition booths and catering next to the auditorium, and there's posters and profile booths on the first floor, so please take a look. We're going to have a break until 10:50. Thank you.
Today we have seminars, conference, so we'll participate, enjoy Korean meal and foreign lecture.
Really want to see what they will explain to us. Many countries, many speakers. I want to listen their experience and their lectures.
Doctor, can I ask you for some interview? In the cases when you have the small thickness of the tissue, do you have a problem to place the titanium plate?
Maybe if the patient has a thin and mucosa without attached mucosa, in that case, at first I made the catheter-affected mucosa of the operation site. After 1 month later, I tried the bone augmentation after making the soft tissue.
Yes, thank you. And for the end, what you recommend me to try to eat in Korea?
Bibimbap.
Okay,
Yes.
I'll remember that.
Yeah.
Thank you so much. I'm recording the people who come here to see some new things in our profession in oral surgery or implantology, and also I'm talk about with my colleagues with other things that we are doing in our own praxis. It's really nice to change experience with the colleagues, and so I'm so glad to be here. You have so many videos. This is the colleagues. This is a girl from United States. You have the people from all over the world. Tell me where you're from.
I'm from Philadelphia. I practice in Pennsylvania.
Okay. How is your impression about this meeting?
It's great. This is my first World meeting, and I think I'll be coming back. A lot of knowledgeable people, and I think that diversity is another favorable thing too. And the knowledge is a wealth of knowledge. So far, I've enjoyed the 2 lectures.
원가이드 시스템의 모든 것이 들어있는 책입니다. 그래서 기본서부터 어드밴스드에서 풀마우스까지 모든 시스템을 할 수 있는 그런 내용들이 다 수록되어 있고 적절한 임상 케이스들이 들어있어서 참조하시면 무척 도움이 될 것 같습니다.
因为我要回去再认真的学习这个OneGuide的这门技术，把这个数字化技术能够在工作当中应用起来。
Очень хорошая технология, продвинутая. Мы ценим, любим, зарабатываем, людям помогаем. Без вас никуда.
Hello everyone. Good afternoon. In life surgery is the highlight of the Osstem World Meeting.
I will do my best to carry out the surgery as planned. So let's get started.
Before we try as a fixed type of restoration, we have to check the angulation of the two implants. That's the key to success.
Creo que los profesores han sido excelentes, han dado muy buena demostración de lo que pueden hacer con sus implantes. La parte de la cirugía en vivo, pues excelente, toda la imagen, toda la entrega que tienen los profesores. Nos llevamos una muy buena enseñanza para nuestros países.
First time in Moscow and next time in Istanbul. This is the third meeting for me. It's the best choice for me to improve my skill. I love Osstem meeting best.
We love Osstem.
Did you know pre-irrigation on implant may improve clinical prognosis? Osstem implant provides guidelines for how to pre-irrigate an implant before you placing it. Before placement, irrigate the implant with saline for 5 seconds to avoid intraoral bacterial infections. Irrigating the implant with saline covers the surface with water. This temporal water film covers the surface of implant. The bacterial attachment is decreased because the oral bacteria contacts the barrier and diluted by water. According to the research, the degree of bacteria attachment is decreased by 28% when the implant is pre-irrigated compared to not pre-irrigated one. It is applicable to not only SA implant but also CA and BA implant. Pre-irrigating an implant may reduce the attachment of oral bacteria. This procedure may be helpful to avoid bacterial infections. Unlike other implants, the soy implant is in wet condition. The surface of soy implant is already coated with the substance, so please use it as is. Although the amount of coated substance on the surface of implant may be reduced through pre-irrigation, it does not affect on the stability of implant. By pre-irrigating an implant before placement, the risk of oral bacteria infections may be reduced. It does not affect on the stability of implant. Increase the success rate of implantation. Introducing the OneCast kit, the digital sinus surgery kit. If you use the OneCast kit, you can digitally pre-plan the exact implant position and drill length required for the sinus surgery. Place the OneGuide template first. Then, use the drills with rounded apex together with the stopper in order to perform safe drilling. You can also perform hydraulic lifting and bone grafting while the template is still in the mouth. Try the OneCast kit for safe and precise sinus surgery. Great unit chairs designed for dental treatment must be convenient for the clinicians to use, feel comfortable for the patient during treatment, and they should also be easy to clean and maintain. I would like to introduce K5 as both a stylish and convenient unit chair. In case the backrest tilts downwards, the leg rest goes up. The tilting function prevents the patients from slipping down. It is convenient for the clinicians to carry out treatments and provide comfort for the patients to receive treatments. The K5 also has a wireless foot controller designed to offer an even more convenient treatment experience for the clinicians. Handpiece RPM can be easily adjusted by turning the foot pedal left and right, making treatment. The sterile water supply device suppresses formation of bacteria and biofilm in the water line of the unit chair. Always using clean water during treatment makes it much easier to reduce the risk of infections. Let's go over K5's key features again. The patient does not slip downwards thanks to the tilting function. When the backrest tilts downwards, the leg rest goes up. Second, the wireless foot controller makes treatment much more convenient for the clinician. Third, DWCS suppresses bacteria in water line to supply only clean water during treatment. Try the K5, a unit chair designed to add both convenience for the dentist and comfort for the patient. Introducing the upgraded T2 Plus with superior high-resolution imaging, ultra-high-speed scanning, and ultra-low radiation dose feature. The T2 Plus has a 0.05 mm voxel size, which results in superior high-resolution images. This enables a more accurate diagnosis compared to the T2. With a T2 Plus, patient waiting times can be reduced thanks to a faster scanning speeds compared to the T2. Images are acquired in just 30 seconds. T2 Plus low radiation mode allows for safer scanning with only 22% of the radiation dosage compared to that of the T2. The low radiation mode allows scans for children and pregnant women without any concerns. The T2 Plus offers various field of view sizes for facial imaging, implants, TMJ, endodontic procedures, and more. The T2 Plus allows for customized scanning based on the treatment. The T2 Plus includes convenient and easy-to-use 1-2 software, 1-3, and VSEP. Through consultation, treatment and implant planning will help increase patient acceptance rates. T2 Plus is available in 3 colors: white, blue, and red. You can choose the color that best matches the ambience of your clinic. Introducing the upgraded T2 Plus with clearer images, shorter scanning times, and lower radiation dose. Selecting the right bone material by comparing it to the patient's existing bone quality and conditions is crucial when expecting the satisfactory result from the GBR. Defects may occur on surgical sites such as the anterior, maxillary sinus, and ridge, which will require bone graft materials that facilitate the process of forming new bone osteogenesis while maintaining the bone volume. With that said, here is the Osstem Implants Xeograft EOS with phenomenal volume maintenance and osteogenesis. For bone graft materials, it is important to have a faster remodeling feature. Similar to the human bone, EOS particles have a cancellous pore structure. The structural property of EOS, when fully saturated with blood, significantly contributes to the process of new bone formation. The success of bone graft material must be verified with various clinic cases. EOS is designed to graft bone in a socket after the tooth extraction, and the treatment of peri-implant defects with guided bone regeneration. EOS can be applied to the sinus lift to place the implant in a maxillary sinus, and to augmenting and reconstruct of the alveolar bone. It can be used to treat and prevent various bone defects. A bone graft material must be easy to use in a variety of surgical situations. EOS collagen plug contains 10% of bovine type 1 collagen. It is specifically designed for post-extraction socket augmentation to maintain the volume and allows for better aesthetic and implant placement. The surgical can cut and reshape the plug to better fit the defected site. The EOS pen is a bone graft material delivered in a syringe-type container that allows the surgeon to hydrate the material with just one hand. And the syringe's inner diameter is available in two specifications, 5.4 and 3.5. This allows the surgeon to select a better suited syringe for each case. In summary, EOS forms new bone rapidly, which can be applied to any surgical site due to its similarity to the human bone. EOS is a perfect solution for both the surgeon and the patient. Try now!
네, 세션 2 이번 주제는요. 오스템 미팅의
The second lecture is the highlight of Osstem meeting, live surgery. So we have live surgeries in the morning and in the afternoon. So the first live surgery session is Professor Yong-Dae Kwon of Kyung University School of Dentistry. He has graduated from Kyung University School of Dentistry. He completed his residency and fellowship at Department of Oral and Maxillofacial Surgery at Kyung University Medical Center, and he is currently the Vice Dean and Professor at Kyung University School of Dentistry. Please give him a warm round of applause. Hello, I'm Professor Yong-Dae Kwon. Thank you for this invitation. For this live surgery, I think live surgery is the key in every event. And we have Professor Jin-Woo Kim from the Department of Oral Maxillofacial Surgery at Ewha Women's University Seoul Hospital will present the topic Beyond the Limits, Feasibility of Dental Implantation in Osteoporosis Patients with Simultaneous Vertical GBR using OssBuilder, Titanium Mesh, and OneGuide. Before we begin, let's listen to Professor Kim's presentation on the surgical plan.
Hello, my name is Dr. Jin-Woo Kim, oral surgeon at Ewha Women's University Seoul Hospital. When I was asked to do this live surgery with the topic of MRONJ, I wondered what I should talk about. It would be good to show MRONJ lesion resection surgery, but it is not relevant to many dentists. So today I will talk about a patient on osteoporosis drugs, how to place implants safely, and the patient lacks bone significantly using OssBuilder. Titanium mesh vertical GBR will be performed simultaneously. This is the most frightening situation with osteoporosis patients. MRONJ occurred after implant placement by a dentist who did not check drug, and the dentist was sentenced to take full liability. So before I talk about the surgical case, let me focus on what you need to know about patients taking bone resorption inhibitors. There are two main technical questions regarding implants. The first one is also for today's case. What protocol should be used to place implants safely in patients on osteoporosis drugs? For this, it is necessary to recognize what drugs are dangerous if the drug requires a drug holiday and which patients are at risk. And first, what drugs are dangerous? In conclusion, there are two types, bisphosphonate and denosumab. Before, the disease was called MRONJ, bisphosphonate-related osteonecrosis of the jaws. Then, in late 2017, denosumab began to be covered by the National Health Insurance, and its use has increased rapidly. Since it has many benefits, its use is expected to overtake the use of bisphosphonate. So a lot of controversy over which drug is more dangerous. Let's look at the results from the most authoritative journal, JBMR, and the risk of osteonecrosis in the jaws is 3.5 times higher in patients on denosumab than bisphosphonate. Also, patients who previously received bisphosphonate and now switch to denosumab have an increase of developing jaw osteonecrosis. Additionally, or synergistically for osteoporosis patient, the denosumab called Prolia is used. It used to be safe if bisphosphonate was not used, but not anymore. I talked about what drug is dangerous. Let's look at a drug holiday for dental surgery. The concept of drug holiday in dentistry is not a recommendation based on pharmacology. If you look at the occurrence of MRONJ, more than 50% of osteonecrosis in the jaws was found following tooth extraction. So drug without drug washout began to be recommended to prevent osteonecrosis, to be careful only for surgery. As you know, in 2014, the AAOMS in the U.S. recommended a drug holiday for oral bisphosphonate for up to 2 months before dental surgery and 3 months after surgery, which was also controversial. So in the latest position paper in 2022, the recommendation was changed. Since bisphosphonate accumulates in bone, it is not certain stopping it for a while can have its ONJ prevention effect, meaning it is difficult to recommend a drug holiday. Denosumab is a little different. If you discontinue the drug, the effect on bone will completely disappear. For bisphosphonate, this controversy does not mean that the drug holiday does not work. Let me talk about our paper soon to be established. In the data of all osteoporosis patients in Korea, it is clear that bisphosphonate had lower MRONJ incidence in the group that took a long drug holiday before extraction. But the problem is it requires a long drug holiday. Denosumab efficacy ends at about 5 months. So the washout protocol is clear in the diagram below. Denosumab is usually administered every 6 months. For implant surgery, you do surgery 5 months after the first dose, and after 2 months of healing, you tell your internist to give denosumab a couple of months later. So there is almost no rebound fracture risk from quitting denosumab, and it's a very simple and clear protocol. Today, the live surgery is the highlight, so I briefly gave you the background. You may have wondered about MRONJ. This year, for the first time, 5 surgical and dental schools are jointly holding a position meeting to prepare a position paper. We are preparing for the international symposium next month, October 20th. I believe you will get a lot of answers for your questions. So I'm going to talk about today's case. A 67-year-old woman came in for a lower posterior implant placement. She was on denosumab Prolia for about 3 years due to osteoporosis, and the last dose was given 5 months ago. After 3 years on the drug, she improved from osteoporosis to osteopenia. As I said earlier, the patient has no history of bisphosphonate and has only been on denosumab. So the risk of MRONJ associated with the bone resorption inhibitors is almost zero. In principle, this osteoporosis patient should receive a minimally invasive or non-surgical treatment, but she was set up for an aggressive bone grafting plan. But precaution, I'm not saying this type of osteoporosis patient can always have such aggressive implant placement and bone graft. If a patient is treated with a high dose or treated for a long time or has other systemic diseases, please ask an oral surgeon near you for a risk assessment. I or oral surgery professors will kindly answer for you. Let's look at the patient case on the left side. There is not enough residual bone, which is 3.8 millimeters near the nerve. It is almost impossible to place implants without bone grafting. So a bone augmentation surgery was planned. On the right-hand side, the surgery will be performed today. Number 17, 46, and 47 are missing. The height of the residual bone is 6 millimeters, and the bone is 6 millimeters. If you subtract 2 millimeters for the lower alveolar nerve safety margin, the available bone is 4 millimeters. If it was a patient with other risks, I would have considered a short implant of about 4 to 5 millimeters, but the patient is healthy in general. We'll use OneGuide to place 8.5 millimeter implants. So the 4 millimeter of the implant will be in bone, and 4.5 millimeter will be exposed over the alveolar bone. So using OssBuilder titanium mesh, simultaneous vertical GBR is planned for vertical GBR of 4 to 5 millimeters or implant placement without alveolar bone wall support. I usually use titanium for the stiff tenting effect. This time, autogenous bone will be taken from the left ramus. The implant positions were precisely determined via Osstem OneGuide simulations. The anterior number 46 was initially thought to have enough vertical bone, but it was horizontally resorbed a lot. So after drilling, it's almost like number 47 without walls in the horizontal defect. The tenting system to be used is Osstem's ready-made OssBuilder titanium mesh. It has great advantage as it can be connected to the implant immediately after the placement, and bone grafting can be performed. Today, as there will be no walls, OssBuilder 3 will be used. And for autogenous bone harvesting from the left side, the auto bone collector will be used. In implant placement using OneGuide, the 1485 kit will be used instead of the usual kit. In cases like this, where the inferior alveolar nerve is very close, the round-shaped 1485 kit will be better than a regular one. I explained today's case. In fact, as an oral surgeon treating MRONJ, I can say there will be no bone after MRONJ treatment. Then the question is if extensive bone grafts can be done with implant placement in the same area. That is what we originally wanted to show in the live surgery, but to make dentists follow right away after watching this case, I've prepared a simpler one. For this second question, we are currently conducting a clinical study with Osstem. I'm going to show you a 3D printed custom titanium, which is going to be released soon by Osstem. For the MRONJ patient on the right, the segmented resection and iliac free bone graft was performed. Fortunately, the free bone healed well, but there is still a very large defect for the implant placement. So in this case of the bone reconstruction, we made a custom guide using 3D printing instead of doing usual GBR. The surgical time was greatly reduced, and with a xenograft only, the bone is confirmed to be really solid after the like the original mandible. The surgery was very easy and the results very good, and it is not easy to get these results in patients who had MRONJ surgery after taking bisphosphonate. A different case, the severe bone loss on the right-hand side caused the entire loss of implants, so all the alveolar bone was all resorbed, and the mental nerve was near the top of the alveolar bone. The posterior region was more resorbed, the worst case for implant placement. This is the design. The soft tissue and mental nerves are almost squared, so using microscope, mental nerves was enough release. After I used the custom guide, so the surgery went easily. As a result, it is possible to augment the vertical bone up to 13 millimeters higher than the remaining mandibular bone. There are no prosthesia, no mesh exposure at all. Bone grafting with this titanium mesh has been around for about 10 years, and I'm treating MRONJ patients with a clinical conviction that this custom titanium bone graft technology using 3D printing is a novel one that shows different clinical outcomes. Osstem is also planning to release this kind of custom technology soon. I'm looking forward to it. If I have a chance, I'll show it to you later. Let's recap. In patients on osteoporosis treatment, the implant treatment is not absolutely impossible, but if it is performed without sufficient understanding, the result will be 100% failure. A minimally invasive approach is the first recommendation. By understanding the drug and the pathological status and using washout strategies, most ONJ can be prevented. Today's case, how patients on Prolia without the history of using bisphosphonate can have implant placement and aggressive bone grafting after sufficient bone holiday. I will see you in the operating room. I'll see you soon. Thank you.
Greetings. I have just started. Can you see? On the left, I think it's going to be quite tight, so I used auto bone collector. And in the area where it's going to be in contact with the implant, autogenous bone is going to be used. And the suture is going to be done. Professor Kim, can you hear me? I think the volume is a little low. You said you harvested the autogenous bone, and yes, the autogenous bone was harvested a little bit, so in the area where implant exposure is done, so autogenous bone graft is going to be used, and on top of it, the bone graft materials will be used. The surgery itself, but the patient's background is quite interesting. Yes. As mentioned, the patient has no history of biphosphonate. Yes, the patient just had Prolia. So in the past, we had 4 years of critical point. And if the patient had been taking it for longer, it was deemed more risky. And if in Japan, through cost study, the cutoff value of cumulative risk, cumulative dose leads to MRONJ risk. And as mentioned, bisphosphonate was never taken by this patient, and in that aspect, the cumulative dose risk is absent here. That is true. So that is why I chose this patient. And among the audience, some people may be misunderstood. In 2013, Taiwan's nationwide study says that the biphosphonate, if the patient has been taking biphosphonate and then moved on to Prolia, and the patients who have just taken Prolia for osteoporosis were compared. In the case of Prolia, the risk was comparatively lower, and the patients who had bisphosphonate had higher risk. And a lot of people worried about Prolia, but based on such a study, it gives you more peace of mind. The guide is placed, and the area for drilling is marked using marking pen. And because I need to open flap, so marking is not done towards the back. Number 12, please. The patient's age is among ONJ patient. I think the patient is a fairly younger, yes. The reason why this isn't mentioned is because there are cases with no comorbidity. Just because the patient received osteoporosis treatment, we do not need to fear about it, but we need to consider other factors as well. We need to think of comorbidity. Flap is being reflected. A vertical incision is made. The mucosa is quite thin, so I'm paying a lot of attention to it. Number 9. Number 9, please. Flap is being reflected, and when we want significant vertical ridge augmentation on linguals, flap raising is quite important. So the nerve is here, so I think there's safety distance. Mental nerve, I can see here in the area over here where vertical incision was made. OneGuide drilling will be done. No water. Okay. OneGuide is being used, and the buccal side is open. I think this is one of the advantages of OneGuide. If you use other guides, they're all closed. So from surgeon's perspective, the drill depths can be difficult to check. From surgeon's perspective, we need to be able to see And at times people find guides difficult, but this is a compromised type of design, so I think this can reduce many concerns. So let's get the implants. Irrigation, please. I'm approaching it very cautiously. So the drill, can you share the information of the drill? $1,485 kit is used. It's slightly different from OneGuide kit. Short implant. If you look here, it's quite blunt, so we want to prevent. And this is a kit where we think that the nerve distance with nerve is close. If we do not touch the nerve, that's best. But even if we come in contact, this is the kit to minimize the damage, and it's quite close to the nerve. So I'm using this kit, 485 kit. By using it, in general, implant tips are sharper, but by reducing that size, this is to minimize damage to vital tissues. Just because you use a 485 kit, it does not mean that you can avoid nerve damage. You need to form a sufficient safety margin, but we need to also use more safeguarding measures as well. So this can be used for placement. So placement mode. I think the professor is about to place implants. The top of the implant does not come in interference, so the professor, are you not going to use countersink? Yes. I think torque is getting applied. I'm just going to manually take a look. Wrench. So the bone is very hard because the thickness of cortical bone is quite significant. In Korea, the implants in Korea have good primary stability, and in these cases, at times difficulties can be experienced. Hand wrench is used to get the planned vertical depths. So implant will be placed. Pull. Say ah. Wrench, please. Wrench, please. Suction. So final drill, you're only going to do it up to the size of the implant, is that right? Yes. I didn't get that. Are you going to drill up to the diameter of the implant? Yes, they're aligned. Hand wrench is used to place the implant to the planned position. So 2 implants have been placed as planned, as mentioned before surgery. There's implant exposure towards the top. So the lingual flap is being reflected. So there's more exposure. Pull. OssGuide connector area is being connected. So please prepare the graft materials. Releasing is going to be done around the implant. So are you going to do perforation on the bone before you do bone grafting? Yes, I think I'm going to do that with this patient. I do not really prefer doing that, but for this patient, yes, please prepare the handpiece. So please give me something to do releasing and pick up. Pull. So if you add more graft material, the soft tissue needs to cover it. So periosteal releasing incision is made. A blade is used to dissect the periosteum. So it can be covered. This soft tissue is extended and tension-free
extension of soft tissue over the implants can be achieved. On the lingual side, I don't think we need to do any more. Over-releasing would lead to better results to avoid the opening later. Okay. OssBuilder is adapted scissors, please. I need to cut. Dental pin set, please. Looks like this is small because of a lot of exposure, but I will go with this. Plunger. So the mesio implant, the lingual bone is up to the implant. I believe there's a 2 millimeters of exposure. So buccolingually, the implants are not in bone. So in order to prevent the bone material leaking, I'm going to bend this a little bit. So I'm going to fixate it a little bit. Cover cap. An OssBuilder is positioned and the cover is put in. $10 millimeter, please. 10, please, for the distal one. I'm going to ask Osstem. You have 10 and 20 millimeter available. It's a little bit tricky. In the posterior region, maybe I should use this. Scissors, please. You need to cut it properly so that no sharp edges remain. So the existing OssBuilders are trimmed to adjust the length. As he said, the sharp part should not be faced above to prevent any issues during healing. The width looks a little bit short, and if they are connected, if these two are connected, it would be better. 20 millimeters, please. It's not a must, but give me 20 millimeter one. That's too big. Good. It's a little bit not enough, but I will go with this. Let me have the bone graft. So attach it to the bone. So this is already harvested. The autogenous bone is added, grafted to the implants. So we have a very good instruments to harvest the autogenous bone. The cortical bone is harvested using an instrument to make it a sludge bone to be a bone graft material. Professor, so do you prefer to make autogenous bone in contact with implants? Yes. When implants are exposed, the autogenous bone, if they are in contact with the exposed area, it will help. In this kind of patient, when bone regeneration would be affected, in this kind of patient, that would be important. And Daniel Boozer's surgery, when implants are exposed, he makes a one layer of autogenous bone in contact with the implants, and then bone graft material is added over it. So you don't prefer perforate the area where implants are placed? And we have many questions coming in. The handpiece, actually, do you usually perforate? No. Why not? I don't think the biological benefits are clear. So I believe periosteomy is more important. So Dr. Kim says perforating the cortical bone is not really beneficial for ossification. In this patient, he wanted to do some perforation, but due to some circumstances in the operating room, he is not doing the perforation. The autogenous bone is too much. It's much better than if you have not enough bone. And xenograft will be packed in. Titanium mesh would ensure the space where autogenous bone is put in, and the rest of the space can be filled with bone graft material. It's not tightly tightened. The second adaptation made it look much better. The patient is sleeping now. Pull it. If you use OneGuide, and you don't have to open the flap, right? So we recommend a flapless surgery, and that is the trend, and that is used quite a lot. But the tooth-supported guide is used, and I prefer to open a flap. But for comfortable surgery, flapless surgery is also used quite a lot. So in our case, even opening a flap, the guide can be adapted quite easily. So that's the request to the company. And sometimes a flapless is used quite a lot, but if a large grafting is done, the flap can be opened in many cases. And among the online questions, when lingual flap is opened for vertical augmentation, so lingual flap is raised, and you may be worried about the damage to lingual nerve, but usually the lingual nerve runs lingually, and it goes through the tongue. So lingual nerve would be affected. If you have the knowledge of the anatomy, you need not be afraid of that. So you need to be carefully think about the position. And this is just damaging the periosteum, but the nerve is much deeper. So AOS is packed over the autogenous bone using the mesh. It looks much more stable. It's a little bit excessively used, so it is easy to remove if you just rotate the above the holes, so they can be removed quite readily. Membrane Artem collagen, please. From Osstem, a guide, OssGuide can be used. The OssGuide is a little stiff, so when you use a titanium guide here, it's a little bit flexible. So please show them the box of the material. So bone graft is almost completed, and over it, collagen membrane will cover it. Suction. Membrane. Please pull this side. Membrane, please. Scissors. How much time do we have? How much time left? Is it already over? So the questions are received. Dr. Kim already talked about this. Bisphosphonate was not used by the patient, denosumab. was used to treat the osteoporosis. So there is no cumulative effect from the drug. So that's why we can do this aggressive surgery. Similar questions are received. So are we already over time? So we are being delayed. So a lot of questions regarding perforation of cortical bone. According to papers, in some papers, perforation is recommended, and some say it makes no difference. If a patient has normal bone regeneration capability, it doesn't really make a difference. If it is perforated, it can be a little bit better, but this patient has very hard cortical bone, and the perforation would require penetration into thick layers, so it was not used. Perforating the cortical bone, I'm not saying it is useless. Yeah, it is a controversial topic. Based on my experience, I don't do it if it is not absolutely necessary. Yeah, I don't enjoy using it a lot. The matrix suturing is being performed. Modified matrix suturing. The flap is fixed so that the pressure can be applied from above. The flap releasing has been achieved without tensions, such matrix suture. I sometimes use it. I don't use it for all wound closure. Dr. Kim is just applying the matrix suture on key areas, and the rest, the flap is tension-free, so you can use other sutures. Here's a suturing, and the surgery has progressed quite a lot, and we are getting to the end. The suture, 4050. 40 for key suture, and the 50 for the rest. Monofilament type, and key suture 40, and the rest, the 50 suture was used. And 50 gives the best tissue response. But, sometimes they're not visible, so I instruct the residents to do the job. So when I do the surgery, I handle it, but when stitch out is needed, I make the resident do it. Now the surgery went quite smoothly, and we are almost done. Titanium mesh is used, so they're worried about the dead space. A similar question. So you adapted the mesh first, and you fill the space with the material. And what about that there is some space left not filled? Based on my experience, even though there's empty spaces, I believe a bone would be generated. Titanium is flexible, so you can open it a little bit and then put the material more. And based on my experience, I believe a bone is regenerated in that space as well. It's almost completed. As you can see, the flap is tension-free, so a very good approximation on the suture site, so we can be confident that it will not open up. Five-0. Professor, after the surgery, to prevent swelling, do you give oral steroid? I believe it's better to give it to him. So this is the right-hand side can have some pain. So surgery is on the right-hand side in the posterior region, but on the opposite side, you harvested bones. So after bone harvesting, swelling can occur. And if swelling continues to the graft site, that may affect the bone graft. So I separated the sites. So if you just use one side, it would be better. But the bone harvesting site may affect the surgical site. So that's why the harvesting and the surgical sites are separate. What time is it? 11:45. What's the ending time of this session? Is it 11:50 or 12? Cut. So let me finish the suture. Okay, we have very skilled resident, but let me just finish it. So the surgical site is almost sutured. So when you raise the flap on the lingual side, did you raise the flap up to the medial side of the surgical site? If it is necessary, I would raise the flap in the medial or distal side if necessary, but I didn't do it this time. So for vertical augmentation, sometimes we raise flap on the medial or distal side. I couldn't see clearly through the camera, so that's why I asked the question. So I wanted to find mandibular anterior region surgical case, but for the live surgery, for the visibility to everyone. It's not easy to find an appropriate patient for live surgery. Irrigation. Suction. 50. I don't have to do it, but just for peace of mind, I will use 50 a little bit more. 40 will do too. Pick up. So this will be the last stitch, I believe. Yes. Cut. Guts, please. Please say ah. More guts. Don't bite down hard. Would you bite down a little bit? That's good. So this has been Professor Jin-Woo Kim's live surgery. Very interesting case. Please give a big round of applause to Professor Kim. So up to now, Professor Kim gave us very good live surgery with bone grafting. I already talked about some questions that have been received online, and if we have more, I will answer them too. Oh, you are already here? Professor Kim, thank you very much. Thank you. There have been a lot of questions. The buccal flap is pulled and the vestibule would be lowered. FGG or apically positioned flap. Are you going to do that later? I will watch and wait. attached gingiva is hardly there, so I will discuss it with the patient because FGG can be painful. So if the patient wants, it will be good, but the thin biotype is the patient's type, so I need to think about it. So in the future, you will watch, observe the healing situation, and you will determine it later. In that case, we need to persuade the patient to go through the surgery, additional surgery. The patient struggles to make the decision because it has already been hard. So do you have any question from the floor for this case or a similar case? Professor Kim? It is my honor to have some time with you. I enjoy the surgery and thank you very much for your hard work. My question is, osteoporosis patient is what we are talking about. Is that because of that you use autogenous bone, or do you usually use autogenous bone in cases like this? I don't always use autogenous bone in this patient. The patient has had osteoporosis for a long time, even though there is no medication accumulation effect. But when we augment vertically, when there is exposure on implants, I prefer to use the autogenous bone. The second question, OssBuilder is used. Do you always use collagen membrane for that, or just this time? I hardly use it if I place just one implant, but if the area is wide, I use it. Is it because you want to increase the effect of GBR, just in case if the site can open up? Yes, for that. And the ossification of GBR would be enhanced using it. And why didn't you sedate this patient at all? Actually, sedation was in the plan, but due to circumstances, I did not use it. But the original plan included sedation. So you don't use electrosurgery for flap releasing or incisions. So why do you prefer just mass? Electro, both? That's my preference. But due to the circumstances, I couldn't use the BOVI. Do you use temporary RPD? In this case, I say for 2 months it should not be used, even though it's a titanium, and it will affect the bone regeneration. The last question, osteoporosis patient. For this patient, what is the post-op prescription? Do you have any unique prescription that you have for osteoporosis treatment? Yes, given the osteoporosis patient. Any special medication do you prescribe? The osteopenia patient, so it was not up to osteoporosis. If osteoporosis was severe, I could have consulted with other doctors, but this was osteopenia patient. Thank you for the good answers. Thank you for the good questions. And Dr. Kim, thank you for the answers. Any other questions?
Greetings. I enjoyed your surgery. I am Joo-Hyuk of Seoul Rooted Hospital. So anchor height. I'm curious about anchor height, 0.5 millimeters. The patient is very thin biotype. And after secondary surgery and after uncoverage, the biotype is very thin, a lot of people talk about biologic width. The implant platform needs to have some depths from gingival margin. Perhaps you could have used a thicker anchor. Biologic width needs to be considered, but because the patient had thin biotype, if it becomes too high, then it can erupt. So I will consider using 0.5 and 1 millimeter. The ideal option should be chosen in this case. I think I want it to be as safe as possible. I didn't want to embarrass myself in failing in live surgery, so I took a safer option. Thank you for the wonderful question. It did cross my mind, but I think the dentist will do soft tissue augmentation perhaps as well. And I think you have gone through significant efforts to choose this kind of patient. So patients receiving osteoporosis, patients moving on from bisphosphonate to denosumab. Not a lot of people present this case in live surgeries. And when you come across these patients, there are not that many patients like Professor Kim's patient. You need to choose your patients very carefully. And that's why I think Professor Kim paid a lot of effort to selecting his patients. So is there any comment you'd like to make? So I've had other people come in and observe my surgeries, but it's my first live surgery and I was quite nervous. If you have noticed my mistake, please, I hope you understand it, and please let me know if you have any comments or questions. Thank you. So I did it also last time and it was quite nerve-wracking. So we have a little more time. Is there a question you would like to raise? So in the center back. I enjoyed your surgery. I am Dr. Yang Jung from Incheon. You placed a 8.5 diameter implant. So if you had placed a 7 millimeter implant, perhaps you would have reduced the amount of vertical augmentation and it could have had more advantages. Because the patient has osteoporosis, perhaps you would have been able to reduce the surgery time. So what do you think about using 7 millimeter implant? So the patient's systemic situation and local situation needs to be considered. And in this case, the patient did not have comorbidity and the patient was younger and the patient had to use prosthesis for long term. Crown root ratio needed to be secured. And in principle, I use 8.5. If the patient had a comorbidity or bisphosphonate, then if the approach is minimally invasive, then I would have minimized bone graft and chosen 7 millimeter diameter implant. And there were similar questions on the online chat as well, but 7 millimeter is an option, but we need to consider the amount of bone regenerated and, if possible, the area that is submerged in host bone. I think we need to find a compromise. I think we're on time. So post-op X-ray is just around the corner, so please give us a few moments. If you have questions, please feel free to raise them. Thank you for the wonderful surgery. I have a question. So you did on the right side, but I think the patient has more resorption on the left side. Do you have any plans for the left side? So, what are you going to do removal upon second surgery? on the right side, I think we need to wait 5-6 months and do secondary surgery, and if necessary, I'll do FGG, and this will be determined with the patient consultation. On the left side, I think it's going to be difficult to do implant placement, and vertical GBR is planned. 7mm, 8mm is planned. I'm considering tenting, or I think I've mentioned it in my PPT, or I'm not sure whether I'm going to place it separately. And vertical GBR is planned. In Korea, in Osstem, I think options are available, but it needs to be approved. So about in 1 or 2 years, such options will be available to us. I hope it answered your question. So 5 months of healing is going to be had before moving on to secondary surgery. Post-op X-ray. Because of lunchtime, I think we need to wrap up. Professor Kim, you can reach out to Professor Kim separately. Thank you, Professor Kim of Ewha Women's Hospital. Please give him a warm round of applause. Thank you. We'd like to express our deepest gratitude to Professor Jin-Woo Kim for the successful live surgery and Professor Kwon Young-dae for chairing the session. It's now time for lunch, which will be served until 1 p.m. Also at 2 p.m. there will be simultaneous sessions on orthodontics, practice opening, and digital dental lab. So the afternoon session of Osstem Meeting 2024 Seoul promises to be even more enriching. Coffee coupon event that many of you have been looking forward to will be had before third session. This is the end of second session. We'll be back after lunch. Thank you.
TS Multi-TI base enables digital implant restorations for edentulous patients. Using the TI base with a multi-abutment and multi-angled abutment enables creating a single-unit prosthesis even in an edentulous case. Using a multi-scan body, the surgeon can select from a dedicated library to 2 digital scanning options, TI base, long or short. To ensure a proper fit and eliminate any possible errors, the prosthesis must be seated in the mouth before being cemented onto the TI base. Try our simple and accurate TS Multi-TI base. Introducing the 1MS kit, the implant surgery kit for anterior region with narrow bone width. In the anterior region with narrow interdental space and also in the narrow bone width, place the OneGuide template. And then you will be able to place MS implants with the most narrow 2.0 mm diameter and TSIII 3.0 implants exactly in the planned position by using 1MS kit. Try the 1MS kit, the implant surgery kit for the anterior region with narrow bone width. Introducing the Scan Healing Abutment, which helps you to take implant impressions without removing the healing abutment. You can use the dedicated carrier to fasten the Scan Healing Abutment in the correct hex direction more conveniently. The Scan Healing Abutment is available in different lengths. You can choose the right abutment for each patient's implant surgery case. When using a CAD program, the unique shape of its upper surface helps you identify the abutment's length. You can also create custom abutments with our official library. If your clinic does not have an oral scanner, or if you are having issues with scanning, you can take a rubber impression as an alternative. Experience easy implant impression taking with the Scan Healing Abutment, which combines the functions of a healing abutment and a scan body. 2024 OneGuide System, pinnacle of digital guided implant surgery, ultimate reference for guided surgery, showcasing diverse clinical cases. The long-awaited English edition of the OneGuide System, which encapsulates the expertise in digital guided surgery, has been officially released. This book is the climax of 2 years of dedicated work by Dr. Se-Ung Kim and Dr. Yong-Suk Kim, renowned for their 23 years of successful implant procedures. The Korean version of the OneGuide System was honored as the 2023 Book of the Year. This single volume encompasses the full spectrum of digital guided surgery, spanning from fundamental principles to advanced techniques, covering both single-case scenarios with OneGuide and comprehensive treatment for fully edentulous patients. This book encompasses the procedures of 1CAS, 1MS, and 1485 kit with a diversity in clinical cases. Now, dentists worldwide can delve into the OneGuide system.
임플란트 유명한 게 좋을까?
뭐가 달라도 다르겠죠.
임플란트 세계적인 게 좋을까?
뭐가 달라도 다르겠죠.
치과 의사에게 사랑받는 게 좋을까?
뭐가 달라도 다르겠죠. 오스템 임플란트.
I hope you enjoyed the lunch. I brushed my teeth and am now back. We will begin the afternoon session. I'd like to introduce myself once again. My name is Lee Gun-ha. As we begin the afternoon session, I'd like to introduce the exciting events we have planned for everyone who has joined us today. First, let's go over the offline event. We've prepared even more fantastic prizes for those of you attending in person. The prize draw will take place at the end of the event. The prizes include an LG OLED TV, Buchen toothbrush kits, Osstem toothpaste, and more. Please stay with us until the end and show your support. Next, we have an online event. For those of you watching online through dental website, we'll be giving away coffee and a dessert set coupons to 900 participants. You can participate by responding to the giveaway pop-up that will appear for about 3 minutes on the dental site, so don't miss your chance. The longer you stay, the higher your possibilities are. Additionally, for those who stay tuned until the end of the session, we have some amazing prizes lined up, including Dyson V12 vacuum cleaner, 2 Wapic oral irrigators, and Horangi plushie sets that we hope you stick around and join the fun. There's an important point to know when participating in the events. To join any of the online events, you must log into the dental website, and please make sure to register in advance. So for those of you on mobile devices, remember to hold your phone vertically to participate in the pop-up event. After each lecture, during the Q&A session, we'll be selecting the top 10 questions from live chat and in-person participants. The winners will receive Wapic handheld oral irrigator. For those selected as best online question participants, we'll be contacting you individually, so please be active and get involved. Now to the second event pop-up on dental website. Don't miss out on your chance to win coffee and dessert coupons. The results of the draw will be announced after the third session, and the coupons will be sent to you via SMS. Next, we have a special session prepared by Chairman Choi Gyu-ok of Osstem Implant. Let's welcome Chairman Choi with a big round of applause.
Good afternoon. I am Gyu-ok Choi, Osstem Implant Chairman. Thank you very much for joining Osstem meeting. And I also would like to appreciate those who participate online, and the speakers, chairs, and poster judges and participants. Thank you. Today, I'm going to talk about our company's story in the past and how we will be helpful to dentists. So we have more than 27 years of history. This is the 28th year. In 2025 and 2026, we will reach the 30th anniversary. Since 1997, I founded the Osstem Implant in that year, and we started with the name D&D system. D&D stands for Dentist and Digital System. Dentist was me, and digital system, the digital software, hardware, and software and hardware were integrated to help dentists. So we started with the name D&D system, and at the year of 2000, we began to do business of implants, and we changed our company name to Osstem. Osstem stands for osseous technology It's the technology about bone and a digital system. Digital system had been pursued even before that. So OSS is from osseous, and TEM is from the system. Our management philosophy, by helping dentists for better treatment, we want to contribute to the human health improvement. So we help dentists for better treatment so that dentists can have more advanced treatment to treat the patients better. That way, we contribute to the human health improvement. Good friend is our slogan, to be a good friend to dentists. Our symbol character is pyorangi. Pyorangi is the combination of leopard and tiger, leoger. So in Korean, it's pyorangi. It's a leopard plus tiger. Good friend. As a good friend, we want to help our friends to provide better treatment and for better management of clinics. Treatment support, what kind of treatment we are talking about. So we will help in terms of implants. And another thing is being prepared in school, 3 diseases. The malocclusion, plaque, and the tooth loss. And tooth loss and the malocclusion, that's 2 major problems. So tooth loss is a very serious disease or problem. In order to resolve tooth loss, so we need to use implants, and we will try to help in terms of orthodontic treatment. We are preparing for that business. From 2000, we started implant business, and I told people that there are 2 types of people in the world. Those who can do implants and those who cannot. Those who cannot do implants. The dentists who cannot do implants will be helped so that they can treat with the implants. So that is our principle. So we provided a lot of training for that. And the majority of people, the dentists, took the AIC course, the implant training course. And in Korea, the participants has reduced, but in overseas countries, we train about 4,000 dentists, and our target is 10,000 dentists to be trained under AIC. So Korea is #1 implant treatment ratio based on per 10,000 people. Compared to other countries, Korea is #1 in terms of implant treatment. So we learned implants, but now we are teaching implants. When we started, we went overseas to take a training to learn implants, and there were dentists who went outside to learn implants for 6 months or for a year, but now it is no longer so. Now, at that time, actually, we invited many foreign speakers, and there were so many people in the audience, but now we don't really invite them anymore because we realize we already know when the speakers talk about implants. So we have many more opportunities to teach them. And there are so many foreigners coming to Korea to learn implants. Last year, more than 1,000 foreign dentists visited Osstem to learn. So in terms of dental industry, the export of implants, that's our number one export item, the implants. And the superstructure is also separate, and that's also number one in terms of export to other countries. If those two are combined, it's much more. And we used to import a lot of implants and dental equipment and all others. Now we are primarily exporting all of them instead of importing them. And medical device production, Osstem has been number one. From 2020, we produce medical device, the number one in Korea. SD biosensor was the number one in 2022 because they produced the diagnostic kit for COVID-19. But last year we achieved number one. Throughout the world, implant sales volume from 2017, 7 years in a row, we have been number one. So Osstem implant is the number one implant used throughout the world, and we will have the same result this year. That will continue into the future with a bigger gap between us and number two. I will talk about management support for you. We provide support for treatment and also management of the clinic. Management. In English, some people say management is, some people say business is very important, but I would say management. So when we do not have a lot of experience, technology, or money, we need to utilize our resources to achieve the management objective. That is the management skill. In dentistry, dentists serve as CEO, and they're also working as floor workers. And sometimes we do not know what others are doing. And if you have a bigger clinic, the problem is more serious. And you need to recruit people to work for you so that we have the digital system. Without this system, effective management would not be achieved. What is the digital system? In our view, that's called OneClick. Osstem's technology and digital system is abbreviated into Osstem. So Osstem's technology has been emphasized, as I said before. We are number one implant seller, and Korea has become a teacher of implants instead of a learner. So, but the digital system has not achieved that level. So electronic chart and insurance, health insurance claims have been utilizing digital technology, but we need investment beyond that. We have about 7,000 people. 900 of them are researchers, and more than half of the researchers, more than 400 people, are software engineers. They plan and develop software, CT scanners, 3D printers, milling machines, so digital dentistry. So we have more than 500 people working in the digital industry, digital area. But still, we need to work more. So for more than 20 years, we have been focusing on implants, but now we need to advance the digital aspect more. Digital system. Let me introduce a portion of the digital system. This is patient care. This is an application that we developed. On the left-hand side, there is treatment. On the right-hand side, there's a messenger. So the new app that we are going to make is the combination of Naver and Kakao. So it functions similar to the combination of those two. So using the app, you can find a clinic and you can make a reservation. The customer or the patient can make the very first appointment using this app. And if reservation is made, notification is sent to the patient about the reservation date. And two-way communication is enabled. It is for new patient as well as for existing patients. On the one click, during treatment, if a customer or a patient sends a message, it appears on the system. One click, the basic of one click up to now, the patient chart. Okay, so you can see the tooth numbers. Here, panorama image is added. So either panorama and the tooth numbers appear. It can be panorama or the CT's panoramic view. So based on that, the patient condition can be displayed and the chart would be recorded. So the chart record would be reflected on the panoramic image. So when a panorama or CT is taken, the current patient condition is displayed, and the one treated and not treated are indicated so that treatment planning can be performed. So a treatment plan is automatically established, and based on that, a consultation can be provided to the patient, and OneGuide is the name of the program. Many patient data is used for consultation with the patient. The patient data and consultation data, when consultation data is not sufficient, and it is hard to find the appropriate case. But if it is too much, it's hard to choose the right case to explain an example to a patient. So patient data and consultation data can be shown together. Now the data is not abundant currently. Electronic chart. So treatment records. The medical chart is in the order of dates. So if you enter some date, you can see the history of the treatment on that date. So that the treatment history appears like each book leaflet, much easier to understand the treatment history. So you can filter the treatment by keyword or by item. So that is being developed. This is based on teeth, and this is images or videos or treatment plan or keywords. So by entering those, you can see all the related ones. One chart, all the record of a patient can be made Up to now, we primarily recorded treatments, but phone call is also recorded here, whether it is outbound call or inbound call. And then phone calls with a specific patient, CRM, sending and receiving text messages, and whether the treatment cost has been paid, and the reservations for treatment, they're all recorded. So this is a separate chart. Not only the treatment chart, all the records are available in this one chart. And there is a health insurance claim guide, so you can make a mistake when you submit a claim, so that there are triple checking done. And there is an health insurance claim guide, and daily claim submission checking, and the monthly checking. So they are almost completed, and there are about 400 algorithms for health insurance claims, and this is on a daily, weekly reservation status. So as you saw, the chart, even though it is hundreds of pages, you can flip through like a book. So to manage patients, we provide all the information beyond the treatment record. This is staff management. Then job is prepared, and this will be improved further as I explain. Clinics, operator, Osstem, and there are people who want to work in a dental clinic. If a dental clinic wants to recruit people, a banner appears, and the banner would be noticed by someone who wants to work in a dental clinic, and this is the connection between those who want to recruit the staff and the potential candidate of the staff. So CV can be submitted by you become a member of this site, and you can enter the conditions for your job, and all the qualifying dental clinics will appear based on the candidate's conditions, requests. So the messenger program is linked to this. So you can apply for a specific job with some requests in terms of work conditions, and all the qualifying clinics will appear. Like if you want to work in this area, the clinics in this area will appear. Or if you want to work anywhere in Seoul, all the clinics that satisfy your request will appear. Or if you want to work just for 1 year in Jeju Island, the qualifying clinics in Jeju Island will appear, so that you can choose one among many. From dental clinics' point of view, actually this is available as a mobile app. So if you are a candidate who wants to work in a clinic, you just enter your requests or conditions to work. And dentists are registered here too. And they can enter the conditions they request for the potential workers. And the banner would be displayed, and the staff candidates will appear automatically when you enter the request. And if you want 5 years or more experience with the candidate, and if there are not many such candidates, then you can lower the work experience to 4 years. And if you can provide dormitory for the staff, then you can recruit people from another region. So those who want a job and who want to hire people can be connected like this using this site. So two-way communication is enabled. So this is being developed and it's being tested right now. So this is for recruiting. What is very important is how many job seekers will come to this site. When the program is finished, we will try to introduce this app to as many people as possible. The students, the dental assistants, and those who are in school. And external people can also use this app to find a job. Nurses or someone wants to work as a coordinator. They can come into the site and find the jobs. So our aim is to become number one, successful recruitment results. So Osstem way, our way. Osstem way means Osstem's work method. Work, people, time, planning, implementation, and checking. So timely implementation of certain tasks by people would be enabled by this, and this it can be applied to dental clinics. So you can see what a staff is doing all day long, and someone comes to the clinic and what kind of lab work need to be received and what materials need to be prepared for the day. So software helps that this is all included in one click. And the timetable is presented to a specific staff. And if some task is not completed, the notification would be shown. So the dentist who works in a clinic is the most busiest person because he or she should run the clinic as well as to do the major work. So there's an office manager, team managers, and there's hierarchy of organization. And then if someone is not doing the given job properly, that's all displayed here so that the work can be facilitated. This is the doctor's, the dentist's flow of work given a day, and it is all summarized, detailed in this chart every day, and what needs to be done at what time is all displayed so that timely work execution can be made. So you can also check inventory, whether necessary resources are prepared. 방장서 is the Korean name. Bang means various rooms, operating rooms or the doctor's room. And Jang means cabinets. And cabinets also have drawers. So the resources or items in inventory is identified. And the location of a specific item is also shown. And whether it is in the upper drawer, upper cabinet of which room. And if you open a cabinet, you can see all the inventory in the cabinet, and this is on the drawer level. mobile cart. You can also see what items, the quantity and the items stored in a specific cart. You can see on the screen. And then you can also check whether a certain item is returned back to the appropriate location. And the inventory checking, the physical checking can be done once a month or so to check the inventory. So once a month, you submit national health insurance claims. And the staff tasks to be carried out for a given month is also displayed here. Our way, Osstem way, can help planning and execution of the plan can be facilitated. This is the plan. So this is the plan menu, and execution is in this menu today. So the plan spans several days or month, and if a certain task is carried out, it is indicated. If not, the bosses can also see that, and the bosses can help why the task is still pending. If nobody cares, nobody checks, certain jobs cannot be correctly executed. So when people execute the given job appropriately, the clinic can run very smoothly, and the environment, atmosphere would be very good in the clinic. Mobile solutions. So individuals need to have this mobile solutions, which is not expensive. So that's what we are going to help you. And with the mobile app, staff will know what their tasks are, and patients can submit the request for treatment, and this is an agreement that you need to obtain from a certain patients for a certain treatment. Digital gateway, with one click, we want to open the digital gateway. And we used to focus on treatment records, but from now on, we will provide efficient tools so that dentists can work better. All the equipment will be linked to this. If X-ray or CT panoramic images are taken, and if scanners catch scans, those will be included in the one-click, 1-3. Up to now, we worked like this. So this is a hex shape. Coronal sagittal cutting was done. Surface rendering was used, but in the past, as you want to see, 1-3 can be made. It is a view. It is a viewing program. It is viewing on your terms. So that is helping viewing of a certain information. Surface rendering on the left-hand side, that's a surface rendered, but in the future, at any angle, you can view anything, like scanned data. If you look at sinus, just like endoscopy, you can look into the sinus. If you cut a sinus, in terms of teeth, the teeth section can be viewed, but for sinus, you can look inside the sinus like endoscopy, and this is cut in half. But if you drop an implant in the sinus, you can see the implant in the sinus, and the actual sinus will be displayed. We are preparing that program. So at any angle that we want, we can cut the image, and then we can provide various views of the same item. Surface rendering is on the surface based on CT, but we can do surface rendering for any item, like sinus only can be rendered, or teeth only can be rendered. The orthodontist would be interested in teeth view only. So if all teeth need to be extracted, that view will appear. So this is just a teeth only view. It doesn't look realistic, but it will be improved, and the pictures will be very realistic in the future. X-ray, the damage to human body, the accumulated the X-ray will be indicated in colors. If you take X-rays only in our clinic, that will be accurately reflected in the image. And if you take the X-ray in other clinics, the data would not be that much accurate. 1, 2. This is 2D images, panoramic or camera images. They will all be managed in one click. If we fabricated something, for example, OneGuide for implant placement, OneGuide can be fabricated, and for ortho treatment, digital aligner, the invisible aligner can be made, and the brackets can be attached, and on 014 or 018 wires can be indicated according to the sequence of ortho treatment. Dentures and other tools would be linked to one click. So, as I said before, we have about 500 software engineers, and still we still have some way to go. And I believe you will be able to see real products soon. It takes a lot of time and money, and we focused on implants, but we have prepared for these programs, and these programs will be available soon, and the digital system that integrates all of them would be one click. National health insurance claims and electronic charts used to use digital technology, but patient management and dentist care tools would be enabled by one click. And if you wait just a little bit longer, those will be in your hands. Thank you.
Thank you, President Che, once again. Let us begin at the third session of the Osstem Meeting 2024 Seoul, which is being translated. Let me talk about the panoramic image that was yet to be shared with you. So the panoramic image will be shared. Dr. Kim Kyung-won is going to help us understand the image. Professor Kwon or Professor Chung should be explaining this, but I'm going to provide a brief explanation. I think that is the real deal of the live surgery, but the patient had to go to the bathroom. I'm sure you saw this during live surgery. Autobone collection was done ahead, and on the left, autobone collector was used to harvest, and on the right side, OneGuide was used to place 2 implants, and on top anchor was connected, OssBuilder was used, and autobone was used for bone graft. A bone graft was added, and surgery was completed. If you look at the X-ray panoramic image, as planned, surgery was done and the patient was satisfied. Thank you. Thank you. We will commence the third session. I'd like to introduce Dr. Jong-Hyun Park, the session chair and director of Seoul East Dental Clinic. Dr. Jong-Hyun Park graduated from Seoul National University School of Dentistry, completed his internship and prosthodontic residency at SNU Hospital, and earned his master's and PhD, and he is the chief director of Seoul East Dental Clinic. Hello, I am Dr. Park Hyung. I am the chair for the third session. This is the prosthodontic session of the day. The main theme is complication. And today we're going to talk about digital dentistry to minimize complications. I hope this helps you in your clinical practice. Opening the third session, we have Professor Joo-Hyuk Bang from Dental Hospital for the Central Veterans Hospital. Please welcome him with a warm round of applause. Greetings. My name is Bang Joo-Hyuk, and I work in prosthodontic department at Central Veterans Hospital Dental Seoul. I'm honored to be here. I'd like to extend my gratitude to the staff. Let me begin. Today I'm going to talk about the prosthodontic complications, and I would like to share my thoughts briefly. These are the contents. I want to talk about the implant systems. There are different implant systems available, and these days we use internal conical joint connection is used most frequently. So I want to focus TS system. After selecting implant system, there are many variations and the intermediate structures and the final prosthesis placed on top. The most common method involves fabricating conventional abutment on the implant followed by a crown. Although this structure is simple, the complications that arise are diverse and can be challenging for clinicians. This can be a major challenge. I want to talk about implant-prosthetic complications. The grand theme of today's session is to utilize digital dentistry, and I want to talk about areas that we can overlook due to the digital system. As we all know, the internal conical joint connection has distinct characteristics, including tapered inner surface and a hexagon connection. Some people use non-hex fixtures, but a lot of people use a hexagon connection. Due to its structural nature, internal conical joint implants can experience axial displacement and rotational freedom of the abutment. This can lead to stress concentration caused by masticatory and external forces at the interface between implant and abutment, potentially causing issues. In the case of internal type, compared to external or tissue-level implants, it's difficult to detect incompatibilities between implant and abutments on radiographs. Therefore, it is crucial to consider ways to minimize errors or mismatches during the clinical stages. The first step in prosthesis fabrication is impression taking. Traditional methods like pickup or transfer impressions are still widely used, but digital impressions using skin bodies or coated healing abutments are being more common. Regardless of the method, it is essential to verify the connection of components via radiographs to reduce errors at the impression stage. A lot of intraoral scanners have become a spread for digital impressions are taken frequently, especially in multi-implant cases. If you are going to fabricate multi-units, you need to do correct connection, and scans should be done properly. Regarding impression, how to take impression. This was already addressed, and a lot of videos have been introduced. What is most easily overlooked is more so than anything else is the scan data. As I was preparing this presentation, I asked a lot of lab technicians. So even when impressions appear accurate, people often say that the scan itself was a problem. And according to a study, if more than 10% of error are observed in the images needed for matching, statistically significant errors can occur in determining the position of the virtual implant. We need to make sure whether there is any error after scanning. And when checking, rather than color mode, texture mode is recommended. Even when an impression appears accurate, discrepancies between the library and scan images can still occur, influenced by factors such as material wear, manufacturing tolerances, or vertical displacement. For instance, although scan body impression might seem well captured, horizontal errors may appear during the design process when compared with the library. Studies have shown that significant discrepancies can exist between actual dimensions of scan bodies and their corresponding library files. This was not about local products, but this was particularly true in terms of height, diameter, and inclinations. there were significant discrepancies. This might be due to manufacturing tolerances or impact of applied torque. These studies indicate that difference in height tended to show the greatest variance, which could be due to manufacturing tolerances and influence of the applied torque. Additionally, although the product you might be using have small manufacturing tolerances, it may be possible that scan body you use on any given day could be at the extreme ends of the manufacturer's tolerance limits. There, it might be necessary to communicate with your lab technicians. Studies have reported that the tightening torque of the scan body increases the displacement of components, also increases, particularly if you look at the catalog. Scan body healing abutment, when you tighten it, rather than specifying how much torque, it just says you need to use a head tightening. Consistent torque needs to be applied. Despite the internal angle of 11 degrees being standard among internal implants, the internal diameters and hex shapes can vary between manufacturers. The internal diameter and internal structures may vary. Some clinicians use scan bodies or coated healing abutments that are claimed to be compatible with implants from multiple manufacturers. However, even within the same internal implant, type differences in internal diameters can lead to vertical discrepancies. Therefore, it's safer to use scan bodies from the same manufacturer. And if there are significant discrepancies, you need to look at the actual measurement and library value. Recently, I measured actual values of the scanned bodies I used, and I found a height difference about 30 microns. So this was a one-off check. So this is not exact. And there were a height difference of 30 microns. If you always check, that is best, but realistically speaking, that is not feasible. You need to communicate with your lab and when necessary, verify scan bodies or healing abutments being used when there are significant discrepancies. Next is about abutments. Most people use these. I want to talk about the prefabricated and custom abutments. One of the longest standing debates has been over the fit of pre-milled versus custom abutments and whether original abutments perform better than non-original ones. The fit were compared. Clinically, it is unavoidable to use custom abutments, but recent studies suggest that while both prefabricated and custom abutments show clinical acceptable micro gaps thanks to the advance in CAD/CAM technology, prefabricated abutments made with original components still tended to offer better fit. For custom abutments, there are two primary fabrication methods, one that uses pre-made rods where the connection part is already machined and milled, and another that mills the entire abutment including the connection part in one step. When using rods, the abutments can be made using standard jig or a reverse jig depending on the connection method. Compared to prefabricated abutments, custom abutments can show micro gaps, especially at the upper contact area, with the implant often more pronounced at the top. One reason why stock abutments might show better results is that they're mass produced with lower machining tolerances. In comparison, custom abutments are manufactured in smaller numbers, and inherently they have larger machining tolerances. For abutments made from rods, the connection part is pre-machined and the upper part is created afterwards using milling machine. For genuine Osstem rods, the more taper gap is managed to be less than 1 micrometer. And this was the response I got. However, if non-original rods are used, the precision and therefore the fit can vary. Typically, there's a small gap between the milled part and the pre-machined connection part, designed to prevent the damages to the connection during milling. After milling, this can be a safety component. Polishing or other processing, such as polishing after milling, is required. If there's inappropriate polishing, then the connection area can be damaged as well. In contrast, abutments milled from single rod are created in one piece from hex to coronal part. And this approach has significant advantage of minimizing the likelihood of misalignment between the connection part and the coronal part. However, unlike mass-produced genuine rods, where quality control is rigorous, the abutments are produced in smaller quantities. If the manufacturing facility does not maintain high standards, significant errors can occur from the connection part onward. When you use abutment, another important part is screw fit. If you use non-original components, there can be significant discrepancy. Screws can show significant variations in fit, particularly in the head and pitch areas. This is a photo comparing screws from 3 different companies that we use at the hospital where I work, and you can see that the shapes are all different. Additionally, the shape of the head portion also varies among them. The preload considered crucial in fixing an abutment occurs when the head of the screw engages with the inner surface of the abutment. As torque is applied, the pitch of the thread goes into the internal threads. Therefore, a good fit between screw head and abutment's internal surface is essential for maintaining preload. The shape of the screw head and area of the abutment that it contacts must be compatible. Even within the same brand, such as Osstem, the screw design has undergone changes over time, so extra caution is required. The pitch of the screw is crucial because the precision of screw manufacturing varies, and each implant system has different screw shapes and contact methods. The problem becomes more pronounced when using compatible screws from manufacturers rather than sticking to the same company's products. And this is not directly related to the fit, but Osstem is transitioning from the existing design. For stock abutment, tie screw is used, which is the new type. Osstem is transitioning from ebony gold to a new tie screw. Regarding abutment, the screw is the space between the bottom of the screw and the base of the implant in short implants. Since the internal space of the implant is shorter in short implants, the clearance between screw bottom and implant base is reduced. As a result, if a screw with different length is used for compatibility, then there is a higher likelihood of bottom interference, which can prevent proper tightening of the screw. As we all know, using original product is the best, but at times we use compatible options. When using compatible custom abutments, the practical step a clinician can take is to regularly perform regular checks to identify any issues and to maintain preload through retightening. one of the main considerations when choosing abutment is whether to select a hex or non-hex design. Non-hex abutments have larger contact area compared to hex abutments, which makes them more advantageous in terms of stress distribution. If you look at the connection area, there's no straight area, so there's less interference, less likelihood of interference during insertion and removal. And it is more advantageous in splinting cases. Therefore, the best choice for two implant prosthesis would naturally be to use non-hex abutments. However, the main concern arises when abutment removal is necessary for repairs, as repositioning the abutment can be challenging. For this reason, it is important to keep jig on hand or provided to the patient for safekeeping, although this also doesn't always work out well. As a practical compromise, I often use a combination of non-hex and hex abutments or opt for hex-hex combination in two implant cases. When using hex abutments, it is essential to first check on the model whether the abutment crown assembly can be removed and reinserted. If the complex is removed in the oral cavity for any reason, I separate the components and reconnect the abutment first, and then reattach the crown intraorally. When using hex combinations, the importance lies in the implant path. So it's essential to ensure proper alignment and positioning by using a surgical guide. As mentioned earlier, the biggest concern with non-hex abutment is the need to store the jig. However, when creating the jig digitally, the design file can be stored, eliminating the need to keep a physical jig. However, when the jig is needed, it cannot be used immediately. It requires time for printing and might be prepared for next appointment. But this can also be considered an advantage. Next is related to positioning jig. The common practice is to rely on the jig to transfer abutment from model to mouth. However, there's possibility of errors occurring when fitting hex abutments according to jig. Also, even if there are discrepancies between the model and the mouth, these might not be detected by the positioning jig, giving false impression that everything fits correctly. This issue arises due to physical properties of the resin used to create the jig. As mentioned earlier, if jig is not sufficiently thick, it is more prone to deformation, making it difficult to detect errors. Therefore, when creating a jig, it is important to ensure that it is not loose, has adequate thickness, matches the upper and marginal areas of the abutment, making it easier to identify any discrepancies when placing the abutment. In a previous case, an error occurred during the patient's first visit. To resolve the issue more conveniently, the jig was cut and modified. The new pickup impression was taken to create a new model. However, the jig itself lacked sufficient strength. Another error occurred. Ultimately, the most reliable approach was to take an impression of the abutment, align it with a prefabricated abutment scan, and this highlights one of the greatest advantages of digital methods. When trying in hex abutment, rather than tightening it while connected to the jig, I first mark the abutment and jig on the model, and then try in the abutment, attach the jig to the abutment, check for discrepancies, and with the jig on, tighten the screw. The most important aspect of abutment placement is to verify with radiographs so that there are no gaps between abutment and the top of implant, and that there is a space between abutment screw and implant base. Even though it might be difficult to see on the radiograph, it's essential to check that there isn't a large gap between the bottom of the abutment and implant. Next is related to soft tissue. Even with a well-made abutment, if the tissue is thick, there can be resistance upon try-in. Especially if the position is not ideal, the contour needs to be adjusted through the custom abutment. The resistance of tissue can become more significant. This resistance can interfere with the proper seating. Most studies on abutment contour are related to marginal bone loss, which is different from soft tissue resistance, but I believe they're ultimately connected as both aim to reduce tissue resistance. Just like Gatapucho's research and a study by Yonsei University, between 0 to 2 millimeters, designing an abutment with a smaller profile angle at 0 to 2 millimeter distance from implant abutment interface and larger profile angle beyond 2 millimeters is beneficial in preventing marginal bone loss. And setting the mesial profile angle to less than 30 degrees and distal profile angle to less than 20 degrees could help. So in the abutment case, I previously showed the implant was positioned lingually, which required abutment shape to be contoured. In the case on the top part, the placement depth was about 2 millimeters, and the profile angle was well over 30 degrees at the 1 to 2 millimeter region, causing bleaching. In such cases, it is difficult to ensure that the abutment has been accurately seated, particularly in terms of its vertical position. Therefore, after connecting the abutment, I have the patient lie on a cotton roll and wait for about 10 minutes. If I suspect that the hex part is not properly engaged, I remove the abutment and reconnect it, and then proceed with the usual process. If I believe hex part is well seated, I simply retighten the abutment and connect the prosthesis. For this case, I plan to monitor the patient during follow-up to ensure that there are no issues with the gingiva. One consideration during the impression stage is that if a larger abutment diameter than the healing abutment is used, it might be beneficial to replace the healing abutment and wait and use the appropriate impression coping for reducing tissue resistance. Traditional impression coping or scan healing abutments can be used. Something that is largely overlooked is dust of abutment and screw. When receiving fabricated abutment, it often has a leftover dust, so it is important to clean the abutment and screw thoroughly before placing them intraorally. Once abutment is tried in, the final step is bonding the crown. Depending on the retention method, the crown can be screw retained, cement retained, or screw cement retained. At Osstem, the ER type of restoration can be considered. During intraoral fitting, it is ideal for the crown to fit passively without any errors from the lab stage or excessive contact at the proximal surfaces. However, if that is not so, the abutment may twist upon insertion. Even if the prosthesis can be fitted and screw tightened, early contact may occur internally, leading to stress and deformation. This is particularly concerning with screw-retained prosthesis, as there is no compensatory mechanism like cement space. Therefore, if necessary, it may be important to adjust the proximal surfaces of adjacent teeth. It is crucial to inform the patient in advance that this may be required. Important consideration in ER type is that once the crown is cemented, any subsequent removal or reattachment of prosthesis must be performed as in screw-retained type. If the abutment seating direction due to implant's placement angle significantly differs from the cementation direction of the crown's upper structure, initial cementation of the prosthesis may be possible, but future removal and reattachment could become difficult. When cementing the abutment and crown, early internal contact may occur in certain areas as shown. The graph on the right depicts an experiment measuring the strain on implants when using cement-retained prosthesis with proper internal adjustments with one with only minimal adjustment and screw-retained prosthesis. The results show that cement-retained prosthesis without proper internal adjustment exhibited larger strain than a screw-retained prosthesis. This indicates that simply using cement-retained type does not necessarily guarantee a more passive fit compared to a screw-retained type, but therefore proper internal adjustment must be performed before cementing the prosthesis. In the case of splint crown, we need to look at the path. There can be complications, as mentioned. Upon surgery, you need to use a surgical guide, or upon prosthetic phase, you need to use non-hex abutment. And if necessary, it might be better to consider fabricating them as single units instead of splinting. If the crown abutment complex needs to be connected intraorally, it is important to consider that alternating tightening of screws can cause less strain compared to tightening them by one. This should be taken into account. Lastly, I'd like to briefly mention cementless prosthesis before concluding. In the past, due to casting process, there were significant errors during the lab stages, so this was not recommended unless there were issues with interocclusal space. However, with the advent of CAD/CAM technology, the error during the lab stage has been greatly reduced, and as biological issues related to cement residue have become more prominent, interest in cementless prosthesis have grown significantly. The right side was not made with screw type in mind. In the case of prosthesis using tie base, the left shows cementless option. This is the ER system developed by Osstem. This is two transmucosal system, and linked components are added. I think these are most prominent cementless prosthesis options. In the case of prosthesis using tie base, the abutment and crown are typically cemented as one unit outside the mouth and then connected intraorally. This can be used for upper anteriors, and this can also be used in the posterior region. According to 2023 ITI consensus, although the report is based on short-term one-year follow-up, the survival rate of this restoration method is comparable to other types of restorations. It was also emphasized that proper treatment planning, including the precise implant positioning through digital means, is necessary. In Korea, rather than the use of tie-base prosthesis is less common compared to transmucosal abutments like MUA. Osstem has also developed its own cementless prosthesis system, and the biggest difference is that the screw does not come in direct contact with zirconia, and wear of screw and film has been reduced. I have not had the opportunity to use it directly, but I am closely keeping an eye. The final prosthesis is connected extraorally and is then delivered If the implant direction is not correct, then we will not be able to get passive fit. According to the findings presented at 2022 EAO, although discussion was based on tie-based fabrication, it was emphasized that position and access of implant are crucial. I think in light of it, surgical guides can be of significant help. This is a summary. Check a connection of impression components and analog. We need to look at the radiograph, so we need to also consider hex, non-hex, as well as compatibility issues. Clinicians need to reduce error in different stages, and the best way to do it is to do recall check and retightening. And upon surgery, we need to get the right implant position. We need to use the surgical guide. This is the end of my lecture. Thank you. Professor Pang, thank you for the wonderful lecture. So we were able to look at the passive fit and components in the lecture. Q&A will be held with the two lecturers on stage.
Next speaker, from Duty Dental Clinic, we are going to invite Jong-Hyun Park. And he's going to share his experience. He's going to talk about TSIII. I'm learning more and more how to use it. Dr. Park, please come to the stage. Good afternoon. I am Dr. Jong-Hyun Park. Thank you very much, Osstem Implant, for inviting me. To reduce complications, understand correct way to use product is very important. Using digital, we can reach the objective more quickly and accurately. I'm going to share my 14 years of experience of using TSIII, the main product of Osstem. According to literature, the distance from gingival margin to implant top should be at least 3 millimeters. And my preferred distance is 4 to 6 millimeters. This is my mother's case. Implant was placed in 2006. The horizontal space was only 2.1, but the placement depth was okay. So it was my first implant placement as a resident, and 18 years later, the oral hygiene is not very good, but it is stable. And I believe it is thanks to the appropriate implant depth for the long-term maintenance. My father's case, regrettably, the implant depth was not proper, failing to get passive fit. And the screw-type prosthesis was used, and passive fit was not achieved. If I did not use a longer implant, and if I used the ER type and secured the passive fit, I don't think I had to remove the implants. So I believe implant complications is largely associated with the implant depth. And so 2 implants were removed and replaced, and the final prosthesis was delivered, and only U.S. implants survived 17 years later. Number 14 implant had a proper placement depth and a new start. This is when placement depth cannot be easily secured with insufficient residual bone and gingival thickness, like in the upper posterior region. One casket was used to do hydraulic lift and alloplast QOS plus bone graft. The residual bone was only 3 millimeters, but using digital guide, a flapless procedure was done. With only 3 millimeters of residual bone, the depth was determined with the idea that even with 1 millimeter of bone, securing enough placement, the depth is important. Residual bone was 1 millimeters. This scanner was used for using one-step prosthesis, final prosthesis 5 years later. In the sinus, the bone formed pretty well. If you try to use the whole residual bone, implant placement depth can be insufficient, and it will lead to biological problem. If the tissue level implant, SS implant placement was discussed by Dr. Im this morning, and I agree with him. Let's go to another case. If 7 millimeter long implant was selected, implanted depth would become insufficient. Then inferior alveolar nerve would be a concern. I selected 6 millimeter implant, and that was a very good choice. So if you use not too long implant, it will become easier. A buccal residual bone. This is very important for implant placement. Using OneGuide, a proper place implant placement was performed. Bone grafting was done. If a smaller diameter implant was used, it would have been better for a bone graft. Final prosthesis was completed. 5-year follow-up. The volume is maintained according to the CT. 5 years later, it looks good, but the graft material is not remodeled. It just remains. When the environment becomes worse, the foreign body reaction may create inflammation. What if it was placed deeper and smaller implant in diameter was used to lower the need for bone graft? Crescent bone quality can be better if a smaller diameter implant is used, but there are some limits in terms of diameter and the placement depth. If you have any questions, I will address it during Q&A session with the prepared slides in advance. The second case, at another clinic, the patient had teeth removed. Diameter 4.5 millimeter and 8.5 millimeter long implant was placed. Compared to case 1, a smaller diameter implant was used. Enough space is available in the bone envelope. Bone formation is facilitated compared to the previous case. CT after 4 months, proper bone structured with sponge bone that can remodel and cortical bone is observed. A small amount of autogenous bone graft was performed, so the bone volume looks better than the previous case, but the patient does not want posterior aesthetics by paying money and time. Good quality buccal bone, if not sufficient in volume, is obtained. I believe quality of crestal bone is more important than quantity. Next case. Number 36 requires bone graft. Ridge split is not a must, but within the bone envelope, if implant can be placed there, it would be better compared to simple bone graft. At the extra bony class 2 volume defect, bone graft was done. And this is the bone graft just for volume increase. Final prosthesis. 6 years later. Crystal bone quality is very important. I like even with additional bone graft, when implant crystal bone is surrounded by autogenous bone, I like it very much. The similar case, the bone width is narrow. OneGuide was used for the narrow ridge. The envelope was increased using ridge split. At the buccal side, using allograft, alloplast and collagen membrane, additional bone graft was performed. Final prosthesis 4 years later with minimal residual bone for function is observed. Ridge split is very helpful to increase the envelope at very narrow width of bone. Next, external forms of abutments and prosthesis. How to design gingiva contact shape. Subgingival contour can easily avoid bone interference, and concave form is good to secure gingival space. Critical contour is the space 1 millimeter below the gingiva margin. It is for emergence profile of crown that goes above gingiva. It starts at the inflection point and transitions to convex form. When the inflection point is 1 millimeter subgingiva, it is good. If this is an immediate placement case, the implant was placed deep, and if the abutment color is 5 millimeter or more, it starts as straight line and with a small angle from the implant top and becomes concave and form the convex from. So this is the shape of the abutment. Okay, and the abutment starts as a straight line from the implant and plaque and the various problems can occur. If the prosthesis over the marginal gingival margin is concave, good food retention and plaque can easily accumulate. The plaque can cause gingival and periodontal inflammations. The form poses challenges for patients to clean. At the buccolingual and the mesiodistal proper position, an implant was placed. At the proper position, a buccolingually balanced prosthesis can be fabricated. At the cervical area, the diameter of tooth and implant is different. The implant body diameter is small and the abutment diameter gets smaller. The crown starts small, that starts at the margin of implant, and the convex crown that gradually gets wider is natural as it reduces the maximum contour area. After extracting number 26 residual root, immediate implant placement was done. Plateau septal bone was thick and hard, so using trephine burr, it was reduced, followed by drilling. It was buccally placed, and to compensate the buccal placement, 0.5 millimeter was compensated at the palatal side of abutment. The functional cusp size was reduced, and palatal crown's maximum contour was minimized. If the placement position is not ideal, I focus on a part of crown rather than compensating focusing on one area. The harmonious result would be better. The embracer may seem a little big, but I believe implant prosthesis embracer should be bigger than natural tooth to look natural. Upper and lower implant crown profiles are not right due to the edge bite of 25 and 27. The horizontal overjet is efficient. For number 25 to 27 bridge, ceramic buildup was used to secure the horizontal overjet. Over contour of buccal side of number 36 and 37, that portion was cut down. Upper and lower implant crown profiles are right. So the patient complained discomfort due to non-chewing. So compared to number 24, the occlusal table is small, so it was made again. If a non-functional cusp, the occlusal size is reduced, the chewing of tongue or cheek can occur. So the patient complained of the itchy gum after the delivery of prosthesis when implant prosthesis was done at another clinic. But if you look at the prosthesis, it is not favorable to soft tissue. And on the X-ray, there's no resorption of the marginal bone around the implant. 1 year later, the soft tissue is stable and there's no patient discomfort. Abutment and prosthesis appearance affect soft tissue stability. 2 years after prosthesis, the discomfort was not there. The pontic base was pressing down. And even though the patient does not complain of discomfort, we cannot leave it like that. The prosthesis was removed and the embracer was opened up. Abutment diameter was reduced. The pontic base pressure was reduced. And after 3 years and 4 months, the soft tissue is much more stable. Residual cement can have big impact. Minimizing the effect is very important. First, you need to use a very small amount. Then you can resolve a lot of troubles with the residual cement. MS implants were used, and the cementation type prosthesis were made. The demerit of a cementation type prosthesis is it cannot be removed to remove residual cement. Forming a vent hole can reduce the cement to flow into the gingival margin. Anterior region implant case. I did my best in the mouth, but I had to remove the prosthesis. And you can see residual cement after the removal. The best way for cement control is to use the ER type. Implants can be placed and removed to remove the cement remaining outside the mouth. So distal guide can be very helpful. The patient was on osteoporosis injection for 2 years. Minimally invasive surgery was done, and on the virtual CJ, the margin was set and embracer was created. And this is to minimize the impact of cement. At 1 year checkup, it was found that soft tissue grew up. If abutment area that goes through the gingiva is small, soft tissue can grow up. If you think supragingival margin prosthesis may have a too big embracer leading to patient complaint, ask the question and I will answer with the prepared slides during Q&A. If patients have insufficient attached gingiva and many systemic diseases, complicated procedures are required, burdensome, and they also often have a history of periodontal disease. The first priority is survival. FGG can be helpful, but you need to explain to the patient that the prosthesis should be made for easy oral cleaning. When attached gingiva is insufficient to get soft tissue sealing, FGG is helpful. More importantly, proper placement depth and small diameter abutment, supragingival margin tightening to remove abutment mobility can work. But the FGG is a better strategy or choice. I learned that sanitary pontic does not give huge discomfort to patients than thought. The retained food cannot easily be removed on its own, and inflammations, if there's inflammations, the patients would experience discomfort. If I prefer to give the prosthetic form favorable for active oral cleaning to patients who are old or with multiple systemic diseases. The bone width is very narrow. Only 5 millimeters of the width can be used. Ridge split was performed, bone grafting was added, and the final prosthesis was completed. The CT image right after bone grafting. Final prosthesis 2 years after, 6 years after. If you look at here, the reason such a space is created in the graft material is because blood is supplied only up to the area. The graft material is just left behind. If the environment worsens, it may appear as a foreign body and cause inflammation. If bone graft is better done, it's a good choice for us. But if it has very regrettable results, so it would be a problem. So shorter implant, smaller diameter implant can be placed deeper, then it's not a bad idea. Let's look at another case, a very good bone width. The bone width is very narrow. Linguocortical bone was thick, so usually when implant is placed, it's buccally positioned. The ridge was made flat and ridge split was done, bone grafting done. On the day of surgery, the volume definitely grew. Final prosthesis. 6 years later, it is maintained stably. Looking back on the case now, placement depth should have been increased and implanted diameter should have been smaller. Then good results would be achieved. All consumers do not want to buy Porsche. Very expensive. Many grandeur customers would be satisfied, and it depends on how the car would be managed. 6 years later, the CT shows very stable volume. But recently, I learned that not all patients want the volume in the posterior region by spending money and time. Poor choice of placement position often requires bone grafting. Minimizing bone grafting is to reduce the implant complications. Appropriate placement position reduces the need for bone graft. Flapless placement was chosen after replacement during drilling. Autogenous bone was harvested and the gap filling was performed. So when it is buccally placed rather than bone grafting, modifying placement position would help. Final prosthesis and appropriate buccal bone remains, and using OneGuide, the bone graft need can be reduced. My my preferred case, older patient, not much money. The bone width is narrow, flapless implant placement. The patient had attached gingiva, not very sufficient. The history of periodontal disease and poor oral hygiene. The treatment was focused on less discomfort and survival of the patient by fabricating prosthesis for easy cleaning. I realized the patient struggled just for 10-minute surgery. So 2 months later, after delivery of prosthesis, it looks very clean, and not all of you would agree, but that this was a very good choice, I believe. On the severe bone loss at number 47, but as in the lower number 7, the buccal cortical bone is often thick. Often with sufficient weighting, the condition changes favorable for implant placement. Implant was placed by paying attention to the inferior alveolar nerve. Final prosthesis, 2-year recall photo. Bone grafting was not done, so crown implant ratio is poor. However, the excellent connection was obtained with the abutment, and through regular retightening, the screw preload was secured. So I believe remodeling implants would prefer to come in contact with the natural remodeled bone rather than bone graft. So crown implant ratio rather than the ratio. Good quality crested bone, a stable implant abutment connection is more important. So enough weighting can create that kind of environment. CT was taken at another clinic, and the patient was concerned about bone grafting, so took the picture using a cell phone 4 months after extraction. So, but the bone was sufficiently formed. Without bone grafting, final prostheses were completed. On the buccal cortical bone, if the bone is preserved, I believe I believed the bone could be formed, so flapless surgery was done. So after panorama film taking, the implant was placed 1 millimeter deeper. So if you wait, if you create an environment where bone can be regenerated without bone grafting, you can create the environment. So for long-term maintenance of implant, it is very important to create a crystal bone. If a patient doesn't pursue aesthetics too much, you can use just available bone, fitting, choosing the size of implant, fitting the width of bone. But it's not true that we can do implant surgery in all cases without bone graft. After the placement, the residual bone was too little, so bone grafting was done using allograft and xenograft. And so sometimes we have to do bone grafting, final prosthesis. Due to periodontal disease, bone loss is severe and waiting would not work. And between 3 to 6 weeks after controlling inflammation, I prefer to do early bone grafting using the healing potential of the extraction socket. Bone is formed and the 7-year recall photo. Sometimes active intervention is needed. Number 35 and 37, severe bone loss. After extracting number 35, 6 weeks later, bone grafting was done, and 6 months later, bone implants were placed. Number 35, there's a severe buccal bone loss. So without the bone grafting, it would not work. So it is not an easy choice to place an implant without the bone grafting. This is CT after 4 years. It is maintained properly. Number 37, severe bone loss. But if you wait 1.5 years to 2 years, the buccal bone is thick, so recovery can be achieved. But waiting for long is not easy. So bone grafting was done at 6 months and waited for 6 more months. Host bone contact is very important. This is the final prosthesis. Digital scanning has been introduced to dental clinics, and only connection, 2 connection movement is needed, reducing the chances of error. Clinical case, the second premolar fractured. Immediate placement was planned, and immediately implant was placed after extraction. 3 months later, digital scanning was used to design abutment and crown. So there's a sign that bone loss can occur because of the mismatch. And residual cement would have an impact too. Implant done in 2013. The soft tissue sealing looks not stable, and you can see the unstable situation in the X-ray of the root. Bone loss is about to happen. A screw loosening happened. So preload of the screw became stable, and the stability continued 8 years. So maintaining the preload is very important. There's a pseudocyst that you can ignore, but if the structure is not familiar one, we can do the palatal flap thinning to create a space. Bone grafting was done, and resorbable membrane was used. CT sections after placement and grafting. 2 years later, intraoral photo and the root. And the bone is formed in the sinus. the bone quality is very important over amount. I prefer to use with the short implants and when pseudocyst exists. We cannot control human body functions. We need to follow the natural course of human body function. If you use a 6 millimeter small short implant, you may wonder at the loading time. If you ask the question, I will answer that during Q&A session. Bone is lost, and we waited 2 months, and if we place implant in the envelope where healing potential is present, bone grafting would not be necessary. Prosthesis was completed. 5.3 millimeter gap will be filled with a new bone. Sometimes we need to pursue the understanding of soft tissue and hard tissue and minimally invasive treatment. Thank you for your listening.
I can see that you have a lot of interest towards TSIII. Thank you for sharing with us. So when I treat my family, I think my son is toughest and my parents are the second toughest. My wife is a very good patient. She has expressed no pain and she has been using for over 20 years, and I thought that that was normal. And so I can see that you went through a lot of hardship. So now we will have a Q&A session. We're limited in time, so we're going to entertain Q&A for 10 minutes. We'll receive questions from the floor. Professor Jong. I have a question to Professor Pang. I think mechanically it's quite challenging. Screw an internal fit. It's quite difficult for me. My question is, scan body and then quoted the healing abutment actual value and the library value. If it's different, how can we minimize the discrepancy? You talked about cement type and screw type, and do you prefer screw type? Thank you for the question. As for the second question, which I prefer, screw type and cement type. Still, clinically, I prefer ER type. If not, because of screw hole position, I tend to use a cement type. As for the first question, I tried to measure my presentation and I wanted to shorten my lecture because of time constraint, and I want to share with you a slide that I prepared. So when you do measurement, the actual value and library value discrepancy can occur. So what you can do is two options. You either use a new one, or at times you may need to adjust the library. So I'm sure there are many gurus that know more than me, and I'm not sure what I'm doing is perfect, but in my case, If I were to use it, I would use Trios as basis library file in order to. I would correct it. There are many ways to correct it, and the way that I've learned is that I use a free tool, Missile, and I use that. I pull the file and look at the different values, save it, and use it in the library. Excuse me. You can try this, or if there is discrepancy throughout. I do doubt whether it will be effective. If there is a small discrepancy, like 30 microns, I did try. And on merging in the program, I did get better result. If you want to make alterations, you can try this method. I think it's also possible in ExoCAD. If there is significant wear or major discrepancy, then I think you should use a new one. Thank you. Is there more question? Please raise your hand. So
Thank
I have
you.
2 questions.
2 questions to Dr. Park. Non-hex implants are used. Usually, we use a hex type, so why do you use non-hex type? The supramargin. So 4 implants were placed according to the abstract. I didn't see the opposing teeth. If you place more than 3 implants, the perimplantitis tend to occur in the middle implants, and the path of 4 implants didn't look parallel. Can you skip one of them? And ready-made abutment was used. How did you overcome the disadvantage? First, regarding implant diameter. So I was thinking about the implant problems in terms of that. Can I open my slide? Please open my slide. Concern for fractures. So I've used one-body implants, external tissue level implant, KS, TS implants, and non-hex implants. The smaller diameter implants can prevent the fractures too. Non-hex implants are used to prevent implant body fractures. And if you look at the abstract, there is a prosthetic example. So they were splinted 2 and 2. So I don't think there's any stress problem. And the ready-made abutments were used because that can reduce the number of visits of patients. And the ready-made abutments, the patient is an 85-year-old patient. For the rest of his life, I don't think they will create any problem to the implants. Just one more question can be entertained. Professor Chung. Thank you, Dr. Park. So I agree with you when you said we need to recreate what God has made. And many implant prostheses look like a zirconia block. Whatever method we may use, the back to the basic is very important. We need to follow the course of nature. The last prosthesis should be made for easy cleaning, and supragingival approach sounds really reasonable. It makes sense. Emergence profile and embracer need to be made properly. I agree with you. Why did you use gold for your mother and zirconia for your father? My mother's implant was done in 2006 when gold was not expensive, but my father did my father's case when gold was expensive and I couldn't get the money back from him. So I believe my father is watching this. But still, you have to use I believe you have to use the same gold for both of your parents. So let's conclude the Q&A session. So Professor Chung and Professor Kim are the winners of the lucky draw gifts. Congratulations.
So I am Kim Myung-nae, and I enjoyed your lectures. I think this question falls under your the latter lecture, and so your dad lost implant. So splint and separate implants. I think there are differences. Splint was done, and if the splint is long, then there can be issue with cleansing. If you do over 3 units, then is it more favorable to do single or 2 units and 1? I want to ask a question about the combination, and the second is the contact loosening occurs because of natural tooth movement, and in order to maintain it or to restore it, do you have any special idea? So I think that will be very good help to prosthodontists.
Okay, 3 were missing, and placing 2 or 3 is always a struggle. I usually place the 3 because I'm practicing. Rather than splitting all 3, I make 2 segments, 2 and 1, and implant contact is very hard to adjust, so it takes a lot of time. All singles would be better, but I need to save time, so I use 2 in 1 segment and 1 individual. I use inlay resin and amalgam, but if problem occurs, we need to remove the prosthesis, and I add the porcelain. That's the best way. So we used to take impressions again, but inlay permit material can be used, and the lab technicians use that very well. So contact adding is in many cases provided for free. So I use only those labs. So I will give you a gift to Dr. Myung-nae Kim, who asked a very good question as chair of this session. Dr. Bang and Dr. Park, thank you for your good lectures.
Thank you. Let's give another round of applause to Dr. Se-Ung Park for serving as the chair of the third session. We will be conducting those who were selected for the best online questions individually. Now, as we close the third session, let's move on to announce the winners of login viewing event. We're about to draw 600 lucky winners for coffee coupons. Congratulations, and please check the announcement board on dental website for more details. The coffee coupons will be sent via SMS to the winners. We will now begin a break. From 3:10, we will start the fourth session featuring live surgery by Dr. Young Lee-sun. Please look forward to it, and we'll see you shortly. Thank you.
Canada. I'm from Switzerland, Bern. From Hungary.
Norway.
Hi, from Italy.
来自저 광동, 중국 광동에서 왔습니다.
네.
지금 녹화되는 거예요?
네.
아, 네. 大家 say hello 하마, 大家好, 안녕하세요. 저희 오스템 본사 참관하고요. 여기 안에 뭐 제품 라인업도 좀 보고, 그리고 치과도 오스템 치과도 구경하러 왔습니다. 많이 배우러 왔습니다.
까지 저희가 설명을 원활하게 전달하기 위해서 제공해드리고 있는 투어용 리시버고요. 영어 통역사를 이제 별도로 구인을 하거나 아니면 법인 현지에서 나오셔서 현지어 통역을 진행을 하고 계십니다.
This is our product exhibition hall where you can find 10,000 types of goods and products at Osstem South.
Первый вид, он как бы по этажам делает.
Та бүхэн одоо ингэ харах юм бол энийг бүр нүдээр харахад ч хэцүү юм, маш жижигхэн юм holding system юм.
I think deeper connection will be better. In my clinic in Dental Ville in Toronto, I'm used regular, but now I think I will intend to buy one with deeper connection to prevent any complication. So it's a really good product, looks.
square meter model dental clinic. Osstem implant also engages in dental specific interior design, having designed interior for over 1,000 dental clinics to date in Korea. We operate our own furniture factory, so every interior you see here can be completed in just a week.
Orada klinikler kendi içinde de laboratuvar ve teknisyen barındırıyorlar ve kendi işlerini kendileri çözüyorlar, yani yerinde çözüyorlar. Bizden en temel farkı bu.
У меня тоже есть клиника, но в другом виде. Очень понравилось мне. Очень классная клиника.
You see the screen over there, and the green screen is chromatic.
Очень отлично, все круто, все на высоком уровне.
我们通过关注奥斯泰 Dental 公众号，它会有定期的推送，我都很留意，有时间我都会看，植入到他们的公司平时的这种运营和宣传当中去，我觉得是一种非常好的手段。
1、2、3，看我地头。
Больше в нем уверен, что он хорошо будет работать с пациентом и очень много времени будет жить в пациента во рту.
Good, Osstem, we love you.
Introducing the ultra-wide implant. Ultra-wide implants are perfect when placing an implant immediately upon extraction of a molar. Ultra-wide implants with a diameter of 6.0 and 7.0 can be placed immediately without GBR in a socket where a molar has been extracted. Also, 6.0 and 7.0 ultra-wide implants are easy to place without having to wait for an extraction site to heal after the removal of a failed implant with a 5.0 diameter. Try the ultra-wide implant for immediate molar implant placements. Introducing Magic Align. A digital clear aligners can be corrected accurately and conveniently, crowding, space, and deep bite, which are various encountered in clinical. Magic Align can be corrected maximum 5 mm crowding cases within about 10 months using less than 20 step aligners. And maximum 4 mm of space case can be corrected within about 5 months using less than 10 step aligners. Also, maximum 4 mm of deep bite case can be corrected within 10 months using less than 20 step aligners. And maximum 2 mm of open bite case can be corrected within 5 months using less than 10 step aligners. Anterior cross-bite cases of less than 2 mm can be corrected within about 3 months with less than 5 steps. Protrusion cases of about 4 mm can be corrected within about 10 months with less than 20 steps. Magic Align uses magic foil, an excellent elastic 3-layer composite material. Therefore, more than 15% better orthodontic retention than the 1-layer material and less deformation due to aligners from put on and take off. So, effective orthodontic treatment is possible. Effective orthodontic treatment is possible due to less deformation of the aligners from put on and take off. In addition, The magical line is trimmed based on the patient's unique gingival line without covering the gums, so the patient can put on easily and accurately at once. Magic Align provides diagnostic analysis files and 3D setup simulations to help establish accurate treatment plans. In addition, orthodontic treatment can be carried out according to the initial treatment plan by applying the Magic Setup system that checks and supplements the teeth movement every 12 weeks. Start orthodontic treatment with Magic Align that can correct various orthodontic cases accurately and conveniently.
네, 이번 순서는 오스템 미팅의 하이라이트 순서죠.
This is the highlight of Osstem meeting. Now it's Osstem live surgery. We're going to now proceed the second live surgery by Dr. Son Young-hee. Let me introduce the Professor Kwon Dae-gun. He has graduated from Gyeongbuk National University and he has residency training at Gyeongbuk National University, and he is a visiting researcher at oral maxillofacial surgery at University of Illinois Chicago, and he's Professor School of Dentistry at Gyeongbuk National University. Please welcome Professor Kwon. Nice to meet you. Today is Sunday, and I'm honored to be in the presence of so many. So if you do surgery alone, you can do a better job. But when you do surgery, live surgery, in front of many people, then it requires a lot of expertise and technique. Dr. Son is going to remove the existing implant in the upper and place implant and do GBR. So I would appreciate Dr. Son, and let's look at Dr. Son's video clip first. Greetings, this is Dr. Son Young-hee of Ijun Dental Clinic. I'd like to begin the preview for the live surgery at Osstem meeting 2024. The patient will be operating today is a 71-year-old female. Her chief complaint is dissatisfaction with the current prosthesis in the upper anterior region where she has implant and temporary prosthesis. She also reports an unpleasant odor. Her past medical history is unremarkable. Currently, implants are placed in 11, 13, and 21, and temporary prosthesis are in place. Additionally, there is a temporary ponic at number 23 with a residual root. Looking at the panoramic X-ray, 3 implants are visible in the upper anterior region, and 2 of these implants have abutments attached, which seem to support the temporary prosthesis. At number 23, there is a residual root present. In the CT view, the implant at 13 appears to have either migrated buccally or experienced buccal bone loss, leading to labial exposure of the implant. At 12, significant bone atrophy is evident. At number 11, the implant slightly engages incisive canal palatally, but there is labial bone loss. Similarly, the implant at number 21 is placed labially without engaging the incisive canal, and buccal labial bone loss is present. The ridge at number 22, though slightly lower than it's slightly more bulkier than number 12, but the ridge form is not ideal for implant placement. At number 23, there is apical perforation with the residual root fragments visible. In the intraoral photos, the 6 anterior temporary prosthesis is set, and there's evidence of multiple repairs. For this surgery, I first performed intraoral scan and CT imaging was done. Using these as a base, we developed a treatment plan. I decided to use a OneGuide system to place implants digitally. The original plan was to immediately place 2 temporary prostheses using 2 implants, but this seems challenging given the situation. The implant placement plan is as shown. At number 13, I plan to place a KS 3.5 by 13 millimeter implant, and to place a deeper implant placement 3.5 by 11.5 implant. It was changed to that implant to place the implant more deeply. At number 11, due to narrow bone housing, the plan was to place TSIII 3 by 10 millimeter implant is planned. At number 23, after extracting the residual root, the original plan was to place a KS 3 by 10 millimeter implant, but it was changed to KS 3.5 by 10 millimeter implant. For number 12 and 22, I consider placing MS 2.0 by 10 millimeter implants, but the ridge is too compromised to allow for implant placement. The decision was made not to provide temporary prosthesis during this live surgery. As you can see, it is extremely difficult to accurately position the implants within bone housing, and there is concern for additional bone loss. For number 11 and 22, the plan is not to place implants. The treatment plan is as follows. The plan is to remove implants at 11, 13, and 21 using the Osstem EIR kit. To extract the residual root in number 23, KS 3 by 10, in number 11, 3.5 by 11 at 13, KS 3.5 by 10 millimeter at 23, all with BA surfaces. Following implant placement, I'll perform GBR using xenograft bone graft material and AOS culture to address the lost labial bone. There are 3 main challenges in this case. Achieving parallelism for the implants will be difficult due to the significant labial ridge protrusion. Parallelism is something that can be considered quite difficult. The focus will be on placing implants securely within the bone housing, even if it means sacrificing some parallelism. Due to narrow bone housing, I need to use narrow diameter implants. To ensure greater stability, I'll use KS implant for more robust connection. The initial plan was to provide provisional restoration, but the given situation makes this unfeasible, so I'll proceed with GBR and conclude the surgery. This concludes the preview of the live surgery.
Good afternoon. I am Dr. Son Young-Hui. I'm with the E-Good Dental Clinic. Please open your mouth. So this is removed. EFR kit is used to remove implants. So it is too deep, and I need to raise a flap to remove. Dr. Son, can you hear? So today, residual root at number 23 will be taken out, right? Yes. To reduce time. Last week on this patient, number 23, the residual root was already extracted. Sorry for not giving that information in advance. Dr. Son is raising a flap to remove the implants. So the flap is raised. So implant removal kit did not work, so you're raising the flap. Yes, the implant is placed too deep. So just as shown on the CT image, it is labially placed. I'm so worried about the condition. The bone is seriously resorbed. So how much releasing incision do you make normally? The vertical releasing incision and the periosteum is based on the position of implants. Periosteal releasing incision is going to be made, and that is my usual approach. So there is a lack of labial bone, so you need to raise it quite a lot. So I do not know up to where graft material should be added. The apical point need to be determined first. The anterior nasal spine, up to that point, you need to raise the flap, I believe. Yes. So anterior nasal spine is appearing. And a lot of bone graft needs to be used. At number 13, it is the area where the most implant exposure is made. As you planned before, number 12 and 22, the reach is too narrow. So I think the implants would not be inserted that easily. The flap is elevated to a certain degree. And let me attempt and try to remove the implants again. I can see your agile hand, very skillful. I need to show this to our residents because you are doing it very well. EIR kit cannot be fit in. Just in case, if a fixture driver can fit in, maybe I can use it. Now it's removed. So when the kit doesn't work, you can use the hex driver, mounted driver. That is another way to remove the implants. Minimal alveolar damage can be made. That's how Dr. Son is approaching the case. Number 11. Now it is being removed. This one is placed really deep as well, like before, yes. So if the implant is placed too deep, the removal kit cannot fit in, so this is a very tricky case. If implants are placed too deep like this, when the kit doesn't fit in, what do? I use a trifine drill. 60 to 70% up to the necronal bone. Trifine drill is used to extract. Now it's being removed. Now we have only number 21 left. EIR kit wouldn't fit in, so there's no other way but to use the trifine drill. The smallest trifine drill is to be used to remove it. So there's no buccal bone. So it is pushed to the buccal side. Now the implant is explanted. Now we have the 3 implants all removed. So there's some bleeding. Correct. Usually the granulation tissue, do you remove them all? Yes, I try to cleanly remove them. After that, after removing the granulation tissue, do you give some medication? The granulation tissue that is removed, if I'm not sure if it is all removed, I cut the gauze and clean it up, the socket again. So they're all finished. There's severe fenestration. Are you okay? Does the patient have any systemic disease? No. So as for me to check the granulation tissue inside, I would wipe the socket out. So what we prefer differs from dentist to dentist. So hydrogen peroxide can be used to wipe it out, the remaining granulation tissue inside. The hygienist, is it your hygienist? Yes, I brought all my staff. Oh, they look very skillful. Cortical perforation will be made for wide-ranging GBR. So do you do drilling with the implant motor? Yes. To accelerate the bone regeneration, deliberately, decortication is made for better blood supply. Now it's done. Let me place implants now.
So I'm going to start with number 13. KS3, 3.5 by 10 millimeter. The path drill does not go in fully. Flattening drill is going to be used first. Does it hurt? OneGuide path drill is used. So drilling has been done up to 11 millimeters. So I'm going to use path drill. For number 23, same implant was chosen. Path drilling is done first. For number 13 and 23, preparations are being done. Yes. Number 13. Diameter is 3.5, and for number 23, diameter is 3.5. Number 13 on the right side, the length is 11.5. Both sides are 11.5 millimeters. So drilling is done once. Drilling is complete. Now I'm going to switch to 1MS, number 11, K3, 3 by 10 MS. There's option from 8.5. So 8.5 drilling is done first. Next, to 10 millimeter full length drilling is going to be done. 8.5 is used as initial drill. You need to use shorter one for initial drilling, and then you put in the same length implant, yes. 2.3. It's done. Implants will be placed. KS. Please give me 3.5 by 10 millimeters. When you use guide, in general, it works nicely. At times, there can be slopes in the ridge, and if it slips, so what do you do? Can you repeat? So I lost you. So in this, it's not the same in this case. So sorry for trying to start a conversation. So maybe Osstem can compensate you for that. So I'm not going to start a conversation in critical moments. In these cases, I get mad at my residents. Is bone quality okay? 3.5 by 10 millimeters, please. KS3, 3.5 by 10 millimeters. Primary stability is better than expected. So I'm going to place the second implant. Primary stability, please. At times it can get stuck like this. Hold this, please. Can you close your mouth a little bit? Thank you. .5 by 10. This is the final implant. Be careful. Don't do suction. Primary stability. Please do suction. Primary stability is not excellent. Please adapt it. Primary stability is not as favorable as hoped. It's gonna be a little bit difficult here. Say ah. Please do suction. Close slightly. Please put it back on. Number 23, primary stability is very difficult to get. So I'm going to take a look, and if implant placement is not visible,
Number 23, on the apex side, there's very little bone, yes. So it's more difficult than thought. So implants are placed as shown because of implant. Bleeding is very severe. Say ah. Stay still. Look up, please. We're going to do additional anesthesia. You're going to be fine in just a moment. Does it hurt here? Say ah. There's bone defect and implant positioning was difficult. So please open up. Please give me membrane. I'm going to do GBR for number 23. We're going to do delayed approach. So that was not the intention. So the bone is more limited towards the top. Please close slightly. Is it membrane that you're using? Yes. I'm cutting, trimming it. I'm applying the membrane here. What is the membrane you're using? This is OssGuide from Bioland. Okay, please give me healing. So I'm going to fixate the membrane first. Please give me 2. Are you grafting after fixing the membrane? Yes. Do you always do it like that, or is this case special? In most cases, I fixate the membrane first and then do graft. So do you use a tack? So you fixate the top part? Yes.
Let's do the other side. Done. Please give me another 12 by 20. Thank you. Do suction, please. Please give me healing. So this is a 7mm healing. The height of healing abutment, how do you determine it? When there are complications and place implant, it is placed deeper than normal. So I try to fit it to equigingival line in most cases. It's around 7mm. That'll be considered appropriate. So you're going to utilize a healing abutment, yes. There's complication, so I think there's going to be a lot of resorption, so I'm going to use a xenograft. I'm going to use EOS. Please give me TS healing. So when you choose a bone graft, is there a standard where you utilize which one? Where in the case of upper anterior, because there is a significant remodeling, I try to use xenograft. And in the area where it's in contact with the implant, I try to use allograft. If there's been a complication and if there's continued inflammation, I try to use materials that can resist remodeling. So bone graft, overgraft is going to be done. Please give me healing abutment. So it's a problem here. Is this 7 millimeters? Yes. But it's submerged. Seven millimeters. But because there's no bone, when you do secondary surgery, at times it goes below the gingiva. What do you do with those cases? I try to avoid those situations. But there are situations where that is inevitable. So it's going to be complete here. I'm going to use bone tap. Do you try to fixate the membrane very firmly in order to prevent graft material movement? Yes. So let's move on. Please give me collagen. Are you okay? We're almost done. Please give me another EOS. Extraction socket, and in the site where there's been an implant, the EOS collagen block is cut and used as a graft material. EOS collagen, another one, please. Let's use additional bone tack. Based on your experience, EOS collagen and using xenograft. When you compare it personally, xenograft collagen blocks, I think it has many advantages. And out of curiosity, when I tried a biopsy, in most cases, it shows similar or better results compared with the particulate bone graft material. So I think it is reliable. That's my personal opinion. There's no major difference with particulate bone graft material. Bone tack. Do you remove bone tack upon secondary surgery on the apical side? I don't. On the coronal side, yes. During secondary surgery, yes.
Almost done. Number 23. So additional membrane, one more membrane would be used to cover the site. So there's a membrane used before, so this is just to cover. So this is a very challenging case. Immediate placement or the staged approach. What do you think? If I believe I can get the primary stability, I prefer to use the simultaneous approach. If primary stability cannot be obtained like this, and if maybe staged approach can be better in this case. So you're doing periosteal releasing incision to suture the flap. So you used a lot of bone and healing abutments are used. So the flap would be not enough. So releasing incision is made. Almost done. Now suturing. So you did the decortication. When do you do it and when not? Do you have any guideline? Well, for immediate placement, for socket graft, I don't really use it. If I need to do GBR and if cortical bone is thick and if there's no other blood source, I do it in most cases. The suture 40 nylon suture. Do you always use that suture? Yes, in most cases. Rarely I use 50, but in most cases I use 40. That's my preference. Membrane holding suture is done, but in this case, so many bone tacks are used here. So membrane holding suture is not used. Just that I do the approximation. So after proper suturing, you still can have adhesions. So what do you do for that? I try to avoid the adhesions, but post-operatively, if adhesions is made, I use dressing to resolve the issue. In this case, if non-resorbable membrane is used, there would be a big problem, but collagen membrane is used. And the dressing and the use of antibiotics would resolve the situation. Even with the releasing incision, after suturing, in many cases, they are not closed cleanly, especially when there was inflammation. So if the site is covered with the membrane properly, there'll be no adhesions. But I'm asking the question because the questions arise on the online site. So you did the extraction. Below the extraction site, there may be severe inflammations in one in what such cases do you do immediate placement and whatnot? I try to avoid immediate placement if inflammations has been there for a long time. After bone grafting and implant placement, and if healing pattern is not very good, and if there has been a period disease, severe period disease, then I prefer to use a staged approach. So you are suturing on both ends. Horizontal matrix suture is used, and you are doing interrupted suture. So do you think that helps the approximation? Yes. Vertical matrix is not used, but why are you using horizontal? The vertical matrix helps, but the range of suture is small, so it's not very good for force distribution. So I prefer horizontal matrix. So later, did you experience any perforation at the horizontal matrix suture site? So over it, simple approximation is added. So I asked this question while you were using OneGuide. The patient bone is inclined, so OneGuide is used then. The drill can slip going to wrong direction. What do you do? In the OneGuide tool, the first drill that I used, you will find a path drill. So it has the rectangular end, so it's not slipping that easily. So when OneGuide is used in the extraction socket, OneGuide path drill is used before I move on to the next drilling. In the canine area, the diameter 3.5 millimeter is used as there's no other choice, 3.5 millimeter. If the canine can have a lot of load applied for bridge, what do you think? So I was thinking about that quite a lot. The implants used here are KS implants. It has the connection. Actually, it can withstand very high force load. So implant connection strength is quite large, so that's why I use the implant. Actually, this is the question from the online audience, and thank you for the answer. The entire flap was raised, and that there was anesthesia given because of the pain. Do you inject on the soft tissue? Yes, on the soft tissue. Actually, it's on the soft tissue level. In a site like this, a titanium mesh is available. Do you use a titanium mesh? Yes, I use it. I was thinking about, I considered the use of a titanium mesh, but we are talking about the big range. And titanium mesh cannot be used because the range is quite large. So sausage technique, collagen membrane is used. I totally agree with you. So this size range of implant site, it is hard to use a titanium mesh. So I don't think a titanium mesh can cover all the site here. In the future, if a titanium mesh can be 3D printed and custom made using a 3D printer, then I believe I can apply the titanium mesh 3D printed. You are very agile in suturing. Please open your mouth. Let me check. So after placing the implants, you checked the primary stability using a wrench. Yes. At number 13, the value was around 15 at 11, 60 Newton. And at 23, I failed at the placement. So after consolidation period, after bone is regenerated, I'm going to place an implant there, followed by prosthesis. So after surgery, when do you provide a denture or temporary? Usually on the day of stitch out, I take impression and I provide a flipper to the patient. Custom abutment was considered for provisional, but it is regrettable that I cannot provide the provisional today. After the surgery, you need to compress the flap a little bit like this. So you will have a better result if you compress the site like this. So now the surgery is completed. Thank you. Please give him a big round of applause. Thank you. And I would like to thank the hygienists and the assistants. Thank you. And we will get some questions from the floor. We'll get some questions from the floor. Thank you very much. And I would like to thank Dr. Son for the wonderful surgery. The contact area with implant, can you hear me? Can you hear me? My question first. After implant is placed, there's a lot of exposure. Autogenous bone needs to be used, the first question. And you are very skillful, and it works for you, but in the mouth, a bone tech, when you use a bone techs, throat packing using gauze would be good. I was worried that you would drop something in the throat. You are very skillful, so there's no problem with you, but other dentists may be advised to use throat packing. So the question is, if you don't use autogenous bone, do you have still good long-term result? I totally agree with you. When only xenograft is used for BIC, of course, if you use autogenous bone in the implant contact area, I agree with you. But in terms of contour management, according to the literature, according to many papers, the implant looks surrounded by the fibrous tissues, but they do not really impact the function of implant. I wanted to use autogenous bone and allograft, but due to constraint of time, I just used the xenograft and a collagen membrane. But I agree with you. If situation is favorable, I believe allograft and autogenous bone would bring very good results.
This was a very difficult case. So I'm not as proficient. I have a question. So when you choose implant, you remove the implant. The defect is significant. I don't think I would use a 3.25. And there's very little bone, but actually, this is a fenestration defect. There's no bone on the apex, but there's contour bridge. When you do GBR, you can use, I think you can use a 4.25. And primary stability would be very difficult to get with 3.5. Perhaps I think we can increase the diameter of the implant. Number 23. Wouldn't you use a thicker one or longer one? I think I would have tried, but why didn't you try? The questions, I wholeheartedly agree. The reason I didn't choose a thicker implant is because of peri-implantitis. If it were a problem of peri-implantitis, I would have used a thicker implant and do a contour augmentation. However, in this case, number 13 and 11, existing implants were removed, but the housing was avoided. I wrapped my hand around it, but that position did not allow for 4.0, and because I was placing 3 implants, I tried to get parallelism. I wanted to maintain parallelism. That is why I chose an implant that can be submerged within the housing, and that's why I chose 3.0 and 3.5. If it had 11 common connection, I would not have tried, but it had deep connections, connection stability. Even with narrow implant, stability is similar to that of regular implants. So based on such expectation, I chose narrow implant. As for number 23, if I had more time, I think I would have tried. Because this is live surgery, we need to continuously make quick decisions. I raised the question, and I would not attempt such a case. And I think you did a good job, and that's why I asked. Dr. Song, thank you for the comment. When I looked at it, you weren't sweating, and you were really calm and collected. That was amazing. But I can see you're sweating now. You're receiving questions. Are there more questions? The panoramic image is ready. On the panoramic image, you can see So I think it would have been best if I had placed the implant in number 23. The apex seems punctured when I was doing drilling. Although I did the path drill, the drilling was not done in the desired position. I think I made a mistake, and about 4 to 5 months later, in number 23, I'm going to place the implant perfectly and provide a good prosthesis. We need to take CT to accurately observe the situation, but on panoramic image it looks okay. Looking at this, panoramic image looks very good. I look up to you. Thank you for your hard work. Thank you, Dr. Son, for all your hard efforts. And there's gifts for those who have raised questions. Dr. Kim and Dr. Song, we're going to give you gifts after we end. We're going to close the session now. It was a very difficult case, and thank you, Dr. Son, for demonstrating the successful live surgery, and to Dr. Kwon for serving as session chair. As we conclude the fourth session, we'll take a short break. The fifth session will commence in 4:40. The fifth session will feature a discussion that has gained continued interest. Also, don't miss on the highly anticipated lucky draw where you could win some great prizes. I hope you stay with us. See you shortly. Please return by 4:40.
Have you ever experienced the pressure of reoperation because of prosthetic issues such as screw or abutment fracture? Introduce ESR kit designed to solve a variety of prosthetic issues. In case of screw fracture occurs, the fractured screw can be removed by using ESR kit. Connect the SR drill with the fractured screw. After making a hole for drilling on the fractured screw, turn the SR tip counterclockwise and remove the fractured screw. Also, after using the reverse drill, connect the screw holder on the fractured screw. Then, turn the screw holder counterclockwise to remove the fractured screw. In addition to screw fracture, the ESR kit can be used for removing the fractured abutment, repairing damaged thread of implant and screw hex slip. Try ESR kit designed to solve a variety of prosthetic issues. Have you ever experienced difficulties in finding a right spot for implant placement? Positioning Guide Kit enables clinicians to find both right spot and direction for placing implant without using a surgical stand. Positioning Guide Kit contains both single guides and bridge guides, so clinicians are able to deal with different clinical cases. The single guide is transparent and cylindrical, comes with a diameter of 5 to 10 millimeters. Clinicians are able to put a single guide next to another single guide or close to an adjacent tooth for drilling. The single guide helps clinicians to pinpoint the spot for placement and direction of the implant. The fan-shaped bridge guide enables clinicians to adjust interval from 7 mm up to 12.5 mm. Bridge guide allows clinicians to adjust the interval by the margin of 0.5 mm and to drill toward the same direction as previously drilled site with convenience. Positioning Guide Kit enables clinicians to find both right spot and direction for placing implant without using a surgical stand. Introducing the OneGuide bone anchor and implant anchor, which are used to fix implant guide. The OneGuide bone anchor can be used in cases where it is difficult to anchor a template, such as completely edentulous cases or patients with insufficient remaining teeth. You can also place it vertically in the bone and anchor the template at the position you have planned. The OneGuide implant anchor can be fastened to an implant already placed in the patient's mouth, which helps anchor the template much more easily. If you need to prevent the OneGuide from shaking and secure it in position, try using the OneGuide bone anchor and implant anchor. Great unit chairs designed for dental treatment must be convenient for the clinicians to use, feel comfortable for the patient during treatment, and they should also be easy to clean and maintain. I would like to introduce K5 is both a stylish and convenient unit chair. In case the backrest tilts downwards, the leg rest goes up. The tilting function prevents the patients from slipping down. It is convenient for the clinicians to carry out treatments and provide comfort for the patients to receive treatments. The K5 also has a wireless foot controller designed to offer an even more convenient treatment experience for the clinicians. Handpiece RPM can be easily adjusted by turning the foot pedal left and right, making treatment. The sterile water supply device suppresses formation of bacteria and biofilm in the water line of the unit chair. Always using clean water during treatment makes it much easier to reduce the risk of infections. Let's go over K5's key features again. The patient does not slip downwards thanks to the tilting function. When the backrest tilts downwards, the leg rest goes up. Second, the wireless foot controller makes treatment much more convenient for the clinician. Third, DWCS suppresses bacteria in water line to supply only clean water during treatment. Try the K5, a unit chair designed to add both convenience for the dentist and comfort for the patient. Introducing the SM5, the dental implant surgery engine that provides safe surgery with its accurate torque value and drilling ability. First of all, SM5 provides accurate drilling result thanks to its outstanding chucking force. The implant can be safely placed since the implant is firmly fixed, minimizing unstable vibrations. Moreover, the torque value and rotation speed can be checked with ease on the LCD panel during the surgery. Try the SM5, the surgery engine that has outstanding chucking force and that displays the torque value and rotation speed during surgery. Introducing the upgraded T2 Plus with superior high-resolution imaging, ultra-high-speed scanning, and ultra-low radiation dose feature. The T2 Plus has a 0.05 mm voxel size, which results in superior high-resolution images. This enables a more accurate diagnosis compared to the T2. With a T2 Plus, patient waiting times can be reduced thanks to a faster scanning speeds compared to the T2. Images are acquired in just 30 seconds. T2 Plus low radiation mode allows for safer scanning with only 22% of the radiation dosage compared to that of the T2. The low radiation mode allows scans for children and pregnant women without any concerns. The T2 Plus offers various field of view sizes for facial imaging, implants, TMJ, endodontic procedures, and more. The T2 Plus allows for customized scanning based on the treatment. The T2 Plus includes convenient and easy-to-use OneTwo software, OneThree, and VSET. Through consultation, treatment and implant planning will help increase patient acceptance rates. T2 Plus is available in 3 colors: white, blue, and red. You can choose the color that best matches the ambience of your clinic. Introducing the upgraded T2 Plus with clearer images, shorter scanning times, and lower radiation dose. With X-ray images alone, it can be very difficult to convince patients since X-ray images don't offer a complete picture of their oral health status. Fortunately, today's product can help you with this very problem. It's the Snap intraoral camera. One of the most important things you need to consider when choosing an intraoral camera is image quality. To help the dentist explain the condition of a patient's teeth and set the correct course of treatment, intraoral cameras need to take clear images inside the patient's mouth, even though it's very dark inside the mouth. Snap uses a 1.3 megapixel sensor, unlike other regular intraoral cameras that top out at 300,000 pixels. That's why it delivers clear HD images that can satisfy everyone. Another important thing of an intraoral camera, which has to take images as quickly as possible, is the focus function. Snap focuses in just 0.3 seconds when you press an image-taking button and snaps images automatically, which helps produce clear, in-focus images that accurately show the patient's intraoral condition. Some existing products do have an autofocus function, but they have 2 separate buttons, each for focusing and image-taking. However, Snap has a convenient 2-in-1 button. All you need to do is press the button once to capture fast and in-focus images of the patient's intraoral environment. And finally, an intraoral camera's head and neckline is very important since it has to take images from narrow spaces inside the mouth. Snap has a curved head and slim neckline that gives you a better angle for reaching the teeth when inserting into the mouth, which makes it easier to image not only wisdom teeth that are difficult to shoot, but also female patients and children who have small mouth. From the patient's perspective, this reduces any foreign body sensation and discomfort, while from the dentist's perspective, it reduces stress when imaging the posterior region and makes treatment easier. I was able to actually see which teeth require treatment, and that makes me have trust toward the dentist and left a better impression in my mind. I feel like I want to come back to this dentist in the future, and I'm going to recommend this clinic to my friends and family. Since I saw my teeth with my own eyes, I think I'd be more likely to consent to treatment without hesitating. Intraoral camera Snap helps accurately explain to patients the condition of their oral environment and creates a more credible and trustworthy impression of the dentist in the mind of patients. Introducing Osstem Implants Hysil Plus. Hysil Light Plus is excellent at reproducing fine areas. Hysil Light Plus can reproduce 20 micrometer lines without any tears or distortion. The stone model poured from a Hysil Plus impression produces smooth surfaces and separates cleanly. Thus, the user can fabricate accurate and precise prosthetics. Hysil Plus is highly hydrophilic. Hysil Plus has a short intraoral setting time of 2 minutes and 30 seconds. Hysil Plus offers a sufficient working time of 3 minutes and 50 seconds. Hysil Plus has a high elastic recovery ratio of 96.5% or more. Experience Hysil Plus for accurate and precise impression taking.
We're now opening the final session. Let's calm down a little bit and begin the final session. My husband is also a dentist, and he's also participating online, and after live surgery he felt really amazed, and hats off to all of you here. The final session, before we begin, there's the major lucky draw, which is going to happen just now. 5 lucky participants will receive doll sets, the Lilger doll sets. 3 will receive water pick oral irrigator set, and 1 will win a Dyson vacuum cleaner. Don't miss out on this chance, and the winners will be announced after presentation of merit awards. Now let's move on to the final session of Osstem Meeting 2024 Seoul. The final session will be a panel discussion where 3 speakers will engage in an in-depth dialogue. To begin, let me introduce the moderator of the discussion, Professor Yang Seung-Min from Samsung Medical Center in Seoul. Professor Yang graduated from Seoul National University School of Dentistry and his graduate school. After completing his residency in periodontology department at the same university, he is currently a professor at the Department of Dentistry at Seoul University School. Please welcome him with a warm round of applause.
Good afternoon. I am Professor Yang Seung-Min at Periodontal Department, Seoul National University Hospital. I'm going to chair this session. The live surgery was very exciting. And in line with the live surgery, we have prepared a lot for this discussion. And you will gain a lot of things by listening to this discussion. So year after year, Osstem Meeting is getting popular thanks to the support of many professors and dentists. Thank you. Let me introduce the 3 speakers. So why don't you introduce yourself? Hello. I am Professor Ji-Young Chu, Busan University Dental School, Periodontal Department. I'm Professor Jun-Young Kim, Yonsei University Oral Maxillofacial Surgery. I'm Professor Yoo-Seung Im, Seoul National University School of Dentistry, Prosthodontic Department. As you know, the theme of this meeting is navigating the digital age, minimizing and overcoming dental complications. Based on that, we are going to talk about periimplantitis, overcoming with the digital technology. Before we start, we did a survey among the dentists on the most contributing factor for periimplantitis. If you look at here, if you look at this case, the implantitis, the cause of periimplantitis, that was a survey question. I believe some of you already saw that, and now is for you to think about it. The implant position, prosthesis contour, periodontal treatment, and poor oral hygiene. Let's have a look at the result of the survey. So in the above case, the risk factor of periimplantitis, and more than half of the dentists chose prosthetic contour as the risk factor, followed by implant positions, and that was followed by oral hygiene and the periodontal treatment. So looking at this, not just this case, but in general, Now, what would be the most important factors when it comes to peri-implantitis? That was another question. Unlike from the previous case, implant position was chosen as the most important factor, and followed by oral hygiene. Number 3, prosthetic design, and followed by maintenance care. And patient's systemic condition received the lowest answer. So this is the survey of. This is the result of the survey, and if you look back on what we heard from morning lectures, and then we can think about the peri-implantitis factors, and this is what we are going to talk about. So when we deal with the peri-implantitis, how to diagnose it, and what is the prevalence, and the risk factors of peri-implantitis. When that happens, how can we control that? Lastly, and if we use a guided surgery, what factors need to be considered? So in that order, let's talk about it. As you know, diagnosis. There's a common thing, peri-implantitis and implant mucositis. There is a commonality between those two. Plaque, redness, purulence, or bleeding on probing. That's the common thing between these two. The difference, the unique things between these two, the bone loss or not. So when we diagnose, what is the prevalence of a peri-implantitis? In 2012, EAO had the consensus conference. 10% of implant placement and 20% of patients suffer from peri-implantitis. So over time, more and more patients would show peri-implantitis, so we need to be prepared for that. So that is the information that we have. My question to you is that peri-implantitis patients, do you have many such patients? We have not prepared the data here, but according to many papers, many papers talk about peri-implantitis patients. And when you place implants, how do you control the risk factors? Risk factors of peri-implantitis, patient-related factor, surgical factor, and prosthetic factor. And let's hear from our professors. Dr. Chu, why don't you go first?
Peri-implantitis. The factors that contribute to peri-implantitis. Let me introduce this study and then move on to the study. In this study, 8 factors increase peri-implantitis probability. Let's look at clockwise direction. History with periodontitis. The BOP and over 5 millimeters of pocket depth, and compare with age if there's more bone loss, and if there's periosusceptibility, and SPT supportive periodontal treatment. How often period treatment or checkup is done? If this is not done properly, there's increased risk. The restorative margin and bone, if they're too close, this can cause problems. And prosthetics, if self-cleansing is not possible, and if the fitting is inappropriate, this can lead to peri-implantitis. Among these 8 factors, I think prosthodontic is related to the prosthesis, and it is related to implant placement position. Other factors are related to patients. This is my case. I want to take a look at patient-related matters. Number 27, around the implant, there was gingival discomfort. Peri-implantitis was diagnosed, and around the implant, there was crystal bone loss, pus, and inflammation. When I took the image in number 26, distal area, there was a periodontal disease as well. And in treating this in number 27, in order to reduce inflammation, surgical approach was done, and distal Parker treatment was done. This is X-ray 2 years later and 8 years later. This follow-up is done for about 10 years. Number 27, there's no sign of inflammation, and number 26 is nicely maintained. In looking at this case around the implant, if the periodontitis around the adjacent natural tooth, it can affect the implant, and if periodontal disease is treated well, then peri-implantitis can also be treated. Let me share. Dr. Kim is going to share the next case.
So a patient that came to our hospital, 51-year-old female. So peri-implantitis was the chief complaint. As you can see, in the upper jaw, 6 implants were placed, and they are hopeless, and the patient had uncontrolled DM, so uncontrolled diabetes. And if that is understood, we would have a different approach. So we discussed about this case, and the systemic disease might be an important factor, and there's a prosthetic factor too. Dr. E? Yes, the patient has uncontrolled diabetes, but I don't think it is due to that disease. And uncontrolled DM can facilitate to accelerate the situation. So there's unstable prosthesis over the 6 implants.
And I'm sure you know this, one piece fit is very difficult to get. And I think this person also had difficulty. You can see margin, and you can see that it's been done roughly. The biggest problem is that oral hygiene in these areas would not have been good. And if you force it in, then tensile strength can occur on the implant, and negative stress can be caused on the bone, leading to bone loss.
The systemic disease with relation to peri-implantitis, according to some paper, DM can be a problem, but if it is under control, it would not be a problem. So I want to share this information, peri-implantitis with the DM. Hemoglobin A1C, if it is over 6.5, we diagnose diabetes, and if it is 8% or more, it's uncontrolled. So peri-implantitis can be affected by the uncontrolled DM, according to the recent paper. And one more thing, osteoporosis medication, as you saw in the morning, drug holiday to prevent MRONJ, we can use the drug holiday. But implants are also integrated, and after that, bisphosphonate denosumab, the drug can be used as steroid. More comorbidity exists. Then the osteonecrosis occurs similar to osteoporosis, similar to peri-implantitis. So the bone is destroyed and it progresses to OMJ, and the problem can occur. Peri-implantitis, it looks a little bit different on CT. So you need to check whether the patient is on osteoporosis medication. Okay, patient-related factor, existence of perio disease, and MRONJ should be checked as well. The second patient-related factor, before we talk about surgical factor, and we did a survey. This is the survey. As mentioned with the survey case, what do you think is the ideal placement depth for implants? So 1, 2, 3, 4, and 5. 1, 2, and 3. That's a bone level implant placement. 4 and 5 indicate the soft tissue level implant placement. The result, almost 40% of dentists believe 1 millimeter from crystal level is the depth that you use, and 30% implants are placed at 2 millimeters from tissue level, 2 millimeters from the tissue level, 20%, and bone level placement, and the 4 millimeters from tissue level, 8%. 0 millimeter from crystal level on 6.6%. So your answers to the survey and what we are thinking about that. Let's discuss about that. So the second factor, surgical factor in terms of implant position. Dr. Kim, why don't you talk about this? In the upper and lower posterior region, implants were placed, and at number 13, it was a resident case. GBR was used, and the cross-section, the implants looked in good position. If you look at periapical area, number 14 and 15, there's a difference in the platform in terms of the depth. So to get the primary stability, it was inevitable to place like that. Actually, there's a 2 to 3 millimeter difference, and the patient, after the delivery of prosthesis, the patient began to complain discomfort, and in terms of probing, there is some inflammation in the peri-implant mucositis. Minoden treatment is used initially for the peri-implant mucositis, and let's have a look at other cases of similar cases.
So this case was my case number 37. Around it, there was gingival swelling, and when I did inspection, the very deep pocket depths was observed, and upon the probing, there was suppuration and bleeding. I took X-ray and compared with adjacent tooth, the implant was placed very deep. And on top of the implant, the abutment was very long, and inflammatory response was mostly related to the abutment. In 2014, there was no bone loss around the implant, and around the implant, I thought it was a peri-implant mucositis. So non-surgical approach was taken, and subgingivally root planing was done, and antiseptics were provided, and a non-surgical approach was taken, and after pain relief pain reduction, the pain did not return. 8 years later, in 2022, in the anterior, the patient complained of gingival discomfort in the anterior region. When I looked at number 37, and the patient did not remember how it was treated. And when I took a look, when adjustment was done, abutment level adjustment was done, and it was made into a ponic. In 2022, around the implant, there was a bone loss, and the adjacent tooth was hopeless as well. When I looked at this case, so in the period pocket, inflammation can occur, and with repetition, alveolar bone loss can occur, and if implants are placed this deep, it could be problematic. If you look at the studies, BOP, period pockets can lead to more inflammation, deep period pockets, soft tissue level and bone level. If deep pockets can occur in such cases, and more so than bone level, or if the gingiva exists thick, then when you first deliver abutment, because there's nice soft tissue sealing, there's no probing, but if it becomes susceptible, the attachment can become reduced, and it can lead to deep period pockets. This is a different study, and if the probing depth increases by 1 millimeter, BOP increases by 1.8 folds. BOP, it is in relation to inflammation in terms of period health, and this is a very meaningful indicator. So in conclusion, if you place implants deeply, then there's higher possibility of deep probing, and it can lead to inflammations. In 2017, Periodontology World Workshop occurred, and there was consensus report that was produced. And in the sixth conclusion, evidence suggests the progressive crystal bone loss around implants in the absence of clinical signs of soft tissue inflammation is a rare event. Hence, if you place the implant deeply, it can lead to peri-implantitis. In that case, doesn't mean that we need to place the implant shallow. If you place implants shallow, these kind of problems can erupt. We can often see these kind of problems. Gingiva is very thin, and when implant is placed at bone level, in the case of this patient, final prosthesis, even before final prosthesis is delivered, gingival recession is done, and thread is exposed in number 22, and this can lead to many patient complaints. This is a very awkward situation. Soft tissue graft can be done to improve the situation. However, fundamentally, if we are to solve this issue, we have to position the implant, correct it.
If an implant is placed too deep or too shallow, there are problems. And regarding the implant depth, we need to consider prosthetic aspect. What do you think about that?
I work in prosthetic division and periodontologists, or maxillofacial surgeons. And I place the implants, and I deal with prosthesis, and there are varying implant placement depths. If very deep is bad and very shallow is bad. In the case of deep placement, there's not that the crown becomes very long, so it can be worrisome, but when it is placed very shallow, it becomes very difficult to provide prosthesis first. The occlusal plane is already defined within the patient's oral cavity. And if vertical depths of the implant becomes more shallow, then the crown's height space becomes reduced. Then if it is less than 6 millimeters, it will become cement type. At times, it can lead to cement screw type, and at times there can still be problems. Second problem related to shallow placement is shorten the vertical soft tissue dimension. I'm sure I'm going to mention it later, but in this case, biological width can be invaded, and prosthodontically, aesthetic contour is difficult to achieve. If you place the implant deep, aesthetic prosthesis can be possible. However, if it is placed shallow, the angle becomes wider, and you provide a brick-like implant prosthesis in the posterior region. Let me give you an example. This is my patient, and before providing prosthesis, the implant was placed shallow, and the soft tissue was close to zero on the buccal side, and on the mesial side there's about 1 millimeter. So if you look at the design, it's wide and like a brick. And in 2021, I provided this prosthesis, and 1 year later, there's already bone loss. The patient did not have inflammation, but because of bone remodeling, there was bone loss, and the soft tissue vertical dimension was reduced, and prosthesis design was unnatural, and this led to bone loss. As for this patient, in 2021, the patient came in like this. So oral hygiene was very good, but the patient went through scaling, but still there was continued odor and bleeding around the implant. So when I looked at this image, I needed to take the inflammation, and inflammation was observed. And below the prosthesis, there was very severe plaque and food impaction, and because the prosthesis design was blunt, there was food impaction at the time of placement. This is the panoramic image. At bone level, it does not look very shallow, especially in the case of number 47, it's deep, and 46 is equilevel, but from soft tissue perspective, I think the patient was very thin biotype. We should not just think about the crestal level, but we also need to consider implant placement depth, tissue level, and because the patient had prosthodontic problem, I provided contouring, and inflammation was reduced. However, the bone loss that already occurred could not be resolved. If number 46 was placed slightly deeper, then problem would have been avoided.
So for the final prosthesis, the contour and appearance needs to be considered. So how deep should it be placed for prosthesis? As mentioned before, if it is placed deep, inflammation can occur. So this is something we are struggling with. From the periodontal perspective, Dr. Chu, what's your comment?
So thinking about perio health, preventing pocket depths is very important, and it may be wise to place the implant shallow, but as Professor Lee has mentioned, in order to allow for appropriate contour and design of prosthesis, we need to consider appropriate amount of soft tissue thickness, and hence it needs to be sufficiently shallow, but at the same time it needs to be sufficiently deep. If you look at this case, in general, in number 26, 27, when we need to place implants, this is how many people place implants. When I first took a look at this patient, the patient said there was bleeding around gingival and felt uncomfortable. There was a very deep perio pocket, and there was a probing upon bleeding, and on x-ray in number 25 compared with number 25 platform, the implants in number 26 and 27 were placed deeply, and there was difference in platform as shown. The prosthesis cervical area was different, so unless the patient did thorough teeth brushing, I thought that in between number 26 and 27 thorough cleaning would be easy. Considering perio health, rather than placing implants this deep, ideally, we need to consider the adjacent implant and vertical position needs to be similar to adjacent implant for healthy perio conditions in order to avoid deep perio pockets. This is the study I've talked about earlier. These two factors are being continuously mentioned, and if there's deep perio pocket, BOP increases, and if BOP increases, if you place implants deeply, peri-implantitis can occur higher. There are higher risks. In terms of restorative margin, if the distance between the restorative margin and bone is short, then it becomes a higher risk. In other words, if the distance is limited, it has been placed shallow. Here it says that if you place implants shallow, then it can lead to peri-implantitis. So then you might wonder how we should place the implant, deep or shallow. I have talked about how perio pockets can cause problems. So I've emphasized that you should not place implants deeply for the sake of perio pockets, but from a different perspective, certain level of depth is important. And I'm sure you have heard of concept biologic width, and this is something that is taught at the very beginning, and 2.04 millimeters need to be secured. Biologic width, easily put. From alveolar crest, there needs to be 2.04 millimeters of gingival attachment in order to form physiologic barrier and cause less inflammation. And on top of alveolar bone, if you need to secure certain level of soft tissue attachment, or even around the implant, we need to secure biologic width as well. And this has been emphasized from a long time ago. There has been many human studies and animal studies. By peri-implantitis and peri-implanted gingival attachment, it needs to be more than 3 millimeters. Biological width around the implant. Let's think about the soft tissue that surrounds it. Clinically, then we would be able to get some more insights. Based on this research, 4 millimeter thickness was here, and there was a 2 millimeter thickness, and crystal bone level implant placement was done. And after 6 months since abutment connection, prognosis was observed in the area where there was a 4 millimeters. So there was a very little change in crystal bone level, and in the area where there was 2 millimeter thickness, a physiologic bone remodeling occurred, and about 4 millimeter of soft tissue was gained. Bone loss occurred to gain soft tissue thickness. Hence, clinically speaking, when we place implants, we need to think about the soft tissue thickness, and this is something that we need to take a note of. In patients with a thin biologic type, we need to form soft tissue space. More so than bone level, it is better to place the implants slightly deeper. Implant placement depth. In terms of reducing perio pocket, it is better to place implants deep. While considering biologic width, there needs to be about 3 to 3.5 millimeters of space. Thank you.
So periodontally, that much space would be required. What about the prosthetic consideration in determining the placement depth, Dr. E?
So placement depths, there can be minor differences from perspective. So I want to share with you a couple of cases where implants were placed shallow. Number 16 and 17 periodontally, the extraction was done because the condition was not good. The soft tissue vertical dimension was about 0 to 1 millimeters. This was placed in 2020, and I provided prosthesis August in the same year. And in the case of the shallow implant placement, biological width can be affected, and prosthodontic phase can be affected as well. I did my best in designing it, and I noticed a bone under resorption, and in 2022 this was changed to tissue level implant, and extraction was done because of inflammation. and the bone resorption occurred significantly. That shows how much biologic width is important. And the patient had a past history of periodontitis. In this case, then what should be done? There's very sound alveolar bone, and the extraction was done because of crown fracture, and in the posterior area, 2 implants were placed. The soft tissue vertical dimension was about 0 to 1 millimeters. In August 2020, and this is contour. This looks very good. This is image after 3 years. There has been a bit of bone loss. Periodontally, it was very sound, and aggressive bone loss did not occur. However, gradual bone loss does occur. The soft tissue thickness or biologic width, regardless of whether the periodontal condition, these continue to occur. As emphasized before, in determining placement depths rather than bone level, I think we need to consider the start from the tissue level, and we need to consider 3 to 4 millimeters of biologic width, and we need to create a condition for favorable prosthesis design. Ideal design. I'm sure the emergence angle should be, if the emergence angle is over 30 degrees, it can lead to peri-implantitis, so it needs to be less than that. Rather than a convex one, it needs to be concave in order to reduce the likelihood of peri-implantitis. At 30-degree emergence angle, let me give you an example. This is a study published last year. In the posterior molar area, if mesiodistal distance is about 10 millimeters, and if you use 4 millimeter diameter implant here, then the emergence angle, in order to get 30 degrees, how deep should we place it? And I used trigonometric function to get the number, and the height is 3.24. So 3.24 millimeters deep from the soft tissue level to get 30 degrees, and you need to place it deeper in order to get an angle that is smaller. The numbers are, a lot of numbers are here, and clinically my recommendation is this. So in order to take an impression, when I remove the prosthesis, this kind of look is what makes me happy. Healthy gingiva and about 4 millimeters of soft tissue vertical dimension. This is the best for providing prosthesis, and prognosis is also very good.
Prosthetically and surgically, we need to consider some factors, and we talked about the depth of placement. We are talking about the implant placement depth, apical-coronal position. Not only that, but we need to consider other factors. Dr. Chu, what's your take on this?
So not just inflammation, but there are patients with anesthetic outcomes. With patients with compromised aesthetics, in most cases, implants have been positioned labially. And platforms, when they are labially inclined, it can lead to alveolar bone resorption, and inflammatory responses can result, especially in the anterior zone. Patients with thin biotype, if you labially position it as shown here on the screen, serious results can come out, and the patients can complain about the results. Labiopalatal, and I think this is very basic. Mesiodistal position can also lead to problems. If you look at this patient, when the patient came in, the patient could not do teeth brushing, and there was significant odor, and it was very difficult to clean. The implant was very close to the adjacent tooth, and Non-surgical treatment was possible, but because of structural issue, we recommended removal of the implant. If you look at this case, this is the posterior region in the lower, and there's 3 unit implants on both sides. And when the patient first came in, the patient complained of gingival discomfort. In the case of the lower, I used on one side a non-surgical approach was used, and the situation improved. But on the other side, despite the same approach, there was continued odor and discomfort. So I looked at why there was such difference. Soft tissue-wise, on both sides, the gingiva was thin, tight, and there was insufficient keratinized tissue. However, vestibule space was sufficient, so I thought that it could be overcome. When I took a closer look in the case of lower, the implant-to-implant distance was significant. On prosthetic level, self-cleansing was possible, but on the other side, you can see that number 35 and 36 were placed too close to each other, and the top of the implant was vertical difference was observed, and embrasure space was not considered upon providing prosthesis. Mesiodistal positioning is something that we need to consider. This is something that is easily overlooked when we do implant placement. At times people make mistakes. This kind of structural issues cannot be overcome by periodontal issues.
So we looked at patient factors, surgical factors. So surgically, as you know, what we can say is that X-ray is a 2-dimensional image, but we look at 3-dimensional patients, and when we determine placement depth, we need to consider that. After surgery, prosthesis should be mounted, and what are the prosthetic-related factors, risks? Dr. Lee?
Let me share with you a case. In 2006, implant was placed in the lower, and in 2013, peri-implantitis occurred. Surgical treatment was done, and the problem did not resolve, and in 2017, the inflammatory response continued. I considered why this was, because the implant on one side was fine, but on the other side there were issues. And quadrant 4 was problematic. If you look at the perio condition, and the implants were placed on the other side in 1999. It was not patient factor, and it was not implant factor, so I thought that another factor played in. As you can see on this image, this is a 3-unit bridge, and the implant position was very awkward. It's 3-unit, and between teeth, the implants existed. The pontic area didn't look good, and it was very difficult to maintain oral hygiene. If guide was used, then this kind of results would not have come out. But as implants were placed where the bone was, prosthesis design came out like this. The person from prosthodontist perspective, I think this was the best that could be provided. And that's why inflammation continued. And prosthodontic adjustments can lead to drastically better results. The patient first came in 2015, and peri-implantitis occurred in 2020. I removed the prosthesis, and there's inflammation, and there was a lot of plaque. And I didn't do anything special. I washed it and cleaned it. And what I did was I did contouring of the prosthesis, and I made an embrasure space. If you compare here and here, the swollen tissue around the implant around 2023, it looks nicely maintained. The cause of peri-implantitis was because of prosthesis, and because of prosthodontic reasons was removed, the situations improved. Especially in the molar region, if there's 2 units, this kind of prosthesis can be fabricated very frequently. Stubble or UCLA type of screw prosthesis, these kind of designs were not that frequent. With the advent of custom abutment, this kind of designs arose, and it has very sharp angles. If you remove these kind of prosthesis, plaque is accumulated and there's inflammation. One of the problem is because the patient has bad oral hygiene, inflammation occurs. The second problem is on this side, compression occurs because of the fat prosthesis, and compression occurs on the soft tissue, and the biologic width is reduced and invaded, leading to bone loss. And we need to remove the risk factor. This was my patient, so I removed it. So this is removing the source of the problem is important, but what is more important is to prevent the problem from occurring. A dentist is not a delivery man who simply transfers the dental technician's work as is. This is the words of Professor Chorira, and this really touched my heart. And we do not just connect the lab technician's work, but we provide prosthesis in line with the patient's condition. Clinically, I do bonding intraorally, and I remove cement and do contouring and connect it. By doing this, peri-implanted disease, we can prevent it before it from occurring, and for the prognosis of the patient's implant, we need to do our best.
So we have looked at patient surgical and prosthetic factors of peri-implantitis. If we can control them before that happens, then we can work on them, but still peri-implantitis can still occur. How can we control that? And Dr. Chu, would you talk about how to treat it? Actually, peri-implantitis cases are more. There's inflammation, and we need to treat to reduce the inflammation. Non-surgical treatment can be used. The implant surface is a titanium, so around the implant, non-surgical treatment includes using titanium scalar or curette. So gingival, the infected surface is removed, and if there's contaminated surface, that should be removed. If pathological pocket remains, that will continue to create problem. Chlorhexidine can be used to disinfect, or minodin, or a local anti agent can be used. So in many cases, a non-surgical treatment can work, but when a patient comes to a hospital, the situation is serious. So non-surgical treatment would cause relapse. Then we need to use surgical treatment. The pocket reduction is the focus, using resective surgery. The contaminated implant surface needs to be decontaminated, and reconstructive surgery needs to be done. Not only the bone treatment, but gingival mucosal relation is not appropriate, and there's a lack of keratinized tissue. Then free soft tissue, free gingival treatment can be done. If surgical treatment doesn't work, there's structural problem, and if implant fails, that should be removed. So how do we need to treat the implant with the peri-implantitis? So the various treatment methods have been discussed. And Dr. Kim, would you introduce some cases of treatment? So I recovered the situation for implants like this. Implanted thread exposure was the problem. So non-surgical approach was done, and surgical treatment was done to reduce inflammation. And if that control works, the threads can be addressed using bone graft. The thread is exposed, and the osseointegrated portion is not large. And the chief complaint at number 14, titanium brush was used to clean the site, and drugs can be used for that. And if we are confident that there's no more inflammation, we can do the bone graft such as a GBR. And the patient wanted a restoration for the right posterior region. Empty distance was planned, and placement depth was adjusted considering soft tissue. And OneGuide system was used to recover the site in the upper posterior region. Number 16 and 17 were used as abutments, and there's a pontic to reduce the mobility of peri-implantitis. And the clinical photo shows the resolution of the exposed thread. So Dr. Kim, that was a very good case. Despite all such efforts, peri-implantitis treatment, the result of the treatment is not predictable, and we often have a relapse. So how do we educate our patients to prevent that? So first line, second line, and third line, the preventions are mentioned. Most importantly, implant position is very crucial. Despite that, peri-implantitis can occur, so the starting point should be brought under control. And if that was missed, then we can use the surgical approach. Clinically, as you know, despite all such efforts, sometimes we have to do explantation. Then how can we restore the case? Dr. Kim? For peri-implantitis, it is best if we can recover that, but in some serious cases, we need to remove the implants. It is called implant replacement at failed sites. So according to literature, the success rate would be lower. In the lower left posterior, the patient had a problem. After implant removal for replacement, there are many problems. First, a lack of a hard tissue. So if there is not much residual bone, primary stability cannot be achieved. And also, in terms of depth, they can be close to inferior alveolar nerve. And the lack of soft tissue can be a problem when the extraction is made. The gingiva can be a problem. So in accordance with the grand theme of this meeting, complications, this is relevant to that theme, to do implant replacement, guided surgery, and GBR for hard tissue problem, and soft tissue graft would be done when a flap was raised. Luckily, buccolingual dimension was okay. Within the bone housing, implants could be placed, and due to inflammation, when implants are lost, we need to be careful that the bone can be hard, and the bone graft was done to do the implant placement. When soft tissue is lacking, we can address the problem. Free gingiva graft can be done, but recently bovine collagen matrix can be used using the apically positioned flap. So in the lower right, you can see it's not sufficient, but to a certain degree, keratinized gingiva band was obtained. So in the implant replacement site, we need to consider this kind of prognosis before and after surgery. Next case, 3 implants in the upper anterior region. The patient didn't come, and the patient was lost to follow-up, and peri-implantitis occurred in the upper posterior region. There is another problem. So after implant removal, the CT showed the palatal and sinus floor bone level almost the same. That means alveolar bone is completely gone. The ridge is very narrow in the mandible, so it's very difficult to place implants anywhere. That's what I explained to the patient, but the patient insisted on having implant treatment. So we made a guide based on CT, and 4 implants would be placed. That's the plan. Bilateral sinus graft, and in order to widen the ridge, GBR would be performed. So digitally, the final prostheses were designed and implant positions were chosen. Most importantly, implant positions should be where bone is for primary stability. So 2 implants in the anterior and 2 in the posterior regions need to be placed at accurate angles to provide the prosthesis. Sinus graft area and GBR site turned out to be favorable for implant placement. So guided surgery was done, and 4 implants were placed in bone, and the primary stability was obtained. In the secondary surgery, healing abutments were connected. This is the final prosthesis panorama, 2-year follow-up. The patient didn't have any symptoms, and the implants are maintained. So when the patient came, this is initial and temporary prosthesis and the final prosthesis. And my coworker, the prosthodontist, did a great job, and the patient is followed up, and the patient is still satisfied. So at a site where implant is explanted due to peri-implantitis, you replace the implants in a perfect way. So when we use a guided surgery, treatment plan should be established accordingly. The surgery should be performed. What needs to be considered when you plan for the treatment?
So in planning stage, the most important is to make a guide properly and treatment plan. In implant-guided surgery, the difference with stent surgery is that we can define the placement depths. In the past, with surgical stent, you would define the tooth position. You would look at horizontal or buccolingual position, but by using guide, you can also get the vertical position as well as the horizontal-ish position. When you do design the CT data and artificial teeth alignment are merged. When you do implant placement, bone-driven implant guide is made. We place the implant where there is most bone, and placement diameter is adjusted. Bone-driven design is used, and this was emphasized continuously. Vertical position. We need to choose from soft tissue level. When you fabricate a guide, we need to define the depths from the soft tissue level, and we need to have correct scan data, and we need to merge it with CT data to appropriately understand the soft tissue level and define vertical depths. By doing this, we can get aesthetic and long-term aesthetic prosthesis with long-term good prognosis. When you do treatment planning, when you design a guide, we need to do soft tissue-driven guide design.
What do we need to consider for surgery, Dr. Kim? When we place implants in our hospital, we use OneGuide system, guided surgery. Lower right posterior region, and I use the guided surgery for the implants, and the depth was proper considering the distance to the nerve. After the surgery, the patient came back 1 month later. If you look at the lower right, there's a bone loss, and the fistula is observed. So I determined that there was some problem initially. According to papers, guided surgery is discussed. The implants were placed in the site. Previously, the implants were there. During the implant placement, some pressures were applied, so we decided to remove the implants, and using guided surgery, the implants were positioned in new positions. So through this case, the surgeons' the feeling should be respected. Guided surgery, heat and irrigation problem. During the live surgery, we saw that. Dr. Son, the pumping and pumping out continuously. So that is related to irrigation and heat generation. Usually when we do guided surgery, flapless approach is used basically. But other than that, when we perform surgery, do we need to raise a flap or not? So from periodontal perspective, Dr. Chu, what do you think?
Multiple implants are had by many patients. If there are multiple implants and if prostheses are splinted, at times there can be peri-implantitis. The patient will be uncomfortable, and from dentist perspective, this is quite a difficult case. As for these patients, in most cases, self-cleansing is not possible with these prostheses, and around that, there's no keratinized tissue, and there's a lack of vestibule in most cases. If you look at this image, by no keratinized tissue, it's similar to the situation. In the case of this patient, buccal mucosa was attached to there was no keratinized tissue, and there was no vestibule to allow toothbrush to go in. In this case, teeth brushing cannot be done properly, and around the implant, peri-implantitis can progress. Abutment level, hard soft tissue sealing prevents crystal bone loss, and soft tissue sealing is very important. In terms of that, keratinized tissue is a very important barrier. If there is no keratinized tissue as shown here in the beginning, it looks as if it's attached, but with continued use of the patient, if the patient cannot do plug control, or depending on the patient's systemic condition, there can be deep pockets and it can lead to peri-implantitis. Hence, when we do all surgeries, we need to preserve keratinized tissue, and this kind of surgical design is essential. If there is sufficient keratinized tissue and the vestibule, guide surgery can be done and flapless surgery can be done. This is a non-invasive treatment, so I think it's a good idea. However, at times, so we need to use a tissue punch after we do. The vestibule space may be lacking because of tissue punch. In that case, rather than doing a flapless, I think it is better to do open flap and do guided surgery.
So the width of keratinized tissue should be considered for guided surgery. So we talked about the various considerations, and Dr. Kim, would you introduce the case and summarize? Yes, we talked about the depth problem or soft tissue and the distance and the guided surgery related problems. So using this case, let me summarize. In the lower arch, due to various problems, the upper bilateral posterior restoration is required. So all these areas are planned for implant restoration. The ridge width was not that bad, so this is a very good case for a guided system. The upper posterior region, sinus graft is required, but sinus grafting and OneGuide system placement can be made in the lower arch. The width is okay, so GBR doesn't have to be done. If you look at the cardiac plane, compared to lingual bone, there's some depth and soft tissue dimension. So you can calculate it to be 4 to 5 millimeters in various tooth positions. A guided surgery was planned in the left and right, and after treatment was completed in a 5-year follow-up, you can see very good results. The abutment angles and mucosa part. I believe with this we will not have a peri-implantitis. So guided surgery, how that's applied in a surgical case was introduced. So if we close, this is a survey question. Peri-implantitis causes. So that was the survey question. Implant placement position is very important. If that is improper, to compensate for that, the poor prosthetic construction can be made. So that creates various problems, such as peri-implantitis leading to implant failure. So that is the cause and result. For ideal implant placement, we need to plan positions in advance. A guided surgery would be better compared to freehand surgery. And when you establish a treatment plan, soft tissue-driven surgical template should be fabricated. Lastly, there's no literature evidence, but we need to do reimplantation of challenging case due to peri-implantitis, and we need to be very careful and control the situation. this is the conclusion, and this closes the discussion session. And let's open up Q&A. If you have any questions, please raise your hand. I'm Dr. Song. I have practiced. Thank you for good presentations. So apologies, I am citing just one case. Dr. Kim, you did it all on 4 on the maxilla. All on 4, I don't think it really works. All on 4, especially on maxilla, because of the load, shortened arch. The shortened arch. Usually we place implant up to number 6, but you use number 7. I don't think that implants will last. And if you look at 2-year follow-up, crystal bone loss was observed. All 4 implants have crystal bone loss, and I don't think the implants can withstand the load for a long time. So do you believe the case will have a good survival? Yes, thank you for the good question. As you said, I have the same idea. The patient, after bone grafting, there was a problem of narrow ridge and crystal bone loss can be compensated by some depth of placement. So, but we couldn't place implants deeply. Regardless of the depth, due to the load, when you use overdenture in the maxilla, bone loss will occur. I believe that's a typical case. IARP should be the approach. I don't think a fixed approach would be working. Yes, you're right. So at this point, I don't do prosthetic work myself, but I do consult with them. So when an implant fails, I did broad range bone grafting just in case. So the problem may occur, but in this given situation, we devised some mechanism to respond to any problems in the future. Okay, all on 4, I believe, is not appropriate for maxilla. That I'm not an expert for that, but Dr. E, do you have any idea? I made a presentation on a similar case 3 years ago, and Dr. Song scolded me as well at that time. The patient is followed up continuously, and I believe all on 4 is not good because bone loss occurs. And another patient had all on 4, and the patient complained they felt very heavy. It was resin cemented, but it fell off. I don't know whether this answers your question, but any other question? So let me
of my interest. So thank you for a wonderful lecture. Professor Chu, you have talked about how in the lower anterior there was an implant in number 1, and in number 2 there was a very severe periodontal destruction. Do you think that was the cause by implantitis? Considering the gingival condition, the endodontic tooth, I think because period condition was bad, destruction occurred. because perio condition was not good. Occlusion could have been bad, and this could lead to food impaction. What's your thought on that? Thank you for the wonderful question. And peri-implantitis, if it occurs, the cause analysis can be various. In the case of this patient, the implant was placed in a different division and periodontal discomfort occurred. So the patient was referred to me. I looked at the chart and I looked at how I looked at the images when implants were placed. The adjacent teeth before the implant looked okay. However, after implant placement, and even with that, it was okay for a certain time, but with a prosthesis delivery, crystal bone loss progressed. Mesiodistal distance was too limited, and interdental brush could not go in and implant to natural tooth distance. If it is so limited, the blood supply can be affected, leading to bone loss. As for this case, adjacent tooth was intact originally, so I think the distance with the implant has led to peri-implantitis. Through chart review, I was able to confirm this in other cases. As you have mentioned, there was a tooth. If there is a periodontitis around the implant, it can affect the implant. Yes, I agree.
The cause of peri-implantitis, as you know, there's not just the one cause, but eventually it is related to plaque. So I believe a plaque is definitely associated with it. So the question is whether plaque control was possible or not. Is that the right interpretation of your question? So the speaker should use the microphone so that interpreters can hear. If tooth was intact and if it went down due to peri-implantitis, actually the gum should not go down because PDL is still vital. The natural tooth gum was much lower. That means the PDL was destroyed. So at that time, the diagnosis is that the natural tooth had the cause of the problem. So if we go deeper periodontally, natural tooth, the distance with in case of the natural tooth, the minimal distance is 1 millimeter, but in this case, plaque is related. Plaque started, and that caused the bone loss. And I need to be careful in saying this. The self-limited width is 1 millimeter. And we looked at the phenomenon of that situation. As Dr. Chu said, this is a matter of egg first or chicken first. And I know what you mean, but it is hard to answer. But we will study a little further on that topic to find the answer for your question. Any other questions? So in the online chat, I found an interesting question. So let's look at that. It's not here. I'm looking at the real-time question. In thin biotype, the implant could not be placed deep because of the mandibular canal. I am thinking about the wide implant with the platform switching. So how can we secure horizontal space when vertical space cannot be secured? So biologic width cannot be secured because low remaining bone. Then can we increase the width using platform switching to secure biologic width? What do you think? I think that is the question. Dr. Chu, do you have any answer for that?
It's a very good strategy, I think. As for the lower, there's a mandibular nerve, so you cannot go in sufficiently deep. There's a limitation. However, in the morning lecture, or I think I saw a similar content, if the soft tissue thickness is too thin, in order to place the long implant, rather than placing it equicrestal, but by reducing 1 to 2 millimeter, I think in the case of thin biotype, I think it is better to place the implant subcrestally to get the good results long term. In that case, we have to opt for short implant. In that case, but we need to also consider the mechanical factors. If the alveolar bone allows it, we need to use a wider implant and to get the better soft tissue sealing. I think it's a very good option to do platform switching.
So I hope this answers the online question. So that can be a strategy to utilize. So online questions. There are some awkward questions as well. Anyway, let's conclude the Q&A session. Thank you very much. So this concludes the session. Thank you.
Thank you, Professor Chu Ji-young, Professor Kim Jun-young, Professor Lee Yu-seung once again. I would also like to thank Professor Yang Seung-min for leading this session. This is about lecture satisfaction survey. Now I would like to conduct a lecture satisfaction survey to gather your feedback on the passionate presentations by our speakers. All offline participants will receive a text message with the survey link. After clicking the link in the text message, completing simple survey, 200 participants will receive a chicken gifticon.
Let's get started with the poster award ceremony. Until August, we received 171 posters, a lot of interest. The winners are chosen after careful evaluation and discussion by 26 judges, 5 from university sector, 5 from private sector. A total of 10 were selected. Awards will be presented by Chairman Kyok-chae. Please welcome him with a big round of applause. First, the 2024 University Sector Osstem meeting poster gold award, and the winners will receive 1 million won and a certificate of merit. 3 will be called out in the order of Korean alphabet. Winners, please come onto the stage. Dr. Yoon Chang-ho, Chosun Dental School, and Dr. Chun P-won from Chosun University School of Dentistry. A poster gold award, Dr. Cha, you have presented excellent research with superb passion for dentistry and are chosen as a gold award winner in the 2024 Osstem meeting Seoul. On behalf of Chairman Joo-Hyuk Bang, Osstem Implant, I read the Certificate of Merit. Resident Chang Ho-yoon, Chosun University School of Dentistry. The contents is the same. The gold award, Chun Hee-won, the resident of Chosun University School of Dentistry. So we will take photos of the winners. Please come to the center of the stage. Congratulations to the Gold Award winners. The winners are asked to step down the stage. Next, 2024 Osstem Meeting University Sector Excellent posters. The winners will get clinical research agreement in 1.5 billion won. Names will be called out, and please come onto the stage. Professor Lee Jung-tae of Seoul National University School of Dentistry, congratulations. Excellence Poster Award, Dr. Lee Jung-tae, Seoul National University School of Dentistry. You have presented excellent research result with a super passion for dentistry and are chosen as an excellent poster award winner in the 2024 Osstem Meeting Seoul by Chairman Joo-Hyuk Bang of Osstem Implant. Congratulations. Let's take a photo. Congratulations. Next, the Green Award in the University Sector 2024 Osstem Meeting Poster Session Green Award. The winner will receive a clinical research agreement in 2 million won. Who is the lucky one? Resident Choi Sung-ah, Hallym University resident, School of Dentistry. Please give a big round of applause to Choi Sung-ah of the winner of the excellent grand poster winner. You have presented excellent research result with a super passion for dentistry and are chosen as the Grand Award winner in the 2024 Osstem Meeting Seoul. And commemorative photo taking. Poster Grand Award winner. Let's hear from her how she feels. It is my honor to be given this award, and I would like to thank my Dr. Yang and Dr. Park for kind advice. And from planning stage, R&D Center has helped me, and I would like to express my deepest gratitude to them. Please give her another round of big applause. So this has been 2024 Excellent Poster Award Ceremony for the University Sector. Congratulations to the winners. Next, 2024 Osstem Awards in the Practice Sector. Chairman Joo-Hyuk Bang is to present the award. The winners will receive 1 million won, and the certificate of merit. The names will be called out in the order of a Korean alphabet. Dr. Lee Jong-Hyuk and Dr. Oh Chang-wook on Smile Dental Clinic. Please, two winners come to the stage. To Dr. Lee Jong-hyuk, you have presented excellent clinical case with a superb passion for dentistry and are chosen as a Gold Award winner in the 2024 Osstem meeting Seoul. Congratulations. I'm Dr. Oh Chang-woo of Smile Dental Clinic, the Gold Award winner. Congratulations. The photo taking. Please come to the center of the stage. Our Gold Award winners, congratulations. Next, the 2024 Osstem meeting, the Excellence Gold Award in the practice sector. Winners will get 1.5 million won and certificate of merit. Winners will be named in the alphabetical order as to come onto the stage. Dr. An, Dr. Kim, and Kim Bo-yoon is not present here, so we are going to convey the money and certificate later. Dr. An Joo-hyun of Jeju Grand Clinic, you have presented excellent research result with a super passion for dentistry and are chosen as an excellent award winner in the 2024 Osstem meeting Seoul. Kyuk Che, chairman of Osstem Implant, please give him a big round of applause. Next, the photo taking. Next, 2024 Osstem meeting Grand Award for the poster presented today in the practice sector. The winner will get 2 million won and certificate of merit. The winner is Dr. Lee Sang-min of Yeonhee Plaza Dental Clinic. Please come on to the stage. Poster Grand Award, Dr. Lee Sang-min of Yeonhee Plaza Dental Clinic. You have presented an excellent clinical case with a superb passion for dentistry and are chosen as a Grand Award winner in the 2024 Osstem meeting Seoul. Kyuk Che, chairman of Osstem Implant. Congratulations again. Photo taking. Let's hear from the winner how he feels. Chairman Kyuk Che is kindly asked to step down from the stage. Thank you. This is beyond what I expected, and I listened to the session case, and my case was not on top of all, but I am given this good award, and thank you very much. And I would like to thank Dr. Park for guiding me all the time. Congratulations again. So this concludes 2024 Osstem meeting. Excellent post award ceremony. Congratulations to all the winners. Next, the contribution awards will be given, followed by offline lucky draw. First, contribution awards. The winners of previous contribution award are 2023 Dr. Joo-Hyuk Professor Chung Chang-mo in 2014, Professor Kwon Jong-jin, Dr. Jo Kyu-sung 2015, 2016 Dr. Lee Kwang-hoon, 2017 Professor Cho In-ho, 2018 Professor Kim Myung-rae and Dr. Oh Young-hak, 2020 Dr. Kim Ki-sung, 2022 Professor Kim Young-gyun and Professor Lee Jong-yup, 2023 Professor Oh Hee-gyun and Dr. Kim Jun-woo. 2024 second half contribution awards will be presented by Chairman Kyok Che again. Please welcome him again. So the contribution award winner is Professor Yoon Kyu-ho. Professor Yoon, please come onto the stage. So please give him a big hand. Dr. Kyu-ho Yoon graduated from Yonsei University Dental School, obtained a PhD in medicine from Inje University, internship in the dental hospital in Inje University, Busan-baek Hospital, assistant professor in dental hospital, Hanim University, Busan-baek Hospital, professor in Inje University, Sangye-baek Hospital, currently clinical professor at the Department of Oral Maxillary Facial Surgery in Chungang University, Gwangmyeong Hospital. He has greatly contributed to the advancement of Osstem implant and dentistry. And 10,000 won will be offered to Professor Yoon. Congratulations. I'd like to ask Chairman Kyok Che to kindly step down the stage, and I would like to ask Professor Yoon to give us a word. So my name is Kyu-ho Yoon. I retired 4 years ago, and I began to reduce work, and I wanted to stay quiet, but now I am given this wonderful award, and I need to be active again. Awesome, Chairman. Thank you very much. I wish your prosperity in business. Congratulations again. Continuing from yesterday, today we have held Osstem Dental Staff Forum, Osstem Meeting 2024 Seoul. With the support and expectations from many, we are running to the successful closure of the meeting. We all must wish to stay longer, right? You don't want to leave, right?
온라인 이벤트 진행 후 오프라인 이벤트도 진행되니까 끝까지 함께 해주시면 감사하겠습니다. 5분께는 표랑이 인형 세트 2세트를, 3분께는 와픽 구강 세정기 2종을, 1분께는 다이슨 V12 청소기를 아낌없이 준비했습니다. 이번 경품 추첨은 로터리 방식으로 진행되는데요. 휴대폰 번호 뒷 4자리가 2875인 분들이 많은 관계로 저희가 부득이하게 추첨은 휴대폰 번호 중간 자리부터 총 5개의 번호가 추첨됩니다. 만일 당첨된 5개의 번호가 중복일 경우 자동으로 숫자 1개가 더 뽑히게 되는 점 미리 참고하시면 좋을 것 같습니다. 자, 그러면 3등부터 한 분씩 추첨을 시작하도록 하겠습니다. 네, 표랑이 인형 세트를 받아보실 3등의 주인공 숫자 5, 7 나왔고요. 다시 한번 5가 나왔습니다. 마지막 숫자 6, 57756 김별나님 축하드립니다. 두 분 더 남았습니다. 아쉬워하시기엔 너무 이릅니다. 3, 1, 0 그리고 숫자 6 31063 홍별표님 축하드립니다. 마지막 한 분 숫자 9 오, 같은 숫자가 많이 나오네요. 8 오 4 99884님 김별배님 3등 축하드립니다. 이어서 2등 바로 진행되고 있습니다. 3등 5분이시군요. 75848님 박별수님 축하드립니다. 마지막 한 분 표랑이 인형 세트를 받아오실 분 4 1 0 3 마지막 번호 41034님 축하드립니다. 2등 진행하겠습니다. 와픽 2종 받아보실 분 진행되고 있고요. 3분을 저희가 뽑겠습니다. 50632 이별선님 축하드립니다. 3190 마지막 번호 31903 정별용님 마지막 한 분 제가 옆쪽에 있다 보니까 1인지 7인지 잘 구분이 안 돼요. 47222 이별정님 2등 축하드립니다. 마지막 1등 다이슨 V12 이것만 있으면 사실 청소 잘 되지 않나요? 숫자 계속 넘어가고 있습니다. 6, 8, 9, 4 마지막 3 68943 김별옥님 다이슨 V12 1등 축하드립니다. 네, 이상 행운의 주인공들 모두 축하드리고요. 당첨자분들께는 저희가 개별 메시지로 안내해 드리도록 하겠습니다. 네, 여러분 어떠셨나요? 9월 7일, 9월 8일 양일간 진행된 오스템 치과 스텝 포럼과 오스템 미팅 2024 서울. 치과계를 이끌고 계신 국내외 연자분들의 훌륭한 강연과 라이브 서저리를 통해 많은 분들이 뜻깊고 유익한 시간이 되셨으리라 믿어 의심치 않습니다. 이 자리를 빛내주신 좌장민 연자분들 그리고 끝까지 시청해주신 분들께 감사의 말씀드리면서 이 시간 마무리하겠습니다. 감사합니다.